Hi everyone. Am I audible and visible? If I'm audible and visible, can I see a quick thumbs up on the live chat, please? Hi everyone. Oh, I can hear. Yes. So, welcome to Biochem LRR Reignite session. This is for INI-CET aspirants. I know whenever there is an LRR session for a specific exam, questions get asked. If this would be suitable for other exams as well. Let me give you an answer straight away. Yes, this can be attended by anybody who's appearing for the upcoming NEET PG or INI-CET or FMG exam, because it's all about covering the entire biochemistry using previous year questions. Okay, so what I planned for, good afternoon everybody, good to see all of you. So the plan for today is to cover the entire biochemistry, and this session has been divided into 5 parts. Part 1 is all about estimation and tests. So usually we start with carbohydrates, lipids, proteins, and by the time we reach genetics, all of us are tired. And then many a times we skip estimation and tests. So I thought I should change the sequence this time. Let's start with estimation and tests first, and then let's discuss about genetics, because we know genetic is a very high yielding topic as far as INI-CET is concerned. So let's discuss genetics in the early part of the session, and then clinical biochemistry, followed by carbohydrate metabolism and other concepts, right? I hope this works for all of you. So this is the agenda, and if you're all stressed about the fact that there is not even 1 month before the exam, please don't worry. It's never too late, right? It's never too late. For example, let me start with my experience when I was appearing for my AIMS exam. At that point in time, it was not INI-CET, it was called as AIMS exam. So I was preparing seriously for AIMS. And then around 1 month before the exam, my flight tickets were booked because I am in Chennai and the exam happens, at that point in time, it happened only in Delhi. So my tickets got booked. I was being a part of booking the ticket, and probably it was in my memory. When I slept in my dream, the dream was about my flight getting crashed. Okay. So as if all my dreams would come true, the very next morning I woke up with a panic, and that panic got spread into my exam preparation. I forgot about my exam preparation totally. I acted as if I'm going to definitely be a part of a flight crash. Okay. So my focus got shifted from there, and then I started discussing with my husband, saying you should not get married if something happens to me. And then I told my mom that you should take care of my daughter. So I started planning for all of that instead of planning for the exam. So if you're attending this session, it means you're much ahead of students like me, right? So it's not just me, right? There are many who get distracted this way. And if you're attending the session, it means you're not distracted. You're attending the session because you know your focus is on the upcoming INI-CET exams. You're well ahead of many of the students around. Okay, so don't get demotivated if you don't remember any of the facts that we are discussing now. If you don't know any of the concepts that we are discussing now, I want all of you to be motivated. Please remember, it's never too late. You can revise all 19 subjects even if you start today. Okay, so with that, how much duration? Probably it'll be for 4 hours. I'll try to finish it off in 3 hours, but maximum 4 hours. Okay, yeah. So this is the agenda, and let's start the session today. Let's start with estimation and tests. I'm going to start with, 1 second. I'm going to start with types of blood collection tubes. 1 second. I'm not able to see the live chat. Give me a second. Now I can. I'm good. I'm happy to see that for many of you, biochemistry is now a favorite subject. So let's start with types of blood collection tubes. Okay. So this is the first type because it's the most common tube that is used. Red cap, because there have been many questions on blood collection tubes in terms of what is a tube that is used for what purpose, and in terms of sequence of sample collection. Okay, order of draw. So this is a red top tube. As you all remember, the mnemonic that you should remember for a red top tube is RSS. right? You were anxious, no point in being anxious. Be happy, be relaxed, just focus today's session, focus on today's session. Okay, so the mnemonic for a red top tube is RSS. What does R stand for? R stands for the color red. S stands for the additive. The additive that is added in a red top tube is silica. And the next S stands for serum. So when will you collect a blood sample in a red top tube? Whenever you want serum sample. What is serum? After clotting, what separates above is called as serum. So for clotting to be facilitated, you need a clot activator. So tell me, what is a clot activator that you add in a red top tube? The clot activator is silica. And what do you use is red top tube for? The red top tube is used for all biochemical analysis. What do you mean by biochemical analysis? Be it for renal function test, right? Renal function test includes urea, creatinine. For electrolyte estimation, right? Not just this, for any hormone estimation, liver function test, right? Cardiac function test. So for anything that is being estimated in the biochemistry lab, I don't want chemical interference from an anticoagulant. So I want only a serum sample. The clot activator that is added is silica. The mnemonic that you should remember for a red top tube is RSS, red, silica and serum. Okay. The next one is gray. Have you all seen a gray top tube? I've always told you gray is G, G for G. So gray top tube is used for glucose estimation. And what is the additive that is used in a gray top tube? It is a combination of sodium fluoride and potassium oxalate. Please remember, it's a combination of sodium fluoride and potassium oxalate. I've also told you the purpose. The purpose is fluoride inhibits enolase. The reason is fluoride inhibits enolase of RBCs, so that RBCs glycolysis is suppressed. RBCs do not use glucose anymore after sample collection. If you allow RBCs to use glucose, after some time, the estimated glucose will be a low value. It will be a false low value. To avoid that, you are adding sodium fluoride, which inhibits enolase of RBCs. What is the other application for a gray top tube? It is not only for glucose estimation, it is also used for lactate estimation. Why for lactate estimation? If you allow glycolysis to happen in this tube, then RBCs start releasing lactate. After some time, when you estimate lactate level in this tube, that the value is going to be falsely high. To avoid that, you are adding fluoride into this tube. So fluoride is used for glucose estimation, for lactate estimation. The same is also used for alcohol estimation, right? Blood alcohol estimation. If there is no fluoride, the microorganism that is in the tube will start utilizing glucose in the sample, releasing alcohol, causing false high value. To avoid that, for blood alcohol estimation, this is not about the breath analyzer that we are discussing here. It's about blood alcohol estimation. Collect blood sample in a gray top tube. So all of you repeat it along with me. Gray top tube is used for glucose estimation, lactate estimation and alcohol estimation. But if they ask you which is the ideal substance that is used for blood alcohol estimation, the ideal substance is sodium fluoride and potassium dichromate. Yeah, what is the ideal substance used for blood alcohol estimation? Sodium fluoride and potassium dichromate. What is the purpose? Fluoride inhibits glycolysis in microorganisms. Potassium dichromate is a bacteriostatic. It is a bacteriostatic agent, so that these microorganisms do not release alcohol. Okay, that's the ideal substance for alcohol estimation. Okay, what is the next color? Is this session full enough for INI-CET? This is a session that will help you to revise all facts for INI-CET. Okay, so after you attend this session, my recommendation is to go and watch the rapid revision videos of biochemistry if you have not watched this till now. So put together LRR on YouTube and rapid revision on PrepLadder version 11, right? If you put together these two, then it's much more than what is necessary for INI-CET. I hope I've answered this question. Yeah. So that's about gray top tube. So tell me, what color is it? It's a lavender top tube. So lavender top tube is K2-EDTA or K3-EDTA. What does it have? K2-EDTA or K3-EDTA is present in a lavender top tube. What do you use a blood sample that is collected in a lavender topped tube for? This is used for complete blood count. Just remember, lavender tube is sent to pathology. What do we estimate in pathology? Complete blood count. It is not only used for complete blood count, it is also used for HbA1c estimation. Logical, right? If you don't use a lavender top tube, if you are going to use a simple red top tube that is sent to biochemistry for complete blood count, what would have happened? The clot activator would have allowed the clot to get stabilized. Within the clot, all cells get trapped. When cells get trapped, will you be able to count those cells in the supernatant? You cannot, right? That is why you collect blood sample in a tube with an anticoagulant, which is K2-EDTA or K3-EDTA. After which, just before analysis, you mix the tube. The whole blood sample is introduced into the analyzer. That will give you the RBC count, WBC count, reticulocyte count, whatever count you want. Okay, and why they use the same for HbA1c estimation? Because it is glycated hemoglobin. For you to estimate glycated hemoglobin, RBC should be intact. RBC should not be trapped in the clot. So you need to add an anticoagulant. So for HbA1c, it's a lavender top tube. And the same lavender top tube is also used for labile parameters like parathormone and ACTH. Good, Mahen, I don't know how to read your name, but good, I see that some of you are answering it right. So all of you tell me, it is also used for labile parameters like parathormone and ACTH, right? Otherwise, what happens? Parathormone and ACTH are very labile, meaning after sample collection, proteases in the sample can degrade parathormone, can degrade ACTH, causing false low values. But if you collect it along with EDTA, EDTA chelates calcium. Without calcium, proteases are inhibited. So labile parameters get protected. So all of you repeat this. Lavender top tube is used for complete blood count in pathology. In biochemistry, it is used for HbA1c estimation, parathormone, ACTH and ammonia. Okay, that's about lavender top tube. And then about blue. Have you all seen a blue top tube, right? Blue top tube has got what as an additive? It has got 3.2% sodium citrate. Please remember the percentage. Blue top tube has got 3.2% sodium citrate. C for C, it is used for coagulation assays. What do you mean by coagulation assays? Prothrombin time, activated partial thromboplastin time, fibrinogen assays, factor assays. So for all these purposes, we are going to use a blue top tube which has got 3.2% sodium citrate. But why did I specify that it has to be 3.2% sodium citrate? Because 3.8% sodium citrate is used for ESR. Right, 3.8% sodium citrate is used for ESR estimation, and this is the black top tube. Okay, so that is about blue and black. Now about green, right? So what does the green top tube have? Green top tube has got sodium heparin or lithium heparin. There is no difference in color coding for both sodium heparin and lithium heparin. I see multiple charts available online which give you wrong information. Okay, green top has got either sodium heparin or lithium heparin. And what do we use this heparinized tube for? I'm not going to wait for you to give an answer, because if I wait for you to give an answer, you would say this is used for ABG analysis. Answer is wrong. Okay, for ABG, you're supposed to use a heparinized syringe. I'm sure all of you have done ABG estimation, for which you have all collected blood sample in a syringe, right? Which is pre-heparinized. This is not a syringe, this is a tube, right? So heparinized tube is not used for ABG. This is used for stat biochemical analysis. What do you mean by stat biochemical analysis? Whenever a quick analysis has to be done, for example, estimating troponin, trop-T assays, right? There is a narrow window period within which the person should be able to react to it. In which case, if I collect it in a red top tube, just because I said for biochemistry, it's a red top tube. If I collect it in a red top tube, I'll have to wait for the clot to get established. That takes a good 1 hour. I don't have that luxury to wait, right? In that case, I collect that sample in a green top tube. In a green top tube, as soon as the sample is received in the laboratory, I centrifuge it, I analyze it. So for stat biochemical analysis, for example, troponin estimation, or in a critically ill patient, if I want electrolytes to be estimated, I collect it in a green top tube. Or if it's an intraoperative PTH estimation, during parathyroidectomy, the surgeon waits for the parathormone levels to be released, the result to be released before they close the suture. Before they suture it. Okay, so in that case, I cannot be waiting for the clot to get established. So whenever the turnaround time has to be short, shorter, you collect it in a green top tube, which has got heparin. Similarly, whenever you want DNA to be extracted or RNA to be extracted, for molecular diagnostics or for cytogenetics, whenever DNA or RNA needs to be extracted, you will have to collect it in a green topped tube. So tell me, what is the use of green top tube? Green top tube is for stat biochemical analysis, and it is also used for DNA and RNA extraction. Okay. The last one. Okay. So what color cap do you see? Yellow cap. And in lab standards, okay, we call it as a gold top. It is yellow or gold top. What do you see at the bottom here? You see a gel at the bottom. So what tube is it? It is a gel and clot activated tube, right? What is it? It's a gel and clot activated tube, meaning at the bottom of the tube there is a gel and there is a clot activator that is sprayed. Okay, why and when do I use this tube? So when I collect sample in a gel top tube, can you see this? When I collect blood sample in a gel tube, the sample is present above the gel. But when I centrifuge, because of the differences in the sedimentation coefficient, the gel ascends up. Can you see that now the gel has ascended up and it acts like a mechanical barrier between cells at the bottom and serum on the top. So what is the use of this gel? The gel acts like a mechanical barrier between cells in the bottom and serum on the top, so that anything which happens in the cell layer does not affect the serum. So when do I use this tube? Whenever I have to transport the sample for a prolonged period of time, or whenever I have to store the sample for a prolonged period of time, I will have to collect it in a gel tube. Okay, so that in due course, even when there is lysis of RBCs, it does not contaminate the supernatant. Do you all understand this? So when will I use an yellow or a gold top tube? Whenever the sample has to be transported or whenever the sample has to be stored for a prolonged period of time. Got it? So let me give you an example. How am I going to use all these tubes? Suppose there is a patient, person A, okay, aged 52 year, okay, 52 year old male, person A has come, and the investigations, right, investigations that are prescribed for this individual include fasting glucose, postprandial glucose, it includes HbA1c, complete blood count, parathormone. This person has to be monitored with tumor markers, okay. Suppose a person wants to estimate AFP, HCG, CA125, right? All these tumor markers are also asked for this patient, okay? In that case, what will I do? Electrolytes are also included. There is no emergency here. So when there is no emergency here, I don't have to use a green top tube. But what will I use for collecting blood sample for fasting glucose? For both fasting glucose and postprandial glucose, it's a gray topped tube. So I would collect blood sample in a gray top tube for this individual. I would also collect blood sample in a lavender top tube because I have to estimate complete blood count. I have to estimate HbA1c. I'll have to collect it in a lavender top tube for parathormone as well. And for the same individual, I would also collect in a gold top tube, because I have to estimate AFP, HCG, CA125, which are all not done in my lab. I'll have to send the sample to a reference lab wherein all these tumor markers are estimated. And this reference lab is like 6 hours away from my lab. I'm not going to collect in a red top tube, send it here in a red top tube, because in that case the lysis would happen and it would contaminate the supernatant. In that case, I will be dependent on a gel tube. Do you understand this? So this is about how I choose blood collection tubes. So can't it get stat result like green top tube? Yes, stat result can be obtained in a lavender top tube. But if you want a stat report for electrolytes, don't collect it in a lavender top tube. Do you understand this? If I'm collecting blood sample in a lavender top tube, okay, and I'm saying I want immediate results for electrolytes, what will happen to sodium? What will happen to potassium? What will happen to calcium? Yeah, it's a sodium K2, it's a K2 EDTA, K3 EDTA. So what will happen to potassium? Falsely elevated. What will happen to calcium? It would have chelated calcium. Calcium levels will be falsely low. Do you get it? And that is why it is always better for you to collect it in a heparinized tube. Heparin does not interfere with any biochemical analysis. Do you understand what I'm saying here? Palash, that's a good question, but the answer is this. Okay. Now about order of draw. So before we go to order of draw, a quick revision. All of you please start answering. Tell me, what is this red top tube used for? Red top tube has got what as an anticoagulant? Silica as a, it's not an anticoagulant. What is an additive that is in a red top tube? It is silica. It is used whenever serum is required. It is used for biochemical analysis. This one, please answer. There is no shortcut to memory. It is just repetition. So please repeat it along with me. What is this gray top tube? Gray top tube is used for glucose estimation, lactate estimation, and for alcohol estimation. Okay. Lavender top tube. Please tell me the answer. Lavender is used for complete blood count, HbA1c, parathormone, ACTH, and ammonia. Blue top tube, 3.2% sodium citrate for coagulation assays. Green top tube, it's for quicker analysis, right? For electrolyte estimation, quicker analysis of troponin, quicker analysis for parathormone, okay? And apart from this, this can also be used for molecular diagnostics and cytogenetics. And then gold top tube. What is it used for? Whenever the sample has to be transported or stored. Okay. So now about order of draw. Okay. So why are we worried about order of draw? We are worried about order of draw because now we are collecting blood sample using a needle. What do you call it as? You call it as a blood collection needle. We are not using a syringe. We are now using needle. When we use needle, what do? One end of the needle will be in the blood vessel. The other end of the needle will be piercing the rubber stopper of all these tubes. And all these tubes have different additives. So do you see that the other end of the needle gets into the lumen of all the tubes, will get contaminated with the additive of every tube. And it causes cross contamination with additives. Okay. So what should be collected first? You will have to collect blood sample in a tube, which is used for estimating an analyte, which is sensitive to contamination. Do you understand this? Which tube will you collect first? You will have to collect blood sample in a tube first. If you know that the sample is going to be used for estimating an analyte, which is very sensitive to contamination. Okay. Which tube will you collect last? I will collect blood sample in a tube last if I know that this tube has got an additive which is notorious to cause contamination. Do you get it? So what will you collect first? You will collect first in a tube wherein the analyte that is estimated is very sensitive to contamination. So what will I collect first? I will collect blood sample in a culture bottle first. right? I will collect blood sample in a culture bottle first. Otherwise, what would happen? The needle would have pierced all rubber stoppers. Whenever it pierces rubber stopper, any microorganism on the rubber stopper will be there in the needle. And then if I'm using it for culture analysis, then the culture is going to be false positive. So let me collect that sample for culture bottle first, okay? And then coagulation assays. What is coagulation assay tube? It is, yeah, blue top tube which has got sodium citrate. That comes next because all coagulation parameters are very sensitive to contamination. So what is first? First is yellow bottle, which is a culture bottle. That should be followed by coagulation tube, which is a sodium citrate tube. And then traffic light. What is traffic light sequence? Red followed by yellow followed by green. In traffic light, red, yellow, green. Okay, red, yellow, green. This is the sequence. And then it is EDTA. Okay, lavender top tube is next. Why am I taking lavender top tube at last? It is because EDTA chelates calcium. So if EDTA goes and contaminates any of these tubes, then the parameter that is estimated will be affected. So I'm going to collect EDTA here. And that should be followed by gray topped tube. The last tube has to be a gray top tube because fluoride is notorious to cause contamination. I hope it's clear. What is the sequence of blood draw, all of you? The sequence of blood draw, the first one is culture bottle. That should be followed by coagulation tube, that is a blue top tube. And then traffic light, red, yellow, green. And then EDTA. Finally, it is fluoride. Okay, so that's all about order of draw. Now about methods used for estimating common analytes. Have they asked you questions in this topic? Many a times, right? Once in INI-CET, they asked you the most widely used technique for creatinine estimation is. Again, they asked you the most specific method for creatinine estimation is. And then they asked you which is the most commonly used method for HbA1c estimation. And then they asked you about calcium estimation. So let's learn about the common analyte methods used. Okay. So starting from glucose, do you all remember this term GOD-POD method which you have learned in your first year? What is GOD-POD method? Glucose oxidase peroxidase method is used widely for glucose estimation. But if they asked you which is the most specific method, always enzymatic assays are specific. So the specific method for glucose estimation is hexokinase method. So please look at the question, read the question mindfully and pick up the right choice. If they ask you which is the most commonly used method for glucose estimation, it is glucose oxidase peroxidase method. The most specific method for glucose estimation is hexokinase method. Urea estimation. Urea is estimated by glutamate dehydrogenase method. Okay, it is GLDH method or glutamate dehydrogenase method. Creatinine. The most widely used method for creatinine estimation is kinetic Jaffe's. Right? What is it? The most widely used method is kinetic Jaffe, but the most specific method is enzymatic method. Using creatinase. Yeah, enzymatic method is very specific. For bilirubin estimation, it is Vandenberg reaction. So for glucose estimation, it is Vandenberg reaction. That is for bilirubin estimation. For total protein, have you all heard of Biuret method? Okay, for total protein estimation, it is Biuret method. For albumin, it is BCG method. Okay, albumin is BCG method. Electrolytes. For electrolytes, it is called as potentiometry. Okay, for electrolytes, it's based on potentiometry. When we talk about electrolytes, there is one electrolyte which is calcium. Please remember all facts about calcium estimation. For INI-CET, it's a favorite topic. Okay, because once they asked you, a person who is hyperventilating presents with carpopedal spasm. This is explained by which of the following? They're given low total calcium, high total calcium, alkalosis, acidosis. The answer is alkalosis. For answering that question, you need to know all about calcium estimation. And then they asked you, for calcium estimation, which of the following is true? Tourniquet has to be tried for long. The person should be asked to clench the fist. In a person who's immobilized for a long period of time, total calcium will be elevated. That is the right answer. Okay, so calcium is a favorite topic as far as INI-CET is concerned. Let me tell you few facts about calcium estimation. As far as calcium is concerned, there are two forms of calcium. One is total calcium. Whenever we say the normal calcium level is 9 to 11 milligram per deciliter. What is all or new? I don't understand your fact, all or new. These are the facts that have been previously asked. If you find it to be new, it means you have not worked on previous year questions. Okay. So at this point in time, I would like to tell all of you, please work out previous year questions. If you're not able to answer an MCQ based on a topic which has been first asked in this exam, the topic has never been asked before. It's a very new topic that has been asked in your exam. Even if you don't answer that question right, your rank does not get affected. Are you clear about it? But if you're not able to answer an MCQ which is based on previously asked topic, then your rank definitely gets affected. So it's all about smart work. Please work out previous year questions. All previous year topics you should be able to answer an MCQ which is based on those. Okay, so coming back to this, what was I telling you? Please don't keep asking, will this be enough for INI-CET? Okay, I would like to tell all students here, please watch this session. Please be mindful during the session. This session is all about previous year questions. This is for your quick revision. I am not here to give you false promises saying that beyond this, no question will be asked in INI-CET. But this session will be of use to you for quickly revising and for quickly understanding concepts. After this, please watch rapid revision video on PrepLadder version 10. Do you understand this? That will help you immensely. If you do both these, then I can tell you 95% of biochemistry questions will be based on both these. For now, please don't get into the fear of missing out mode. FOMO is not what you need now. Yeah, please be mindful, watch this, listen, memorize. Okay, so coming to what I was discussing about, I will repeat about glucose and urea. Let's finish this first. Okay, so calcium, total calcium, normal value is 9 to 11 milligram per deciliter. That is a total calcium that you estimate. This total calcium exists in two forms. One is free calcium. The other one is bound calcium. What do you mean by free calcium? The calcium that is not attached to anything. What is bound calcium? It's the calcium that is attached to plasma proteins. Bound calcium is the calcium that is attached to plasma protein or the calcium that is attached to inorganic anions. And the split is 50-50. Out of the total calcium, 50% of the calcium is free calcium. The remaining 50% of calcium is the bound calcium. And this free calcium is the physiologically important form of calcium. Yeah, the physiologically important form of calcium or the functional form of calcium is free calcium, because it is this free calcium which maintains the resting membrane potential. Okay, and about calcium estimation, you have methods which can estimate total calcium. You have methods to estimate free calcium. The method that is used to estimate total calcium is spectrophotometric method. Yeah, the method that is used to estimate total calcium is spectrophotometric method. Okay, that is widely used in all labs. But do we have method to estimate only ionized calcium? Yes. And if you're estimating ionized calcium, that is by potentiometry. Then I tell you just now, that is by potentiometry. Okay. So coming back to the question that I told you previously, What was the question? The question was, what if the person is hyperventilating and the person is presenting with carpopedal spasm? What is the reason? The reason is when the person is hyperventilating, the person washes away carbon dioxide. Carbon dioxide is a source of an acid. When the person gets rid of a source of an acid, the person presents with respiratory alkalosis. When there is respiratory alkalosis, all plasma proteins in the plasma senses alkalotic pH. Their aim is to avoid this alkalotic pH, for which they give off any hydrogen ion that they have. Do you understand this? In alkalotic pH, all plasma proteins sense the alkalotic pH. They give off their H plus to the medium. When proteins give off their H plus, all proteins become negatively charged. You understand this? All proteins become negatively charged. This means more and more calcium would come and bind to these proteins. Do you understand this? When all proteins become negatively charged, more and more calcium ions come and bind to proteins. So out of the total calcium, do you understand this? Out of the total calcium, which fraction increases? The bound fraction increases. So automatically free calcium decreases. Okay, when free calcium decreases, I said it's a free calcium, which is the physiological form of calcium. When there is low physiological form of calcium, resting membrane potential will not be maintained. The resting membrane potential reaches threshold potential, action potential is generated, and that causes all cells to be hyperexcitable. And hyperexcitable cells would present with carpopedal spasm. So tell me, what is the reason for carpopedal spasm when a person is hyperventilating? It is because of alkalotic pH. All proteins become negatively charged. All calcium go and bind to negatively charged proteins, increasing the bound fraction. So automatically free calcium decreases. When free calcium decreases, resting membrane potential is not maintained. So total calcium is unaffected. Do you all understand this? Total calcium remains normal, but free calcium is reduced. So tell me, which is a better way of estimating calcium? I'm not bothered about what is my total calcium. I'm bothered about the active form of calcium. So I have to be estimating free calcium. So which is the better way of assessing calcium levels in a person? Better way of assessing a calcium in a person is free calcium estimation, which is done by potentiometric method. Are you all clear about this? Yeah, because free calcium is responsible for maintaining the resting membrane potential. So look at the question. If they ask you total calcium is estimated by, what will be your answer? Spectrophotometric method. If they ask you ionized calcium or free calcium is estimated by, your answer should be potentiometry. If they ask you which is better, estimating the active form of calcium or estimating the free calcium is always better. That will tell me whether a person will end up in tetany or no. Okay. And now coming back to what are the preventive measures, or what are the measures that need to be taken whenever calcium needs to be estimated, right? Measures to be taken is tourniquet should not be applied for a prolonged period of time, right? Tourniquet should not be applied for a prolonged period of time, because what happens in this case, when you apply it for a prolonged period of time, there is an acidic pH that happens in the medium. When there is acidic pH, all proteins become positively charged. When proteins become positively charged, ionized calcium will become more. So there will be a false elevation of ionized calcium that is observed whenever tourniquet is applied for a prolonged period. Similarly, do not ask a person to clench the fist. If you ask a person to clench the fist for a prolonged period of time, again lactic acid accumulates, again ionized calcium value will be falsely high. So whenever you are estimating calcium, avoid tourniquet application, avoid clenching the fist, directly collect the blood sample and estimate ionized calcium by potentiometric method. Okay? Yes. So coming back to the methods used, we learned about electrolytes. Electrolytes are estimated by potentiometry. Total calcium is estimated by spectrophotometric method. HbA1c estimation. For HbA1c estimation, we have multiple methods. The most widely used method is ion exchange chromatography. For HbA1c estimation, the most widely used method is ion exchange chromatography. Of course, we have affinity chromatography, we have electrophoresis, we have immunoassays as well. But if they ask you which is the most widely used technique, your answer should be ion exchange chromatography. Okay, so let's now learn about the methods, a quick revision on the methods. Please look at the slide that is seen here. Okay, repeat it along with me. This repetition will help you in recollecting all the information on the day of exam. Okay, so glucose estimation, what is the method that is used? Glucose oxidase peroxidase method. Urea estimation is GLDH method. Creatinine, the most widely used method is kinetic Jaffe. The most specific method is enzymatic method. Bilirubin estimation, Vandenberg reaction. Total protein is estimated by Biuret method. Albumin by BCG method. Electrolyte estimation, potentiometry. And calcium, total calcium by spectrophotometry. Ionized calcium by potentiometry. HbA1c, the most widely used technique is cation exchange chromatography, but we also have other techniques. Okay. As you all know, GLDH is glutamate dehydrogenase method. Yeah, this is a rapid revision session. I will not be able to get into the details of chromatography. All that you need to know is ion exchange chromatography is used for HbA1c estimation. There is also affinity chromatography. Beyond this, I don't think I'll be able to have enough time to explain anything else about chromatography. Also, recently, I've not seen any questions on this. Okay. So, glutamate dehydrogenase, GLDH is glutamate dehydrogenase. So now about special analytes. Okay. So special analyte, I'm going to tell you few facts about HbA1c. What is HbA1c or glycated hemoglobin? It's a measure, right? It's a measure of irreversible, non-enzymatic glycation. Please remember, it is not glycosylation, it is glycation of N-terminal valen, of beta globin chain. Of beta globin chain of normal adult hemoglobin. Any of these can be asked as one-liners. So please remember what is glycated hemoglobin. It's a measure of irreversible non-enzymatic glycation. What is glycosylation? Glycosylation is enzymatic. Glycation is non-enzymatic. Okay. So it's a measure of irreversible non-enzymatic glycation of N-terminal valen of beta globin chain of normal adult hemoglobin. Okay, so why are we estimating non-enzymatic addition? Had it been enzymatic addition, then the measure that you do does not only depend on the glucose value of the blood, it will also be affected by the enzymatic activity. I don't want any variable. I want the only variable to affect this value to be the glucose that is present in the blood. Because using this, I'm trying to assess the long-term glycemic control of an individual. What am I trying to assess? I'm trying to assess how much of glucose had existed in this person in the last 6 to 8 weeks. So the only variable that should affect my HbA1c value should be what? The glucose level in the last 6 to 8 weeks. I don't want enzymatic activity to affect. That is why it's a measure of irreversible non-enzymatic glycation of N-terminal valen. Okay. And what am I going to use this for? I'm going to use this to assess the last 6 to 8 weeks glycemic control of an individual. What gives me the confidence to say that it is going to reflect the last 6 to 8 weeks glycemic control? It is because I know that lifespan of RBC is 120 days, right? If an RBC is born, it is there in the blood for 120 days. In those 120 days, this RBC is exposed to glucose that is present in the blood. If the glucose level in the blood is high, amount of glycation is going to be high. Okay, but what is the limitation of estimating HbA1c? It is based on an assumption that lifespan of RBC in every individual is 120 days, which is not true. Okay. For example, if the person has got iron deficiency anemia, all of you tell me, in iron deficiency anemia, what happens to lifespan of RBCs? Lifespan of RBC will be high because the body assesses that there is not enough iron. So the body wants to conserve iron, for which the body conserves RBCs. Right? If there is rapid turnover of RBC, there is a need for iron. The body does not have iron. So the body does not allow RBCs to undergo turnover. So lifespan of RBCs increased. So not for 120 days, for longer period of time, these RBCs have been there in the circulation. So they get glycated more. So that causes false high values. Do you understand this? This causes false high values of HbA1c. Please remember this. Is iron deficiency anemia common? Yes, it's very common. So whenever you are interpreting HbA1c value, please check if the person has got normal hemoglobin levels. If the person does not have normal hemoglobin levels, you're not supposed to interpret HbA1c directly, and you're not supposed to titrate the anti-diabetic drug concentration. Do you get it? This is why many a times women, right? Women with iron deficiency anemia present with hypoglycemic episodes. Why do they present with hypoglycemic episodes? This lady with iron deficiency anemia has shown a falsely elevated HbA1c value. Based on the falsely elevated HbA1c value, the diabetologist has titrated the dose, has increased the dose. And because of the high dose of anti-diabetic drug, the person is presenting with a hypoglycemic episode. So you as a clinician, when you're asking for HbA1c value, always ask for CBC. Always look out all hemoglobin and iron related parameters. Okay. So that is about iron deficiency anemia. What happens in hemolytic anemia? In hemolytic anemia, lifespan of RBC is reduced. When lifespan of RBC is reduced for a shorter period of time, it is exposed to glucose. So that gives you false low values. So whenever you see a patient with iron deficiency anemia and hemolytic anemia, don't use HbA1c values to titrate the drug dosage. Right? What should you use? You should use fructosamine. In iron deficiency anemia and in hemolytic anemia, don't use HbA1c values to titrate the dose of the drug. What should you use? You should use fructosamine. Because what is fructosamine? Fructosamine is glycated albumin. Right? Fructosamine is glycated albumin. So this does not get affected whenever RBC lifespan is altered. But what is the limitation of using fructosamine? If you use fructosamine, that is not going to give you the last 6 to 8 weeks glycemic control. It would give you the last 3 to 4 weeks glycemic control information. Because lifespan of albumin is not 120 days, it is shorter than that. Do you understand this? So this is about estimating HbA1c and this is about estimating fructosamine. If it's a case of beta thalassemia trait where hemoglobin is low, that will also show high HbA1c. Even if the total hemoglobin is low, okay, even if the total hemoglobin is level is low, what happens to your glycated hemoglobin concentration, hemolytic anemia? That is going to be very low, okay, and that causes low values of HbA1c. Iron deficiency anemia, Dr. Strange. Iron deficiency anemia, you want to conserve RBCs, right? When you want to conserve RBCs, you won't allow RBCs to undergo turnover. RBCs are alive for a prolonged period of time. They live longer than 120 days. For a longer period of time, they get exposed to carbohydrates present in the blood, and that causes false high values. I hope it's clear. Dr. Strange, if it's clear, send me a thumbs up, please. So that's about special analyte HbA1c and fructosamine. Now about color reactions in urine, right? This is also a favorite topic of INI-CET. Have you seen image-based question on Rothera's tests? They've given you image-based question on Rothera's test. They always give you a purple colored ring, right? Purple colored ring, and they ask you what is the clinical condition. Or they've given you image-based question on Benedict's. Choice A is Benedict's test. Choice B is alkaptonuria. Choice C is Rothera's test. And choice D is something else. So color reaction of urine is another favorite topic for INI-CET. Let's learn about this now. Okay. Yeah. So I'm going to fill up this table. Abnormal constituent of urine. What is the color reaction that is done and what is the observation? Obviously, first one is reducing sugar. All of you, please give me an answer to find out if there is a reducing sugar in urine. What is the color reaction that you perform? The color reaction that you perform is Benedict's test. When you perform Benedict's test, the blue color Benedict solution, if it becomes red, if the blue color Benedict solution becomes red, it is Benedict's test positive, which means urine has got some reducing substance. So to find out if there is any reducing sugar, what is the test that you perform? Benedict's test, wherein blue color Benedict solution becomes red. Okay. To find out if there is ketone body, to find out if there is Suhail Akhtar, you will have to wait for another 10 minutes. I'm going to start genetics. Okay. So all of you, I'm reiterating this fact. Do not get into FOMO. Yeah, do not get into FOMO. Please live your life for that moment. Right? Please live your life. When I say live your life for that moment, at that point in time, what is the information that you're gathering? Be happy about it. Register it. Keep collecting as and when you go. At the end of the day, the number of facts that you would have learned will be much better than, right? Much better than you crying over a fact which you don't know. Is that clear? Yeah. So please wait. I will finish all topics in biochemistry. I don't want you to get distracted by what is yet to be discussed. Okay. So listen to this. Ketone bodies. Yes. What is the color reaction that is used? Rothera's test. And in Rothera's test, what is the observation? That means it is positive. The observation is purple colored ring. Okay, that's about ketone body, Rothera's test. And then to find out if the urine has got any protein. Yeah, to find out if the urine has got any protein, the color reaction that is used is sulfosalicylic acid test. Sulfosalicylic acid test. Then you see white precipitate. So please don't get confused. What did I tell you? The test used to find out if there is protein in blood, right? Protein in blood is Biuret test. Protein in urine is different. Protein in urine is sulfosalicylic acid test, where you see a white color precipitate. To find out if there is blood in urine, it is benzidine test. To find out if there is blood in urine, it is benzidine test, where you see dark green or black precipitate. Benzidine test gives you dark green or black precipitate. Okay. Now bile salt. It's an interesting reaction. I hope you remember you playing with sulfur powder in your first year lab. Right? You would have put sulfur powder and you would have seen whether it sinks to the bottom or is it floating on the top, right? That is bile salt test. So the test that is used to detect if there is bile salt is sulfur test, sulfur powder test or haze test. Okay, sulfur powder test or haze test. Please remember what is positive, what is negative. When you add a sulfur powder, if there is bile salt in the urine, bile salt reduces the surface tension of urine. When there is no surface tension in the urine, when you add sulfur powder, it sinks to the bottom. So whenever sulfur powder sinks to the bottom, it is positive. Do you all understand this? Whenever sulfur powder sinks to the bottom, it means there is no surface tension. It means there is bile salt. So what will you observe here? You would observe that sulfur powder sinks to the bottom, which means it is bile salt positive. What is a test done to detect if there is bile pigment in urine? For bile pigment, it is Fauchet's test. Please remember what is the test? It is Fauchet's test. In Fauchet's test, you see blue or green precipitate on the filter paper. Do you understand this? What do you see in Fauchet's test? Blue or green precipitate on the filter paper. So all of you listen to this. Yeah, so there is a visual form of memory that you can establish here and an auditory memory that you can establish because I'm going to repeat it. Please repeat it along with me. That means your psychomotor memory is also getting established. Okay, so let's stimulate as many sensory systems as possible during this session. Please look at it, listen to me and repeat it. Okay, so what is the test that is done to detect if there is any reducing substance in the urine? Benedict's test, when you see blue precipitate become blue color solution becoming red precipitate. Ketone bodies, Rothera's test, you see a purple colored ring. To find out if there is protein in urine, it is sulfosalicylic acid test, which gives you white precipitate. To find out if there is blood in urine, it is benzidine test, when you see dark green or black precipitate. Bile salt, it is Hayes test. If sulfur powder sinks to the bottom, it is positive. Bile pigment, it is Fauchett's test, when you see blue or green precipitate on the filter paper. Also remember, whenever bile salt and bile pigments are positive in urine, both bile salts and bile pigments are positive in urine, it means it is obstructive jaundice. Please remember what is it? It is obstructive jaundice. Because only when there is an obstruction in the bile duct, bile overflows and it gets into the circulation. And whenever it gets into the circulation, it is there in the urine. So bile salts, bile pigments positive means it is obstructive jaundice. Are you clear? So this is about, yeah. This is about abnormal constituents of urine. What is the color reaction that can be performed? What is the observation which is positive? Okay. Now, few mnemonics related to amino acids, right? So I always tell you these 4 mnemonics because students find it very difficult to memorize what is the group that is present in an amino acid and what is the color reaction that is answered by an amino acid. Okay, just 4 mnemonics. The first mnemonic is HIP. The second mnemonic is TIA. Transient ischemic attack, right? TIA. The third mnemonic is AGS. The third mnemonic is AGS. The last one is MPS. Okay, so repeat this. What are the 4 mnemonics that you should remember? HIP, TIA, AGS, and MPS. What does HIP stand for? H stands for histidine. What is the group that is present? Imidazole group. Histidine has got an imidazole group and it answers Pauli's test. Okay, histidine, imidazole group, Pauli's test. TIA, tryptophan, has got an indole ring. Tryptophan has got an indole ring and it answers aldehyde test. TIA, tryptophan, indole ring, aldehyde test. AGS, arginine, has got a guanidinium group. Right? Arginine has got a guanidinium group. It answers Sakaguchi test. MPS is the mnemonic that you can remember, that you can use to remember what are the color reactions which give you red color. Right? What are the color reactions which give you red color? Other than this, most other color reactions related to amino acids will give you purple color. Okay. So what are the red color reactions? Millen's test, Pauli's test, and Sakaguchi test. Okay. Millen's test, Pauli's test, and Sakaguchi test are the 3 color reactions which give you red color. Are you clear? So these are the 4 mnemonics that you should remember. Okay. So histidine, imidazole group, Pauli's test, tryptophan, indole group, aldehyde test, arginine, guanidinium group, Sakaguchi test, Millen's test, Pauli's test, Sakaguchi test give you red color. Okay, can we try some MCQs now? MCQs and PYQs. So start answering this, everybody. It's an INI-CET PYQ on prolonged starvation. Which of the following tests will be positive? Prolonged starvation. Starvation causes ketosis. Ketosis, what is the color reaction? Rothera's test. Rothera's test will give you what color reaction? Purple colored ring. So what is the right answer here? All of you please start typing it in the chat box. The right answer is C. Okay. But we are going to learn about other choices as well, right? So these are the other choices. What is this yellow color? This is xanthoprotic acid test. Yellow color is xanthoprotic acid test. I always ask you to remember it this way. Do you remember in your class 12, right? 12 standard salt identification, whenever you worked with dilute nitric acid, if dilute nitric acid falls on your palms will get discolored yellow, right? That is because nitric acid reacts with aromatic amino acids of the sweat to give rise to yellow colored complex. Nitric acid reacts with aromatic amino acids. So what are the aromatic amino acids that you know? Please remember the three aromatic amino acids are phenylalanine, tyrosine, tryptophan. Have you memorized it? As I always tell you, be alive at this moment. Memorize every fact that comes in your way, right? So what are the three aromatic amino acids? Phenylalanine, tyrosine, tryptophan. All these three aromatic amino acids react with dilute nitric acid to give yellow colored complex. That is xanthoprotic acid test. That is choice A. Okay. Choice B, blue color becoming red. Please tell me what is this color reaction? Benedict's test. What does it signify? It signifies that urine has got some reducing substance. Okay. The next one we all know, Rothera's test, which tells you that the urine has got ketone bodies. What is the last one? There are two possibilities for the last one. Urine turning dark on standing. Please tell me which clinical condition is it? Urine turning dark on standing is alkaptonuria, right? Alkaptonuria caused by the defect of homogentisate oxidase. Alkaptonuria is one possibility. The other possibility is benzidine test. Did I tell you benzidine test is a test done to detect if the urine has got blood? If there is blood in urine, then you see dark green or black precipitate. Okay, very good. So that is about the four choices that were given in this INI-CET question. Quickly answer this, all of you. Additive, red top tube. What is the mnemonic that I gave you? RSS. S here stands for silica. So what is the right answer? The right answer is choice D. I'm happy to see that the chat box is active. I would like this to happen throughout the session, right? So the more active you are, better will be the retention. Is that clear? So please be active throughout the session. The most widely used technique for HbA1c estimation is, again, INI-CET PYQ. What is it? It is ion exchange chromatography. Choice A. Long-term, another INI-CET question. Long-term glycemic control in a person with hemolysis is assessed by estimating fructosamine. What is fructosamine? Fructosamine is glycated albumin, right? What is albumin? Albumin is a protein. Only in INI-CET, they are as cautious as this, right? They are not giving out the right answer even in, by using it as an or a. So what is it? Glycated albumin. The answer is protein. Answer this, please. The group that is present in tryptophan. What is the mnemonic I gave for tryptophan? TIA, right? So tryptophan has got an indole ring. Don't get confused between indole and imidazole. Indole in tryptophan, imidazole in histidine. Young boy, another INI-CET. So already do you see two MCQs previously asked in INI-CET on Rothera's test. Young patient with type 1 diabetes. This is diabetic ketoacidosis with unconsciousness. So what is it? Rothera's test. So what is the right answer? Choice B. Try answering this. Which is the right order of blood draw? What should be drawn first? Yellow bottle. Culture bottle has to be first. So we know the first one has to be yellow. What should be the last? The last one has to be fluoride or gray. So do you know the answer already? First is yellow. The last is gray. So what is the right answer? The right answer is choice B. Okay, very good. Yeah. So part two, it's a very short part. It's all about graphs because, as you know, image-based questions are often asked in INI-CET, right? And the graphs that they ask are also unique. So let's learn about first Lineweaver-Burke plot. Today we'll be learning about Lineweaver-Burke plot. We'll be learning about glucose tolerance tests. Because do you remember in November 2025 INI-CET, there was a question on glucose tolerance test. So let's learn about glucose tolerance test graph interpretation. I'll be telling about something called a surface plasmon resonance graph that was asked previously. And recent November 2025 INI-CET, there was a question on titration curve. So let's learn about all these graphs now. Let me start with a brief theory concept of Lineweaver-Burke plot. Not entirely the theory. Okay, we'll quickly finish this in 15 minutes. The entire graph part. Okay. So brief theory, it's all about Vmax and Km. I want you to only know about Vmax and Km. And then I'll tell you about the graph. So what is Vmax? Vmax is the maximum velocity that is achievable by an enzyme. Are you clear? What is Vmax? Vmax is the maximum velocity that is achievable by an enzyme. Now, what is Km? I'll give you the definition of Km. Look at it. Listen to this. Km is the substrate concentration at half maximal velocity. Right? What is Km? Km is the substrate concentration at half maximal velocity. To keep it simple, what is Km of an enzyme? It tells you how much substrate does this enzyme need for this enzyme to achieve half maximal velocity. Okay. What if I say Km of an enzyme is high? If I say Km of an enzyme is as high as say 1000 micromole, it means this enzyme needs 1000 micromoles of the substrate to achieve half maximal velocity. Okay. What if I say Km of an enzyme is low? Suppose I say Km of an enzyme is only 10 micromole. It means even when I provide just 10 micromole, this enzyme can achieve half maximal velocity. So what do I mean whenever I say Km of an enzyme is low? I mean to say that I need to provide very less substrate for the enzyme to become active. Why do you think I have to provide only less substrate? It is because the affinity is high. Do you understand this? Because affinity is high. So tell me, how are Km and affinity related? Km and affinity are inversely related. Low Km means high affinity. Do you understand this? So these are the two simple facts that I want you to remember about Vmax and Km. Okay. Now Lineweaver-Burke plot. How do we draw this Lineweaver-Burke plot? Let me first tell you, it is also called as double reciprocal plot. So my request to all of you who are watching this session is to stay put for the next 5 minutes. If you're here for the next 5 minutes, any MCQ on enzyme inhibition, any MCQ on Lineweaver-Burke plot, you will be able to answer. Okay. So what is the other name for Lineweaver-Burke plot? It's called as double reciprocal plot. Why do we call it as double reciprocal plot? It is because both along the x-axis and along the y-axis, you see reciprocals. Along x-axis, it is 1 by S. Along y-axis, it is 1 by V. If you're all asking me how to remember this, it's easy. Because along x-axis, it is 1 by S. X and S sound similar. Yes or no? X and S sound similar. So along x-axis, it is 1 by S. Y and B look similar, right? Y and B look similar. So along y-axis, it is 1 by V. Whenever you draw a graph with 1 by S along x-axis and 1 by B along y-axis, you always get a straight line. For any enzyme, you get a straight line. If you extend the straight line touches the y-axis. If you extend the straight line touches the y-axis at 1 by V max. Already I said along y-axis it is 1 by V. So it touches the y-axis at 1 by V max. And it touches the x-axis at -1 by Km. Have you understood this? So can you repeat this, all of you? Please tell me, how do you draw Lineweaver-Burke plot or double reciprocal plot? The double reciprocal plot is drawn with what along x-axis? Please repeat it. Along x-axis it is 1 by S. Along y-axis it is 1 by V. We always get a straight line. If you extend the straight line touches the y-axis at 1 by V max. It touches the x-axis at minus 1 by Km. Okay. So what is this graph used for? This graph is used to find out the Vmax and Km of an enzyme. It is to find out the Vmax and Km of an enzyme. There is another use for this double reciprocal plot. It is also used to find out the type of enzyme inhibition. Now, what are the types of enzyme inhibition? Please remember, there are two types of enzyme inhibition. One is reversible inhibition, the other one is irreversible inhibition. Let's forget about irreversible inhibition. Reversible inhibition is of 3 types. Okay, reversible inhibition is of 3 types. What are the 3 types? The first one is competitive inhibition. Second one is uncompetitive inhibition. The third one is mixed inhibition. So tell me, what are the 3 types of reversible inhibition? Competitive, it is not non-competitive. Competitive, uncompetitive, and mixed inhibition. A special type of mixed inhibition is called as non-competitive inhibition. Are you clear about this? These are the types of enzyme inhibition. Now we are going to learn about what happens to Vmax and what happens to Km in all the 4 types of inhibition. Okay. What happens to Vmax and what happens to Km in the presence of any of these types of inhibitors. First, about competitive inhibition. All that I want you to know about competitive inhibition is, in this type of inhibition, you can overcome the inhibition by increasing the substrate concentration. What should you remember? You can overcome competitive inhibition by increasing the substrate concentration. If you can overcome the inhibition, what happens to the final Vmax that is achievable? The final Vmax that is achievable is normal. You're able to overcome the inhibition. So the final Vmax that is achievable is unaltered. So please remember, in competitive inhibition, Vmax is not changed. But to reach that Vmax, I said you have to increase the substrate concentration. And what is Km? I told you Km is the substrate concentration at half maximal velocity that needs to be increased. Okay, so in the presence of a competitive inhibition, what is not changed? Vmax is not changed, but Km is increased. Okay, next type, uncompetitive inhibition. You cannot overcome the inhibition. If you cannot overcome the inhibition, then the final Vmax that is achievable is less. Right? If you cannot overcome the inhibition, the final Vmax that is achievable has to be less. Also remember, in uncompetitive inhibition, it is parallel shift. What do I mean by parallel shift? Not only Vmax is low, Km is also low. Because it's a rapid revision session, I will not be able to explain why. If you want to know why, please watch rapid revision videos in PrepLadder version 10. Is that clear? So for now, what should we know about? We should know about in uncompetitive inhibition. In the case of uncompetitive inhibition, both Vmax and Km are low. Mixed inhibition. In the case of mixed inhibition, both the values are affected in the wrong direction. What do I mean by wrong direction? For me to say that an enzyme is active, I should say that Vmax of the enzyme is high and Km is low. Right? For me to say that this enzyme is active, I should be saying that this enzyme's Vmax is high and Km is low. But what does the mixed inhibitor do? It affects both. So Vmax is low and Km is high. Mixed inhibitor, Vmax is low, Km is high. Okay. Non-competitive inhibition. Non-competitive inhibition, normal Km. Easy to remember, right? Non-competitive inhibition is normal Km. Okay, it is normal Km, but Vmax is low. Okay, so this table, everybody should remember. All of you look at this. 1 second. I'm not able to see the live chat. So what happens in the presence of these 4 types of inhibitors? First, about competitive inhibition, it can be overcome. So Vmax is normal, Km is high. Uncompetitive inhibition, you cannot overcome this inhibition. Bmax is low, Km is also low. Mixed inhibition, both are affected in the wrong direction. Bmax is low, Km is high. Non-competitive inhibition, normal Km, Bmax is low. Okay, so this you will be able to find out. What do you mean by minus sign? Pratik, Vyas, don't worry about all these intricacies. Okay, don't worry about all these intricacies. The negative point does not mean anything. Okay, just know it touches the x-axis at -1 by k. Okay, it's the absolute value that you should look at. Okay, so this you will be able to find out when you look at the Lineweaver-Burke plot. Okay, so Lineweaver-Burke plot, all of you tell me for a quick revision. All of you tell me what is along x-axis. 1 by substrate concentration along x-axis. What is along y-axis? 1 by V along y-axis. What do you get? A straight line. The straight line touches the y-axis at 1 by Vmax and it touches the x-axis at -1 by Km. Okay, so this is a normal Lineweaver-Burke plot. What happens to this graph? So what is this? This is the line that you get for a normal enzyme in the presence of a substrate. What happens to this line when there is an inhibitor in the medium? When I add a competitive inhibitor to this combination, I said this competitive inhibitor does not affect Vmax. So 1 by Vmax would remain the same. Yeah, it does not affect the Vmax. So 1 by Vmax remains the same. But what happens to Km? I said Km is increased. If Km is increased, 1 by Km will be decreased, right? If Km is increased, 1 by Km will be decreased. So if you see a line like this, right? If you see a line like this in the presence of an inhibitor and they're asking you what type of inhibition is it? Your answer should be competitive inhibition. Do you get it? So all of you listen to this carefully. Whenever you see an image-based question on Lineweaver-Burke plot, step number 1 is for you to check what is along x-axis. Ascertain that along x-axis it is 1 by S. Then check what is along y-axis, right? Be clear that along y-axis it is 1 by V. And then if you look at the curves, there will be more than one curve. Find out which is the curve that is there in the presence of just enzyme and substrate without an inhibitor. Find out which curve tells you about enzyme and substrate effect without any inhibitor. That is the nascent curve. Okay, that will tell you the normal Bmax and normal Km of that enzyme. After finding out the normal Bmax and normal Km, look at the other curves, right? That will tell you about the effect of an inhibitor. In the presence of an unknown inhibitor, if you see that Vmax is not changed and if you see that Km is increased, close your eye and say it is competitive inhibition. Got it? So this is about competitive inhibition. Now about Normie Doctor, you will be getting the PDF as soon as the session gets over. Okay? I mean, you don't have to cry for this. This PDF is made ready for you, right? You will be getting the PDF. So for now, look at this, learn it. Okay? So now what happens in the presence of an uncompetitive inhibitor? So this is the Lineweaver-Burke plot for a normal enzyme in the presence of a substrate. In the presence of an uncompetitive inhibitor, tell me what happens to Vmax? Vmax is low. What happens to Km? Km is also low. Okay. When Vmax is low, 1 by Vmax is high, 1 by Km is high. So when you see 1 by Vmax to be high and 1 by Km to be high, because of which if you see a parallel line like this, right? If you see a parallel line like this, in the presence of an unknown inhibitor, And if you're asked what type of inhibition is this, your answer should be uncompetitive inhibition. Do you understand this? Whenever you see parallelly shifted lines above, your answer should be it's an uncompetitive inhibitor. Okay. What happens in the presence of a mixed inhibitor? What did I tell you a mixed inhibitor does? It reduces the Vmax and it increases the Km. Okay. So 1 by Vmax is high and 1 by Km is low. Okay. If this is the line that you get in the presence of an enzyme and a substrate, and in the presence of an unknown inhibitor, which is the mixed inhibitor, what happens to Vmax? Vmax is low, so 1 by Vmax is high. What happens to Km? Km is high, so 1 by Km is low. So if you see a line like this, right? If you see a line like this, which has allowed the 1 by Vmax to be high and 1 by Km to be low, and you're asked what type of inhibition is it, what will be your answer? Your answer will be a mixed inhibition. Okay. Now the last type. What is the last type? The last type is non-competitive inhibition. What did I tell you about non-competitive inhibition? It is normal Km. Right? Normal Km. So if this is the graph that you have in the absence of any inhibitor, and in the presence of an inhibitor, 1 by Km is the same, but Vmax is low, so 1 by Vmax is high. So if you see a line like this and you're asked what type of inhibition is it, what will be your answer? Your answer will be non-competitive inhibition. Right? Your answer will be non-competitive inhibition. Okay. So that is all about Lineweaver-Burke plot and types of enzyme inhibition. Okay. So now the next graph that we are going to learn about is glucose tolerance tests. So glucose tolerance test, recently they showed you a graph and they asked you which of these curves represent diabetes curve. Okay. So first, how was this graph drawn? This graph is drawn according to whose standards, right? According to whose standards, this graph is drawn after a person is given 75, right? After a person is given 75 grams of oral glucose that is dissolved in 200 to 300 ml of water. But what should happen prior to this? Prior to this, there should have been 8 to 12 hours of fasting. Not just 8 to 12 hours of fasting. Prior to this, for the previous 3 days, the person should have taken normal glucose, normal carbohydrate intake. Normal carbohydrate intake is 150 grams of glucose. Yeah, normal person. I'll show everything. Okay. So prior to this, for the previous 3 days, the person should have taken 150 grams of glucose per day. Okay. So these are the ways of doing GTT. So what should be done? What are the steps? The step number 1 is the last 3 days, a person should have taken 150 grams of carbohydrate per day. And the day before, 8 to 12 hours of fasting. On the day, collect fasting blood sample and urine sample. After you collect fasting blood sample and urine sample, give the person 75 grams of glucose dissolved in 200 to 300 ml of water. And then you collect blood sample and urine sample every half an hour. Half an hour, 1 hour, 1.5 hours and 2 hours. Okay. And then you draw this glucose tolerance test. When you draw this glucose tolerance test, what is the diagnostic criteria? What is the normal level? Normal glucose levels are, you call a person to have normal glucose tolerance only when the fasting plasma glucose is less than 100 milligram per deciliter, which means only till it is 99 it is normal. 100 and above is not normal. Do you understand this? What is the normal criteria? For normal glucose tolerance, the criteria is fasting plasma glucose should be less than 100 milligram per deciliter. And postprandial, 2 hours postprandial glucose should be less than 126 milligram per deciliter, which means only till 125 it is normal. Okay. So what is the criteria for normal values? Less than 100 fasting, less than less than 140 postprandial is normal. 126 is about diagnostic criteria for diabetes. Okay. So fasting plasma glucose less than 100, postprandial plasma glucose less than 150. When I say less than 150, less than 140. When I say less than 140, even 140 is not normal. Okay, this is for normal. Now, what is the diagnostic criteria for diabetes? Whenever the fasting plasma glucose is more than or equal to 126 milligram per deciliter. What is the diagnostic criteria for diabetes? Whenever fasting plasma glucose is more than or equal to 126 milligram per deciliter, and whenever the postprandial glucose is more than or equal to 200 milligram per deciliter, then that is diabetes. So what if the value is in between? What if it's between 100 and 125? If the fasting plasma glucose is between 100 and 125 milligram per deciliter, that is impaired glucose tolerance. If the 2 hours postprandial is between 140 and 199, 2-hour postprandial is between 140 and 199, that is impaired glucose tolerance. So are you clear about these criteria? Yeah. So what is normal, all of you? Normal diagnostic criteria is fasting plasma glucose less than 100, postprandial plasma glucose less than 140. That is normal. What is diabetes criteria? Diagnostic criteria for diabetes mellitus is fasting plasma glucose more than or equal to 126. 2 hours postprandial glucose more than or equal to 200 is diagnostic criteria for diabetes. What is impaired glucose tolerance? Fasting plasma glucose between 100 and 125, and postprandial 2 hours postprandial between 140 and 199, diagnostic criteria for impaired glucose tolerance. So whenever they ask you for diagnostic criteria for diabetes, please remember these three values. Diagnostic criteria for diabetes. Okay. One is fasting plasma glucose more than or equal to 126 milligram per deciliter. 2 hours postprandial glucose more than or equal to 200 milligram per deciliter. HbA1c value more than or equal to 6.5. Right? More than or equal to 6.5, irrespective of whether they have any symptoms or no. If you see any of these, that is diagnostic of diabetes. Are you clear? Oral glucose tolerance. What do you mean by PP? This is about oral glucose tolerance. Okay. So normally oral glucose tolerance, how do you see the graph? The graph will start at 0R. 0R is the fasting value. The fasting value will be anywhere between 70 and 99. That is normal. And that is where it starts. And then you will see a peak. You will see a peak plasma glucose 1 hour postprandial. 1 hour postprandial, you see a peak glucose. And that peak glucose should be less than the renal threshold. What is the renal threshold for plasma glucose? 180 milligram per deciliter. 1 hour postprandial glucose will be the peak value, and that peak value will be less than renal threshold, which is 180 milligram per deciliter. From there, 1 hour, it comes back to close to normal in 2 hours. In 2 hours postprandial, it comes back to close to normal. So this is the normal glucose tolerance. Do you see that? From where does it start? The fasting value, it is normal. Normal value is anywhere between 70 and 99. When do you see a peak? The peak is seen close to 1 hour. The 1 hour postprandial should be less than the renal threshold, which is 180 milligram per deciliter. From there, it starts declining, and close to 2 hours, it comes close to normal. This is normal GTT. Okay, now look at this GTT and can you make a diagnosis? Medico by choice, be it following oral glucose tolerance or following a person having a meal, 2 hours postprandial value that I said is diagnostic for normal, impaired and diabetes. There is no change in whether you're giving it as glucose or the person has had a food. To us, these are the values. I hope it's clear. Okay, so look at this and tell me about this curve. You know, this is the normal curve. Now tell me about this curve. What is a fasting plasma glucose? Fasting plasma glucose is more than 100, less than 126. It is impaired. Okay. And then 2 hours postprandial. 2 hours postprandial is more than 140. So it is not normal, less than 200. So it is impaired glucose tolerance. Do you understand this? What is the diagnosis for this curve? This curve is a curve of a patient who has got impaired glucose tolerance. Now look at this curve and tell me the diagnosis. Look at the fasting value. Fasting value is less than 100. This is normal. But look at the steep increase. The steep increase, and the peak is seen just half an hour after food. I said the normal glucose tolerance peak is seen 1 hour after food, but here there is a steep increase in plasma glucose. The peak is seen half an hour after diet. And this has crossed the renal threshold. What is the renal threshold? I told you 180 milligram per deciliter. If it has crossed renal threshold, at this point, the urine sample that was collected would show positive result for glucose, right? Thereafter, there is a steep fall. Why am I saying it's a steep fall? Even within 1 hour, it is back to normal values. And then it is almost like hypoglycemia. So what is it? This is called as alimentary glycosuria. What is your diagnosis? Alimentary glycosuria. This happens whenever the GIT starts absorbing glucose quickly from the diet. So when there is an increase in the rate of absorption of glucose along the intestine, there is a steep increase in plasma glucose. You see a peak close to half an hour, and that peak crosses renal threshold for glucose to be found in urine. Seeing such a steep increase in plasma glucose, pancreatic beta cells will respond to it by releasing insulin. When the insulin is released, there is no further increase in plasma glucose. So there is a steep fall and the person ends up in hypoglycemic episodes 2 hours later. This is called as alimentary glycosuria. Tell me, what are the clinical conditions when you can see alimentary glycosuria? Whenever there is thyrotoxicosis, right? Whenever there is thyrotoxicosis, because thyroxine causes upregulation of GLUT transporters in enterocytes. So in thyrotoxicosis, because GLUT transporters get upregulated in enterocytes, in the immediate postprandial state, there is a steep increase followed by a steep fall. Another example for alimentary glycosuric condition is whenever there is a short bowel syndrome, right? Short bowel syndrome, gastrectomy, yeah, CA stomach or CA small intestine. So there is a short bowel syndrome, in which case the hyperosmotic food is rapidly dropped into the absorptive segment of intestine. So in the immediate postprandial state, rapid rise and rapid fall. So when do you see alimentary glycosuria? In thyrotoxicosis and in short bowel syndrome. That is when you see a steep rise and a steep fall. Okay. Now look at this. What do you see here? The fasting plasma glucose is normal, right? And you see a rapid rise, but the rapid rise has not crossed the renal threshold. Though it does not cross the renal threshold, you see that urine glucose is positive. Despite plasma glucose not going above renal threshold, if glucose is found in urine, then that is called as renal glycosuria. Right? What do you call it as? You call it as renal glycosuria. This is basically a defect of proximal convoluted tubule, wherein the PCT has failed to reabsorb glucose. Only when PCT has failed to reabsorb glucose, even when the plasma glucose is much below the renal threshold, it will be found in urine. So this is called as renal glycosuria that happens whenever proximal convoluted tubule is damaged. For example, Fanconi syndrome. For any reason, when PCT is damaged in Fanconi syndrome, PCT does not reabsorb glucose. So glucose is found in urine despite plasma glucose being less than the renal threshold for glucose. Okay. Yes. So this was the graph that was shown in the recent INI-CET paper. And here they told you that this discontinuous line represents normal glucose tolerance. And then they said continuous lines are named as A, B, C, D. So look at A. What do you see in A? Fasting glucose is normal, right? There is a peak in 1 hour. And then 2 hours postprandial glucose is also normal. So the continuous line A is normal. All of you look at the curve B. What do you see in curve B? There is a steep increase. In the first half an hour, it has crossed the renal threshold. So urine would have shown glucose. And then there is a steep fall. So what is B? Steep rise, steep fall. That is alimentary glycosuria. Okay. Now look at the curve C. What is the fasting value? Fasting value is close to 150, which means it's more than 126. That is the diagnostic criteria for diabetes, right? Fasting glucose more than 126, diagnostic criteria for diabetes. Look at 2-hour postprandial glucose. That is also above 200. So what is C? C is diabetes. Look at D. Fasting glucose is even higher, above 200. 2 hours postprandial, above 350, close to 350. So D is severe diabetes. Do you understand this? D is severe diabetes. So tell me A, B, C, D. A is normal. B is alimentary glycosuria. C is diabetes. D is severe diabetes. Okay. Danish Gaude, I'm happy that you're enjoying this session. Yes, these are common topics. Many a times we miss it. So I thought I should include this in this session. So we learned about Lineweaver-Burke plot. We learned about glucose tolerance test. Now about surface plasmon resonance graph. Even in the wildest of my dreams, right? Even the wildest of my dreams, I did not expect an INI-CET paper to have a question on surface plasmon resonance graph. An UG student is not expected to know this, but because they had asked you before, now it becomes a previous year topic. So let me help you understand this. Okay. So surface plasmon resonance graph is drawn with what along x-axis and what along y-axis. As you can see in the image, right? What is along x-axis? Time is along x-axis. Resonance unit is along y-axis. What is this graph used for? This graph is used to learn about binding kinetics between two molecules. What is it used for? It is used to learn about binding kinetics between two molecules, like how antigen antibody interact, how a DNA and protein can interact, how a protein and another protein can interact. So it is all about learning binding kinetics between two macromolecules. Okay, what is the principle that is used? Please listen to this carefully. I'll show you all the slides. For now, listen to me, try to understand this. It is based on a very simple concept that whenever one macromolecule binds to another macromolecule on a surface, resonance increases. Okay, this is the basic principle. Whenever one macromolecule binds to another macromolecule on a surface, the surface resonance increases. So how do we draw this graph? To draw this graph, I take a flat surface. On this flat surface, I absorb one macromolecule. One macromolecule that I absorb is antibody. Okay, and then on the surface, I throw a solution. The solution will be of an antigen. So when I throw the solution, which is an antigen, this antigen goes and binds to this antibody. Antigen-antibody interactions happen. Whenever there is an antigen-antibody interaction that is happening on the surface resonance unit increases. Do you understand this? Surface resonance unit increases. So as you can see here, there is the baseline resonance. This is the resonance that is observed on the surface. What is on the surface? On the surface, I have antibodies. So this is a baseline resonance that is observed. And then I'm adding antigen. When I add antigen, antigens go and bind to antibodies. When antigen binds to antibody, resonance unit increases. So this we call as an association phase. Following an association phase, there is an equilibrium phase or a plateau phase wherein they remain attached. After which this antigen starts coming out. That is called as the dissociation phase. During the dissociation phase, when antigen comes out of antibody, resonance unit decreases. When resonance unit decreases, it goes below the baseline. And it stays below the baseline for some time. And then there is the recovery. When there is a recovery, it comes back to the baseline. Do you understand this? So this is about surface plasmon resonance graph. Point number one about surface plasmon resonance graph is, why do you draw this graph? You draw this graph to understand binding kinetics between two macromolecules like antigen antibody or any protein-protein interaction or DNA-protein interaction. Okay, how was this graph drawn? This graph is drawn with time along x-axis and resonance units along y-axis. Okay, and what is the basic principle that is used? The basic principle is, whenever there is an interaction between two macromolecules on a surface, resonance unit increases. Okay, so how do I draw this graph? I take a surface. On the surface, I absorb a macromolecule. Most of the times, it's an antibody. And then I throw a solution which has got an antigen. Before I throw a solution, there is a baseline resonance unit. This is the baseline resonance unit. When I throw the solution, when antigen interacts with antibody, the resonance unit increases. This is called as an association phase. And then there is the plateau phase. There is the dissociation phase. And then there is the recovery phase. Okay, by checking the slope of all these curves, I will know clearly about the binding kinetics. Okay, so if you're asking me, do we have only this technique to understand binding kinetics between two macromolecules? Answer is no. We also have ELISA. We also have simpler techniques like ELISA. So what is the advantage of doing the surface plasmon resonance graph? If I'm using ELISA, I need to label the antigen or I need to label the antibody. When I label antigen and antibody, the kinetics will vary. I will not know the native binding kinetics. So one advantage of doing a surface plasmon resonance graph is no labeling is required. One advantage. Second advantage is, even if you have very small volume of antigen, this can be done. So limited volume requirement. The volume that is required for surface plasmon resonance graph is very low. Okay. Third is, it gives a detailed information on binding kinetics. So these are the three advantages of surface plasmon resonance graph. Do you all understand this? So all of you repeat this. What are the facts that I told you about surface plasmon resonance graph? It is a graph that is drawn to understand binding kinetics between two macromolecules. It is drawn with time along x-axis and resonance units along y-axis. Simple concept is, whenever there is a binding that is happening between an antigen and antibody, surface resonance increases. What are the phases of this graph? Association, plateau phase, dissociation phase, recovery phase. What are the advantages? Labeling is not required, minimum volume requirement, and it gives detailed information on binding kinetics. Okay. So the next one is a titration curve. Now let's learn about titration curve. Recently they asked you about titration curve. Before we start learning about this, I'm going to tell you about pKa and isoelectric pH. Okay, so I'm going to tell you about pKa and titration curve. What is pKa? pKa is a property of a functional group. So pKa of a functional group is the pH of the medium at which 50% of the groups are ionized. I'm repeating this. What is pKa? pKa is a property of a functional group. For example, if you take amino acid, Amino acids have two functional groups. One is an amino group and an acid group. For each of these functional groups, there are two pKa's. Okay, so pK of a functional group is a pH of the medium at which 50% of the groups are ionized. And around pKa, the functional group exhibits maximum buffering capacity. Around pKa, the functional group exhibits maximum buffering capacity. Because what is an example of a buffer? You must have learnt in your school that buffer is a combination of unionized and ionized forms. Do you remember that? What is a buffer? You would have learnt in your school that buffer is a combination of unionized and ionized forms. Only in this case, to this combination, even when I add a strong acid or a strong alkali, there will be no change in the pH. Right? You remember that, right? And what is pK? I told you pK of a functional group is the pH at which 50% of the groups are ionized, which means remaining 50% of the groups are unionized. So close to pK, you have equal volume of ionized and unionized form. At this point, it can act as an effective buffer. When I say it can act as an effective buffer, I mean to say close to pKa, even if you add a strong acid or a strong alkali, you will observe that there is no change in pH. That's all about pKa. Okay. Now, what is isoelectric pH? Isoelectric pH of a molecule. pK is a property of a functional group. Isoelectric pH is the pH of a molecule at which the net charge carried by the molecule is 0. Do you understand this? What is isoelectric pH? Isoelectric pH of a molecule is the pH at which net charge carried by the particle is 0. When I say net charge is 0, what do you think about its buffering capacity? It will be least. Only when there is something which is charged, it can act as a buffer. Here the net charge is 0. So around isoelectric pH, buffering capacity is very low. Okay. And isoelectric pH is calculated as an average of pK of all the functional groups. It is calculated as an average of pK of all the functional groups. Least buffering capacity. Not just that, close to isoelectric pH, if net charge is 0, what do you think about electrophoretic mobility? A particle will be able to move in an electrical field only as long as it is charged. Here the net charge is 0. So close to isoelectric pH, electrophoretic mobility is nil. Okay. When there is no charge, it means it is not soluble. The solubility is the least. So close to isoelectric pH, the solubility is the least and electrophoretic mobility is also the least. So what are the facts that you need to know about isoelectric pH? Isoelectric pH of a molecule is the pH at which net charge carried by the particle is 0. Because the net charge is 0, here the buffering capacity is minimal. It is least soluble. The electrophoretic mobility is 0. Okay. So these are the facts that you need to know about pKa and isoelectric pH. Now, how is a titration curve drawn? A titration curve is drawn by adding a strong alkali to a solution. Okay. When you add strong alkali, along the x-axis, you add the concentration of alkali that needs to be added. Along y-axis, you draw the changes in pH. So how is a titration curve drawn? The titration curve is drawn with what along x-axis? Along x-axis, concentration of alkali that gets added. Along y-axis, the changes in the pH that is observed. Okay. So this is the titration curve of an amino acid. This is a titration curve of an amino acid. And when I add an alkali, as I add a strong alkali, do you see that initially there is a quick increase in the pH? Whenever I add a strong alkali, initially there is a quick increase in the pH. But after a point, do you see that there is no change in pH even when I'm adding more and more alkali? If I see no change in pH here, It means close to this point, it is acting as an effective buffer. If it acts like an effective buffer here, it means this is one of its pKa. It means it is one of its pKa. For this amino acid, one of its pKa is 2.1. Okay. After this, when I add an alkali, do you see that there is a quick increase in pH? Right here, there is a quick increase in pH. After which, even when I'm adding more and more alkali, there is no change in pH. If there is no change in pH, here it is acting again as an effective buffer. If it acts as an effective buffer here, it means this is another pKa of this molecule. So another pKa of this molecule is what? Another pKa of this molecule is close to 10. Okay, so one pKa is 2.1, other pKa is 10. So this tells you that this molecule has 2 pKa, which means this molecule has got 2 functional groups. pK of one functional group is 2, pK of another functional group is 10. So what is the isoelectric pH of this molecule? I said isoelectric pH is an average, right? It's an average of pK of the 2 functional groups. So it is 2.1 plus 10 by 2, which is 6. So isoelectric pH of this molecule is 6. So do you understand what are the facts that you have learned just from this titration curve? Yeah. So what are the facts that I told you about titration curve? All of you repeat this. How was the titration curve drawn? A titration curve is drawn with what along x-axis? Concentration of alkali that is added is drawn along x-axis. Changes in pH are drawn along y-axis. Then you are looking at the curve. When you look at the curve, initially when you add the alkali, there is a quick change in pH. Beyond a point, even when you add more and more alkali, there is no change in pH. Which means around this point, it's acting as an effective buffer. When will a substance act as an effective buffer? Close to its pKa. So that tells you that this is close to one of its pKa. After a point, there is a quick increase in pH. So that is not its pKa. Then what you see is, again, there is a buffering activity. So that is its second pKa. So whenever you see a flat, right, 2 flat regions, it means there are 2 functional groups. One corresponds to one functional group, the other one corresponds to the other functional group. In that case, how will you calculate isoelectric pH? Average of the 2 pKa. So isoelectric pH of this amino acid is 6. Okay. Yes. So can we quickly go through some MCQs and PYQs based on these graphs? So what are the graphs that we learnt about? Can you recall and tell me? We learnt about Lineweaver-Burke plot, which is frequently asked about. And then I told you about glucose tolerance test that was recently asked. And then I told you about surface plasmon resonance graph. Yeah, we learnt about this unique graph that got asked in INI-CET recently. And then we also learnt now about titration curve. Okay. So look at this, name the graph and mention the application. What is the graph? Surface plasma resonance graph. And what is it used for? Affinity, antigen antibody affinity understanding. Which of the curves represent diabetes? The exact graph that I showed you, right? What represent diabetes? D and E. Okay, start answering please. I'm not going to give you an answer for this. In the given enzyme kinetics graphs, identify the types of inhibitors labeled as A and B. This is A and this is B. In the case of A, what remains normal? Vmax remains normal. If Vmax remains normal, it means it is competitive inhibition, right? And what do you see in B? I'm going to move for you to see this B. In B, what is normal? Km is normal. Normal Km is non-competitive inhibition. So A is competitive inhibition, B is non-competitive inhibition. Yes, very good. Answer A. in the given graph, identify the type of inhibition. So what has happened here? What is not affected? Vmax is unaffected. If Vmax is unaffected, what kind of inhibition is it? Competitive inhibition. So didn't I tell you May 2025 this question was asked? What you're going to appear for is May 2026. So let's pray that this question gets asked and you all get this right. Okay. So in the given glycine titration curve, calculate or identify the pH at which molecules exist in a Zwitter ion form. Zwitter ion form is isoelectric pH. One pK, they marked it 2.2, the other one is 9.6. So it is 11.8 divided by 2 is 6. Do you all want to have a quick break for lunch? Like a working lunch, you can continue, but you can go get your plates ready and come back. Can you come back in 15 minutes? Yes or no? Yeah, let's resume in 15 minutes because I want your utmost attention, right? 100% attention and concentration for you to understand about genetics. Okay, so let's resume in 15 minutes. Now time is 2 o'clock. Come back 2 o'clock, right? Yeah, 2 o'clock. Come back at 2:15. I'm so sorry. Am I audible now? Now, am I audible? Now, am I audible, please? Okay. So I started the session by saying that I want you to be open-minded when you attend this part of the session. I don't want you to approach genetics thinking that genetics is difficult to understand or as genetics is volatile, right? It is neither volatile nor difficult to understand. If you learn the concept first, and then when you start learning to apply it, it will be a cakewalk. And that is how we designed this part of the session. We will be learning all concepts first, and then we will learn applied aspects of genetics. So I want you to approach this part of the session with an open mind, thinking that you will be able to understand this part of the session. Okay, so that is what I told you when I started. Now, this is the first question. The process of gene regulation involves condensation and uncondensation of chromosome. This occurs by binding of a variety of proteins on DNA by charge interactions. At physiological pH, the charge on the DNA is, and I was telling you that DNA has multiple phosphate groups. So DNA is negatively charged, whereas your histones are positively charged. That is why there is an electrostatic attraction between positively charged histones on one hand and negatively charged DNA on the other hand. So that a segment of double-stranded DNA gets wound around histone. This winding of double-stranded DNA around histone is responsible for condensation of chromosome. Do you all understand this? For now, the only fact that you should remember is charges on DNA are negative, charges on histones are positive. Okay, now an introduction to organization. Okay, so I'm going to give an outline on organization, and then I'll tell you very few facts that you need to remember. So the organization starts with a nitrogenous base. We have purines and pyrimidines, right? So we have nitrogenous base, that is the first level. When this nitrogenous base is attached to a sugar, that is called as a nucleoside. And if you want to know which sugar gets attached, I hope you all know this. It is a ribose or a deoxyribose sugar. So all of you repeat this. When a nitrogenous base gets attached to a ribose or a deoxyribose sugar, it becomes a nucleoside. Then this nucleoside becomes a nucleotide. When many such nucleotides get attached, we call it as a polynucleotide chain. So every polynucleotide chain is made up of multiple nucleotide monophosphates. Okay. Then two such polynucleotide chains interact with each other. When two such polynucleotide chains interact with each other, that is called as a double-stranded DNA. Then a long double-stranded DNA gets condensed with the help of proteins. That is called as a chromosome. So what you call as a chromosome with a centromere, a short arm and a long arm is nothing but a long double-stranded DNA. Please remember this. The chromosome which you always draw with a centromere, a short arm and a long arm is nothing but a long double-stranded DNA which has got condensed with the help of proteins. And every chromosome has multiple genes. You know that, right? Every chromosome has multiple genes. Pink color structures that I'm drawing here represent genes. And every gene on transcription, what is the first process that happens here? Transcription. Every gene on transcription gives rise to an mRNA. What is a structure called as mRNA? And every mRNA on translation, what is the next process? The next process is translation. So every mRNA on translation gives rise to a protein. So this is the central dogma. Is this clear, everybody? So all of you repeat this. What is the first level? The first level is a nitrogenous base, purine or a pyrimidine. When a nitrogenous base gets attached to a ribose or a deoxyribose sugar, that is called as a nucleoside. This nucleoside gets attached to a phosphate group to become a nucleotide. When many such nucleotides are linked, we call it as a polynucleotide chain. So be it a DNA or RNA, right? Be it a DNA or RNA, all these polynucleotide chains are made up of nucleotide monophosphates. When two such polynucleotide chains interact with each other, that is called as a double-stranded DNA. When a long double-stranded DNA gets condensed with the help of proteins, that is called as a chromosome. Every chromosome has multiple genes. Every gene on transcription gives rise to mRNA. Every mRNA on translation gives rise to a protein. So this is an outline. Okay. Now I'm going to give you some facts that you'll have to remember. Okay. So let's bite this bullet, right? Let's bite this bullet by memorizing few facts that I'm going to tell you now. Okay. There are 3 facts that I want you to remember. The first fact is the only linkage that is possible in a polynucleotide chain is 3' 5' phosphodiester linkage. Suppose this is a DNA, a long polynucleotide chain DNA. What is the only linkage that is always possible? Please remember this. You are not allowed to change the number. What is the linkage? It is 3' 5' phosphodiester linkage. Point number 1. Point number 2 is the only direction in which a new strand can be synthesized by a DNA polymerase or by an RNA polymerase is 5' 3' direction. So what is the second fact I've told you? The only direction in which a DNA or an RNA polymerase can synthesize a new strand is 5' 3' direction. So whenever they ask you a question, DNA polymerase synthesizes in which direction? Your answer should be 5' 3' direction. And whenever a DNA polymerase synthesizes a new strand in 5' 3' direction, they need a template strand. That template strand has to be anti-parallel, which means the template strand should always be in 3' 5' direction. Yeah, the template strand should always be in which direction? 3' 5' direction. So have you memorized these 3 facts? All of you repeat it along with me. The first fact that I told you is the only linkage that is possible in a polynucleotide chain is 3' 5' phosphodiester linkage. The only direction in which a new strand can be synthesized is 5' 3' direction. So all DNA and RNA polymerases can synthesize a new strand only in 5' 3' direction. If they can synthesize a new strand only in 5' 3' direction, the template strand should be in 3' 5' direction. So whenever they ask you a question, template strand for replication is in which direction? 3' 5'. Template strand for transcription is in which direction? 3' 5'. So these are the 3 facts that you need to know. Okay. Now about structure of double-stranded DNA, which is given by Watson and Crick. So what did Watson and Crick state? According to Watson and Crick, the 2 strands are exactly complementary and anti-parallel. Do you see that here? According to Watson and Crick, the 2 strands are exactly complementary and anti-parallel. What do you mean by complementarity? If there is A on one strand, there should be T on the other strand. If there is G on one strand, there should be C on the other strand. What is being anti-parallel? As I told you, if one strand is in 3' 5' direction, the other strand should be in 5' 3' direction. And the 2 strands are oriented in a ladder-like fashion. Don't you see that this looks like a ladder? So the 2 strands are oriented in a ladder-like fashion. The backbone of the ladder, okay, the backbone of the ladder is shaded as yellow here. The backbone of the ladder is made up of 3' 5' phosphodiester linkages with ribose or deoxyribose sugars. Repeat this. What is the backbone made up of? The backbone is made up of 3' 5' phosphodiester linkages and ribose or deoxyribose sugars. Steps are made up of nitrogenous bases which are linked by hydrogen bonds. There are 2 hydrogen bonds between A and T and 3 hydrogen bonds between G and C. All these facts you need to know. So what are the facts that you need to know about a double-stranded DNA? Watson and Crick stated that the 2 strands are exactly complementary and anti-parallel. They are oriented in a ladder-like fashion. The backbone of the ladder is made up of 3' 5' phosphodiester linkages with ribose or deoxyribose sugars. Steps are made up of nitrogenous bases which are linked by hydrogen bonds. Okay. Now tell me, what happens when you break these hydrogen bonds? Can you answer this? When you break these hydrogen bonds, the double-stranded DNA undergoes unwinding to form 2 single strands. And that is called as unwinding or denaturation. So tell me, how is denaturation brought about? Denaturation or unwinding of a double-stranded DNA is brought about by breaking these hydrogen bonds. Okay. And tell me what happens when you break this linkage. If you break this linkage between the nitrogenous base and the sugar, the backbone is intact. If you break this linkage, the backbone is intact, only the base is lost. Adenine is lost or guanine is lost. Whenever a base is lost, that is called as base excision error. Do you understand this? That's called as base excision error. And this base excision error is the most common error that can happen in a DNA. That happens by breaking the linkage between the base and the sugar. Okay. What happens when you break 3' 5' phosphodiester linkages of both the strands? Whenever you break 3' 5' phosphodiester linkages of both the strands, that is called as double-stranded DNA break. The double-stranded DNA is completely broken. So that's called as double-stranded DNA break. So can you all repeat this? Very good. Excellent. So can you repeat this? What happens when hydrogen bonds are broken? Unwinding or denaturation. What happens when you break the linkage between the base and the sugar? Base excision error. When you break 3' 5' phosphodiester linkage, that causes double-stranded DNA break. That's all about double-stranded DNA. Now about chromosomes. Okay. What is a chromosome? I told you. You have a very long double-stranded DNA, right? You have a very long double-stranded DNA, and this measures a meter long, right? It measures a few meters long, but your nucleus is few microns in diameter. So you cannot pack such a long double-stranded DNA within a nucleus which is so small. To enable package, you have to condense the long double-stranded DNA to form a chromosome. So tell me, what is a chromosome? I told you, one chromosome is one long double-stranded DNA which has got condensed with the help of proteins. Which protein helps in condensation? Histones. What did I tell you about histones? Histones are positively charged. So imagine that this circle represents histone, which is positively charged, and your long double-stranded DNA is negatively charged, so that a segment of double-stranded DNA gets wound around histone. Yeah, a segment of double-stranded DNA gets wound around histone. This string on bead appearance. What is a string and what is the bead here? The string is the double-stranded DNA. Bead is the histone that is present in the center. So this string on bead appearance is called as nucleosomes. Okay, and this helps in condensing a long double-stranded DNA to form a very short chromosome to enable package. Do you understand this? Additional fact about this is, when do you want your chromosomes to be condensed and when do you want your chromosomes to be uncondensed? Whenever my chromosomes need not perform their functions. What are the functions of any chromosome? Any chromosome can do only 2 functions. One is replication, the other one is transcription. Whenever you say with pride that you have 46 chromosomes in your cell, you mean to say that you have 46 double-stranded DNAs. And these 46 chromosomes cannot do any other magic. They can only perform two functions. One is replication, the other one is transcription. And whenever my chromosomes need not perform replication, need not perform transcription, my chromosomes are highly condensed. Okay, they're highly condensed. But whenever my chromosomes have to perform either replication or transcription, you know that for both replication and transcription, there should be unwinding first. For unwinding to be mediated, there should be uncondensation prior to that. So a resting chromosome is condensed, then this condensed chromosome becomes uncondensed. Uncondensed chromosome then undergoes unwinding. After unwinding, there is replication or there is transcription. Okay, that is all about how a chromosome is formed. Okay. Chromatin is a part of chromosome. Both are same. Chromatin, chromosome, all these are same. Okay. So this is about what is a chromosome. Now, what are genes? Can anybody tell me what is a gene? I just now told you. Gene is an older term. Transcription unit is a newer term. Both represent the same. So what is a gene or a transcription unit? A gene or a transcription unit is a segment of a chromosome. Please repeat this. What is a gene or transcription unit? It's a segment of your chromosome which can code for either a protein or for RNA. A gene finally codes for either a protein or an RNA. Within the gene also, you have non-coding sequences. Not just between genes, even within the gene, you have non-coding sequences. And that is why when there is transcription, I told you genes undergo transcription. When genes undergo transcription, the first product that is formed does not only have coding exons, it also has non-coding intervening sequences, otherwise called as introns. That is why the first product of transcription of a gene cannot be called as a functional mRNA. You should call it as a primary transcript. Why am I calling it as a primary transcript? Because it is the first transcript that I have written based on my gene sequence. So the first product is called as primary transcript, or it is called as heteronuclear RNA. Why am I calling it as heteronuclear RNA? Because it is formed in the nucleus. Logical, right? Gene is in the chromosome. Chromosome is in the nucleus. So transcription happens within the nucleus. So the first product of transcription should be called as heteronuclear RNA. It is also called as primary transcript. Then this primary transcript or heteronuclear RNA enters into nucleolus. Right? It enters into nucleolus. In nucleolus, 3 post-transcriptional modifications happen. Why do you call it as post-transcriptional modifications, all of you? Whenever I teach a concept, right, students get jittery and then they feel that they are wasting their time and they drop off. Okay, and those who are staying back, please don't do this. Okay, please don't do this. If you don't understand concept, you will not be able to answer most of the MCQs. Do not get into factual learning mode. Factual learning mode does not help you in answering an MCQ, does not help you in your life as well. Okay, you will have to, you cannot be in a hurry, right? You cannot be in a hurry for something which has to be long lasting. Whatever you are learning today is not just for you to clear any of these exams. It is for you to be able to shine in your future as a good clinician. And that happens only when you understand something. For understanding something, you will have to invest time. It is called as investing time. It's not called as wasting time. Okay, so please put your mind into it and understand this. What are the 3 post-transcriptional modifications? All of you tell me. Why do you call it as post-transcriptional modification? Transcription is over, after that it's getting modified, right? That's why it's called as post-transcriptional modifications. What are the three post-transcriptional modifications? The first one is 7-methyl-guanosine cap gets added to the 5' end. Second is poly-A tail gets added to the 3' end. This is to protect the external surfaces of RNA. It is to protect the ends of RNA. So the 5' end of mRNA is protected with a cap. Which cap is it? 7-methyl-guanosine cap gets added to the 5' end. Poly-A tail gets added to the 3' end. The third post-transcriptional modification is you remove all introns and you join all exons in a process called the splicing. Yeah, you remove all introns, you join all exons in a process called the splicing. After these three post-transcriptional modifications, what do you call it as? You call it as a functional cytoplasmic mRNA. Why do you call it as functional cytoplasmic mRNA? Because here the mRNA leaves the nucleus and it reaches the cytoplasm. What happens when it reaches the cytoplasm? As soon as mRNA has reached the cytoplasm, ribosomes start reading these mRNAs. So tell me, what do these ribosomes do? Ribosomes start reading these mRNA from 5' end to 3' end. What do they read? They read every codon one by one. Ribosome reads every codon one by one. Depending upon the codon that is present on the mRNA, ribosomes are capable of recruiting a complementary anticodon containing tRNA. That tRNA comes along with an amino acid. This is how nucleotide sequences of mRNA get translated as amino acid sequences of a polypeptide chain. So long it was nucleotide sequences. During translation, nucleotide sequences of mRNA get translated as amino acid sequences of a polypeptide chain. So we call this process as translation. Are you clear? So this is about the various steps that happen during transcription and translation. Okay, so I'm going to quickly repeat this because based on this, there are some clinical concepts that you need to understand. Based on that, you will be able to answer a few INI-CET MCQs. Okay, so tell me, what is the gene? Gene or transcriptional unit is the segment of your chromosome which can code for finally a protein or for RNA. Within a gene, you don't only have coding sequences, you also have non-coding intronic sequences. So the immediate product of transcription of a gene is not a functional mRNA. What is it called as? Primary transcript or heteronuclear RNA. Then this primary transcript or heteronuclear RNA enters into nucleolus. In nucleolus, three post-transcriptional modifications happen. What are the three post-transcriptional modifications? 7-methyl-guanosine cap gets added to the 5' end. Poly-A tail gets added to the 3' end. You remove introns, you join exons in a process called as splicing, after which you call it as a functional cytoplasmic mRNA. Because this mRNA leaves the nucleus and it reaches the cytoplasm. In cytoplasm, mRNAs are read by ribosomes. From now on, if you're asked what is the function of ribosome, you should clearly state that ribosome reads the mRNA from 5' end to 3' end. It reads every codon one by one. Depending upon the codon that is present, ribosome recruits a complementary anticodon containing tRNA. That tRNA drags along with it an amino acid. This is how nucleotide sequences of mRNA get translated as amino acid sequences of a polypeptide chain. So we call this process as translation. Okay. Now, what is the clinical concept that you need to understand? Sometimes there is something called as alternative splicing, resulting in diseases. What is alternative splicing? Instead of considering an intron as an intron, in some disorders, introns are falsely considered as exons. Okay, so they get retained during splicing. If an intron gets retained during splicing, the resultant functional mRNA will be longer. Do you understand this? Sometimes an intron is not considered as intron and it is not spliced out. By mistake, it is considered as exon and that does not get spliced out. Okay. And suppose this intron is retained. What happens to the length of the mRNA? The length of the mRNA is longer. It is higher. When it is longer, the functional protein that is formed is also longer. This functional protein will have different function when compared to the actual protein's function. That can result in a disease. Many cancer conditions are brought about because of this. For example, have you heard of BCL? Yeah, what is the function of BCL? Do you know that it is a pro-survivor protein? BCL is a pro-survivor protein or it is anti-apoptotic protein. Because what is the function of BCL? It inhibits Bax. What does Bax do? Bax creates pores in the mitochondria. Right? Actually, Bax creates pores on the mitochondria. Through these pores, cytochrome oxidase can be released and that would cause apoptosis. Yeah, normally Bax creates pores in the mitochondrial membrane through which cytochrome oxidase will be released and that causes apoptosis. Bax is an apoptotic protein. What does BCL do? It's an anti-apoptotic protein. It degrades Bax. Okay. Now, this is necessary for a human being. But sometimes what happens in individuals, one of the introns of BCL is not considered as intron, it is retained. And the length of the BCL mRNA is longer and the length of the protein is longer. That longer protein is called as BCL XL, extra large, right? BCL XL or extra large BCL, its function is more intense. When its function is more intense, it degrades all Bax. There is no apoptosis. It's a pro-survivor protein and that causes lymphomas. Yeah, follicular cell lymphoma. Okay, so this was asked recently. Yeah, what was asked recently? They asked you, I'll show you that MCQ. You will be able to answer it now. So some cancers are caused by alternative splicing, resulting in lengthier mRNA, lengthier protein with different functions, which can increase the survival of the protein. Example is BCL-XL, stands for extra large BCL, wherein introns are not spliced out. These proteins are more intense in degrading Bax. There is no apoptosis. There is more survival that results in follicular cell lymphoma. Okay, so that is one fact that you need to know. Now about chromatin. Okay, before I tell you about chromatin, a quick recap about condensation and uncondensation of chromosome. What did I tell you about condensation of chromosome? When is your chromosome condensed? When your chromosomes need not perform their functions. When your chromosomes are resting, your chromosomes are condensed. When will it undergo uncondensation? Whenever your chromosomes have to perform either replication or transcription. Functional parts of chromosomes are uncondensed. Okay. Now, types of chromatin. There are two types of chromatin, euchromatin and heterochromatin. So, what is euchromatin? Euchromatin is transcriptionally active region of a chromosome. When I say it is transcriptionally active, please answer this in the chat box. Will it be condensed or uncondensed? Active regions are uncondensed. When it is uncondensed, will it stain more densely or less densely? Less densely. So tell me all about euchromatin. Euchromatin is transcriptionally active region of a chromosome. For it to be active, it is uncondensed. It stains less densely. Exactly opposite is heterochromatin. What is heterochromatin? It is transcriptionally inactive regions of a chromosome. When it is inactive to enable package, it is highly condensed. When it is highly condensed, it stains more densely. Okay. Have you all seen G-banded chromosomes? In all your textbooks, have you seen images of karyotyping? Yeah, images of karyotyping, for example, trisomy 21 Down syndrome. You would have seen an image wherein all chromosomes are arranged in a particular order and all chromosomes are duplicated. We have 2 copies of all chromosomes. And for chromosome 21 alone, if you have 3 copies, that is diagnosis of Down syndrome. That is karyotyping image. That karyotyping image is obtained by you staining chromosomes with GM-SA. That is called as G-banded chromosome. And if you look at those images, G-banded chromosomes, in all chromosomes, you see alternating dark bands and light bands. What do dark bands represent? Condensed chromosome, inactive chromosome. What do light bands represent? Uncondensed chromosome, active chromosome. So someone was asking me what is chromatin and what is chromosome, right? Chromatins are regions of chromosome. Some regions are active, some regions are inactive. Okay. Now, what are the 2 types of heterochromatin? One is constitutive heterochromatin. The other one is facultative heterochromatin. Constitutive is something which is inactive always. Right? Constitutive heterochromatin is inactive always. Karthik wants to know about cell cycle. I'll quickly tell you about cell cycle. Please listen to this now. What is constitutive heterochromatin? It is something which is inactive always. Facultative heterochromatin is sometimes active and sometimes inactive. Right? Where in your chromosomes do you see constitutive heterochromatin, something which is inactive always? Centromere and telomeric ends. Right? Centromere and telomeric ends. That is why, irrespective of whichever chromosome you are representing, you always have a central dark region. Why do you represent the central region to be dark always? To denote that it is inactive. Because it is inactive, it is highly condensed. And that is why it is marked as a dark dot. Okay. Similarly, in the telomeric ends, it's always darker. It can be chromosome 1, it can be chromosome 2, it can be chromosome 21, and all these chromosomes terminals are always inactive. So where do you see constitutive heterochromatin? Centromere and in the telomeric ends. Facultative heterochromatin, sometimes active, sometimes inactive. That is female X chromosome. Right? What is it? It's female X chromosome. I hope you all know that somatic cells of all females have 2 X chromosomes. You know that, right? Somatic cells of all females have 2 X chromosomes. One X chromosome is from the father, the other X chromosome is from the mother. And in all somatic cells, one of the 2 X chromosomes is inactivated. Right? One of the 2 X chromosomes is inactivated in all somatic cells. Okay? And that inactivated X chromosome is condensed. Because it is condensed, it stains more densely as bar body. You know, this is used for sex determination. So what is bar body that is used for sex determination? It represents a highly condensed chromosome. Do you understand? It represents a highly condensed chromosome. And we understand that it's heterochromatin because it is condensed, because it is inactive. But why am I saying it's facultative heterochromatin? It is because the X chromosome which is active in one somatic cell is inactive in another somatic cell. Do you get it? In one somatic cell, paternal X chromosome is active. Here it is active. In another somatic cell, paternal X chromosome is inactive. So sometimes it's active, sometimes it's inactive. That is why we call it as random inactivation of X chromosome. So if they ask you what is an example for facultative heterochromatin, your answer should be female X chromosome or bar body. Sometimes it's active, sometimes it is inactive. So are you clear about this? So that is about what is chromatin, what are the types, euchromatin, heterochromatin. 2 types of heterochromatin, constitutive heterochromatin and facultative heterochromatin. Okay. Now coming to epigenetics, right? So there have been so many questions on epigenetics recently. But what is epigenetics? epigenetics represents inheritable, inheritable changes in gene expression not caused by sequence changes. So can you repeat this? What is epigenetics? Epigenetics includes all inheritable changes in gene expression which are not because of sequence changes. How can expression be changed without changing sequence? It is by altering condensation and uncondensation of chromosome. Right? It's by altering condensation and uncondensation of chromosome, because I know when a chromosome is condensed, it is not expressed. When a chromosome is uncondensed, it is expressed. So sometimes what I do is I condense a part of a chromosome which I don't want to be expressed. That is called as gene silencing. So tell me, what is gene silencing? Gene silencing is a process wherein a segment of chromosome is condensed just because I don't want it to be expressed. Right? So how do I condense a segment of chromosome? There are two ways in which I can condense a part of the chromosome and I can silence it. One is methylation of cytidine residues. Methylation of cytidine residues of CG islands. In your entire chromosome, there are many segments which have CG islands. What do I mean by CG islands? These segments have multiple CG sequences. So if I go to those regions and if I methylate these cytidine residues, that region automatically undergoes condensation and that region will not be expressed. That is called as gene silencing. So what is one way of silencing a gene? It is done by methylation of cytidine residues of CG islands. Another way of silencing a gene is histone deacetylation. Another mechanism is histone deacetylation. If you're asking me how does this cause gene silencing? Because didn't I tell you histones are positively charged? And that is why I said it interacts with negatively charged DNA. Okay, but because histones are positively charged, they often undergo random acetylation. Yeah, they often undergo random acetylation. So tell me, what will happen when you allow them to undergo acetylation? They lose their positive charges. When they lose their positive charges, they lose their interaction with DNA and DNA will uncondense. So histone acetylation causes uncondensation of chromosome and that causes gene expression. What if I have a histone deacetylase? If I have a histone deacetylase, what I can do is I can remove all these acetyl groups. I can retain positive charges of histones. I can retain the interaction with DNA. DNA remains condensed. DNA remains silenced. Do you understand this? So can you all tell me what is, this was asked recently, remember? Yeah, this was asked recently. So tell me, what is epigenetics? Epigenetics is inheritable changes in gene expression not caused by sequence changes. The moment you read the definition, you should think to yourself, if it's not because of sequence change, how can I change the gene expression? I can change the gene expression by condensing and uncondensing chromosomes, right? What happens when there is condensation? It is gene silencing. I can bring about gene silencing by two processes. One is methylation of cytidine residues. The other one is histone deacetylation. Because when there is histone deacetylation, histones remain positively charged. They remain interacting with DNA. DNA is condensed. That DNA is not expressed. Okay, that is all about epigenetics. Okay. So now answer this question based on whatever we have learned in the first 15 minutes. There will be many MCQs that you'll be able to answer. So answer this first. Process, the charge on the DNA is, the charge on the DNA is negative charge. Bar body is an example of, it's an example of facultative heterochromatin. I'm happy that dots are getting connected, Palash. I don't know if I'm spelling it out right. This gives me happiness. This is what I want to hear from students. Okay. I don't like when students just memorize it. So this is an INI-CET question. Now you will be able to answer it. In rheumatoid arthritis, patient synovial tissue shows increased expression of TNF alpha and interleukin 6, contributing to inflammation. You don't have to know what do these do. TNF alpha, interleukin 6, yes, they are pro-inflammatory cytokines. You don't have to know anything about this. Look at the question that is asked. Which epigenetic change most likely explains this? They're asking you which epigenetic change will cause increased expression. Increased expression of any gene can be done by two ways. One is demethylation of cytidine residues or acetylation of histones. Right? Increased expression is done by demethylation of cytidine residues, which is inhibition of DNA methylation, or by acetylation of histone. So read all these choices. If you activate DNA methylation, you're silencing the DNA. That is not increasing the gene expression. If you activate histone deacetylation, what happens? Yeah, if you cause histone deacetylation, histones remain positively charged, right? And that causes gene silencing. Inhibition of histone acetylation is the same. So what is the right answer? The right answer is choice B, inhibition of DNA methylation. So all of you, I see that around 85 students are here. My question to all of you is, do you understand that even if you know a fact or a concept, if you're not mindful, you might get the question wrong? Okay. And being mindful is a skill that comes only by practice, which means you will have to practice MCQ as much as possible. Starting from today, be it INI-CET your aim, or NEET PG your aim, or FMG is your aim, irrespective of that, starting from today, utilize 75% of the time that you study for practicing MCQs. Only then you will understand what kind of mistakes you commit. Okay, so the answer for this question is choice B. This also you know now. Try answering this. Cancer cells show increased length of a specific RNA transcript of fragment. The length of the mRNA is longer. Okay, the most likely reason for this is, can you start excluding choices? Which choice will you exclude first? I would exclude gene silencing, because what is gene silencing? Gene silencing is reducing gene expression. What is reducing gene expression? From one gene, all along, if you are getting 100 mRNAs in gene silencing, one gene will start producing only 10 mRNAs. This is called as gene silencing. Okay, you're only reducing the number of mRNA. You cannot reduce the length, or you cannot increase the length. So it is about length of mRNA, that is not gene silencing. What is gene amplification? Gene amplification is so long a gene was giving rise to 10 mRNAs. In gene amplification, a gene will start giving rise to 100 mRNAs. Increasing the number of mRNA that you get from a gene is called as gene amplification. That does not increase the length of mRNA. Here the question is about length. How will you be able to change the length? Only by alternative RNA splicing. Okay. So the answer is choice B. Happy to know, Karthik. So I told you, right, BCL, XL, extra large BCL causes follicular cell lymphoma. That's an example. So this is a very lengthy MCQ. Okay, I want everybody's focus here, because this MCQ is about PCR, and INI-CET has shown favoritism towards PCR at multiple levels. Okay, so we are going to learn all about PCR now. Watch this. A person is working on finding out polymorphisms of albumin gene. He wants a fragment of albumin gene which includes between the 5th and the 9th exon of the gene. He knows that human chromosomes can be unwound at 95°. Denaturation happens at 95°. He constructed two primers. The melting temperature of forward primer is 64°. That of the reverse primer is 60°. He uses Bacillus-Smithy DNA polymerase enzyme. The elongation step temperature that you would use for this setup is, okay, I see that many of you are answering it as 72°. It is not 72°. Had they told you he uses Thermus aquaticus DNA polymerase, right? Had he told that he uses Thermus aquaticus DNA polymerase, then the answer is 72°. So the entire clue lies here. He is not using Thermus aquaticus. It is Bacillus-Smithy DNA polymerase, for which the answer is 60°. Let me first tell you the answer for this question and then I'll explain it to you. The answer is 60°. And the explanation is all about PCR. Okay. So what is PCR or polymerase chain reaction? PCR or polymerase chain reaction is an amplification technique. What do I mean by amplification technique? Using PCR from one copy of double-stranded DNA, I aim at getting multiple copies. So what is PCR used for? PCR is used for amplifying the number of copies. So it's an amplification process. Okay, but I'm going to add more to it. It is an in vitro amplification. That we know, right? In PCR, are you amplifying inside a cell? No, you are amplifying outside a cell in a test tube, PCR tube. So it is not inside a cell, it's outside a cell. So it's an in vitro amplification. And in PCR, you don't randomly amplify something. In PCR, you amplify a specific fragment of DNA. So if you're asked to define PCR, your answer should be, it's an in vitro amplification of a specific fragment of DNA. How do I amplify a specific fragment of DNA or a desired fragment of DNA? That is made possible by choosing specific primers. How do I choose primers? I choose primers in such a way that they are complementary only to the flanking sequences of the desired fragment. Okay. First of all, do you know that when I say it's an amplification process, it is a replication process, right? From one copy of double-stranded DNA, if I want multiple copies of double-stranded DNA, it means I'm going to replicate the DNA multiple times. When you know it's a replication process, you know you need a DNA polymerase enzyme for this. Okay. And do you know that all DNA polymerases need a primer? You know that all DNA polymerases need a primer. So PCR also needs a primer. But in PCR, you're not going to use any random primer. You use specific primers. How do you choose specific primers? You choose specific primers in such a way that they are complementary only to the flanking or the terminal sequences of the desired fragment. What do I mean by that? Do you remember in the question they said that the scientist is working on a polymorphism between 5th and the 9th exon of albumin gene? That was the question. Okay. Suppose these two blue lines represent the chromosome in which you have albumin gene. The two blue lines represent the chromosome in which you have albumin gene. Okay. Red line represents albumin gene. Within this red line, suppose this green line represents the segment of albumin gene between 5th and the 9th exon. So what I want is, I want multiple copies of only the green fragment. How will I get the green fragment? By choosing primers. How do you choose primers? I'm going to show you primers in pink color. I choose primers in such a way that these primers are complementary only to the flanking or the terminal sequences of the desired fragment. So my primer goes and hybridizes only here. When my PCR amplifies, I will get only this fragment. Yeah, by PCR I get only this fragment that I want. So how do I make this possible? I make this possible by constructing specific primers which are complementary to by choosing specific primers which are complementary to flanking sequences of the desired fragment. So all of you tell me, what is PCR? PCR is in vitro amplification of a desired fragment of DNA. Okay. Now about steps of PCR. Okay, I want you to follow the steps of PCR because that was also asked recently. I want you to follow the steps of PCR, imagining that you're working on polymorphisms of albumin gene between the 5th and the 9th exon. And just imagine that these two lines that you see in this slide represent the entire chromosome in which you have the albumin gene. And the red lines here, yeah, the red fragments here represent exon 5th and the 9th fragment. How will you get exactly what you want? By subjecting this DNA to PCR. And then PCR, which is a replication process, you know, for any replication, first step is unwinding, right? First step is unwinding. So can you see that in the first step, the double-stranded DNA is unwound to form two single strands. This is done by breaking these hydrogen bonds. And breaking hydrogen bonds happen at higher temperature. So if you're asked what is the first step of PCR, your answer should be unwinding or denaturation. First step of PCR is unwinding or denaturation, and this denaturation should be carried out at a very high temperature of 94 or 95 degree. Okay, after denaturation or unwinding, in the next few steps, my DNA polymerase is going to elongate new strands. But I know for my DNA polymerase to elongate new strands, the enzyme needs primer. So in the next step, I'm going to add primers, and these primers are going to anneal to the flanking sequences. Can you see that here? I've added primers, and these primers have annealed to the flanking sequences of the desired fragment. So what do you call this step as? Annealing step. Why do you call it as annealing step? Because primers are annealing to the flanking sequences. And this annealing step should be carried out at an optimum temperature of 5 degrees less than the melting temperature of your primers. What should be the annealing temperature? The annealing temperature should be 5 degrees less than the melting temperature of your primers. For example, if melting temperature of one primer was 57 degree and the melting temperature of the other primer was say 59 degree, can you tell me what is the average? Average of 57 and 59 is 58 degree. 5 degrees less than 58 is 53 degree. So for this example, what should be the annealing temperature? 53 degree. Otherwise, it's variable. It varies based on the it varies based on the melting temperature of the primers that are used. Now you should ask me, why should it be 5 degrees less than the melting temperature? It's because if it's 5 degrees more than the melting temperature of primers, then the primers will not anneal. They keep melting. They keep moving away. Okay. What if it's 2 less than the melting temperature of primers? If the annealing temperature is 2 less than the melting temperature of primers, then the primers go and anneal somewhere else. Okay. Because annealing is based on Watson and Crick base pairing rules. What are Watson and Crick base pairing rules? A should hybridize with T, G should hybridize with C. These Watson and Crick base pairing rules are followed only in optimum temperature. If you reduce the temperature too much, A would hybridize with C, T would hybridize with G. With great difficulty, with great caution, you constructed primers in such a way that these primers anneal only to the flanking sequences based on Watson and Crick base pairing rules. So if you reduce the temperature too much, if they don't follow Watson and Crick base pairing rules, your primers will go and anneal somewhere else. And you would get something which you don't want. To avoid this, to get exactly what you want. Do you understand this? To get exactly what you want, annealing temperature has to be optimal. It should be neither too high nor too low. It has to be 5 degrees less than the melting temperature of the primers that you have constructed. Okay. Now, after annealing, in the next step, your DNA polymerase is going to elongate new strands. So what is the next step called as? The next step is called as elongation step. And for this elongation step, I need a thermostable DNA polymerase. Why do I need a thermostable DNA polymerase? Because the DNA polymerase that I use in PCR should be capable of withstanding cyclical rise of temperature to 94 or 95 degree. Whatever I'm showing you in this slide, denaturation, annealing, elongation, these three are 3 steps of one cycle of PCR. After this one cycle, the double-stranded DNAs again go through denaturation, annealing, elongation. The products again go through denaturation, annealing, elongation. So the DNA polymerase that you're using in PCR should be capable of withstanding cyclical rise of temperature to 94 or 95 degree. So I need a thermostable DNA polymerase. That is why I've extracted DNA polymerase from an organism which lives in hot springs. If an organism can thrive in hot spring, it means these organisms have an enzyme which is thermostable. The organism is Thermus aquaticus. Right? The organism is Thermus aquaticus and the DNA polymerase is Taq DNA polymerase. Do you understand this? And the optimum temperature that is required for Taq DNA polymerase to elongate new strand is 72 degree. That is why elongation is carried out at 72 degrees. Do you understand this? So can you summarize and tell me, all of you, those who are watching this, please tell me what are the 3 steps of every cycle of PCR. Every cycle of PCR goes through denaturation, annealing, elongation. Tell me the temperature. Denaturation is carried out at 94 or 95 degree. Annealing temperature is 5 degrees less than the melting temperature of your primers. Elongation is at 72 degree. Okay. And the enzyme that is used for polymerase chain reaction is Taq DNA polymerase or Thermus aquaticus DNA polymerase. And the machine that is used for this PCR is called as thermocycler. All of you tell me what is the machine that is used? Thermocycler, because the machine cycles between temperatures. Okay. And what we understood is during COVID pandemic, we understood even if we have the money power to deploy as many thermocyclers as possible in the periphery, finding a person with technical expertise to handle this machine is going to be always difficult. And that is why we cannot always be dependent on this conventional PCR technique. What I've told you here is conventional PCR. We need an isothermal amplification technique, right? Is this isothermal? No. Why is it not isothermal? You should keep cycling between temperatures. So this is not isothermal, but we need an isothermal amplification technique, and that is called as LAMP assay. What is LAMP assay? Loop mediated amplification assay. In isothermal amplification, as the name indicates, denaturation, annealing, elongation, all these are carried out at 60 degree. Do you understand this? All these are carried out at 60 degree, and that is possible only because in LAMP assay we don't use Taq DNA polymerase. We extract DNA polymerase from an organism called as Bacillus stearothermophilus. Please look at this slide. Use your visual memory cue. Please look at it and memorize it. I also know that you have heard of this organism before, right? Have you heard of bioindicator used for autoclave? What is the bioindicator used for autoclave? Bacillus stearothermophilus. Right? 1 second. Yeah. Bacillus stearothermophilus. And the enzyme that is extracted from Bacillus stearothermophilus is BST DNA polymerase. Or you can use another organism, Bacillus smithii. If you extract it from Bacillus smithii, it is called as BSM DNA polymerase. And both BST DNA polymerase and BSM DNA polymerase, they have very strong strand invasion ability. Even at 60 degree, they can invade the DNA strand, they can elongate the strand. So denaturation, annealing, elongation, all these are carried out at 60 degree. Please remember it. In LAMP assay, it is carried out at 60 degree. For this, you don't need thermocycler, just an incubator would do. For this, you don't need anybody with technical expertise. Anybody who can make a tea can use LAMP assay, right? Anybody who can make a tea can use LAMP assay. So simplified the technique is. So that is all about LAMP assay. All of you tell me, what about LAMP assay? Loop mediated amplification assay, isothermal amplification technique. The temperature is 60 degree. DNA polymerase used is BST DNA polymerase or BSM DNA polymerase. Now do you understand the answer for this question? Yeah. What is given here? Bacillus smithii DNA polymerase. So whatever may be these numbers, all these numbers are misleading numbers, distracting numbers. I know that many of you took an average of 50, 60 and 64, calculated as 62, and then you are looking for 62 as an answer, chose it as choice A. All these are distractors. Okay, when you use Bacillus smithii DNA polymerase, all these steps are carried out at just 60 degree. Okay. Answer this, please. Now it's evident, right? INI-CET November 2025. Steps in PCR are denaturation, annealing, and elongation or extension. And some of the students came back and asked, is hybridization a part of PCR? No. In PCR, we don't hybridize anything. When do you hybridize? Hybridization is a part of blotting technique. What is hybridization? Allowing one nucleic acid to hybridize with another nucleic acid. Hybridization is not a part of PCR. It is denaturation, annealing, and elongation. I loved this question when I saw this in a paper. Okay. So can you think and tell me, after how many cycles of PCR, this is also an INI-CET May 2025 question, after how many cycles of PCR are we expected to have half the number of copies as found after 26 cycles? What is answer? 25 cycles, right? Because you know, in every cycle, in the first cycle, one copy of double-stranded DNA would become 2 copies. In the next cycle, from 2 copies, you would get 4 copies. So in every cycle, it gets doubled. Do you understand? In every cycle, it is doubled. They're asking you, when will it be half? The cycle before that, it will be half, right? So in 26 cycles, if you have n number of copies, n by 2, you will get in 25th cycle. So what is the right answer here? The right answer here is choice C. Many answer it as 13. No. Okay. It is in the 25th cycle when you have half the number of copies. A patient who has been diagnosed with multiple colonic polyps and carcinoma with a positive family history of HNPCC has a defect of which of the following repair mechanism? I've always given you a clue here, right? HNPCC, double C, double M. HNPCC, double C, double M. What is double M? Mismatch repair defect. Okay, so what is the right answer here? The right answer here is mismatch repair. But can we quickly have a recap on DNA repair mechanisms? Yeah, because there are many questions which are asked in this topic. What are the 4 repair mechanisms? The most common error is base excision error. So the most common repair mechanism is base excision repair mechanism. followed by what I told you about now, mismatch repair. The third one is nucleotide excision repair. The last one is double-stranded DNA break repair. Have you memorized it? Please memorize this. You have no other go but to do this. What are the 4 repair mechanisms that can happen in a DNA? The first one is base excision repair. Second is mismatch repair. The third one is nucleotide excision repair. Finally, double-stranded DNA break repair. Because it's a rapid revision video, I'm not going to get into the repair mechanism as such. I'm going to tell you the diseases caused by defects of these repair mechanisms. Okay. Mismatch repair defects. Mismatch repair defect causes HNPCC or Lynch syndrome. Right? HNPCC or Lynch syndrome. Hereditary non-polyposis colon cancer. The next is nucleotide excision repair. The term has gotten X. Defect causes X. Xeroderma pigmentosa. Okay, nucleotide excision repair defect causes Xeroderma pigmentosa. Also remember cocaine syndrome. Okay, so remember these 2 conditions. Nucleotide excision repair defect causes Xeroderma pigmentosa, characterized by hypersensitivity to UV light, increased propensity to develop skin malignancies, and cocaine syndrome. Let's learn about double-stranded DNA break repair a bit, not in detail, a bit that's needed for you to answer MCQs. Okay. So double-stranded DNA break happens in the presence of ionizing radiation like gamma rays. In the presence of ionizing radiation, we were all worried about nuclear war, right? So ionizing radiation is what we are worried about in that case, because when there is ionizing radiation, it can cause double-stranded DNA break. And whenever there is double-stranded DNA break, repair can be done in 2 ways. One is non-homologous enjoining. The other one is homologous DNA repair. So tell me, what are the 2 terms? Please memorize it. The 2 ways by which double-stranded DNA break can be repaired are now non-homologous enjoining and homologous DNA repair. All that I want you to know about non-homologous enjoining is it's a suboptimal way of repairing it, because in non-homologous enjoining, there is loss of nucleotide sequences. During this repair mechanism, there is loss of nucleotide sequences always. And you know, when there is loss of nucleotide sequences, that can cause a deleterious deletion mutation. In MCQ, if they ask you which is the most dangerous of all nucleotide sequence changes, your answer should be deletion. Deletion is the most dangerous. That is possible whenever there is non-homologous enjoining. So which is a better way of repairing double-stranded DNA break? It is homologous DNA repair. Because in homologous DNA repair, what we do is, suppose one copy of chromosome 1, suppose paternal copy of chromosome 1 has undergone double-stranded DNA break. All that you need to do is, maternal copy of chromosome 1 should be aligned with this. Physically, you will have to align both the copies. That is enough, right? The repair will be done by your DNA polymerases. Your DNA polymerases will look at the normal sequence here. They substitute the nucleotides that are missing and they link it. So which is a better repair mechanism? Homologous DNA. Do you understand homologous DNA repair? Why is it called as homologous DNA repair? You're aligning homologous DNA sequences. So this is a better repair mechanism. Okay. So these are the facts that you need to know about double-stranded DNA break repair. Whenever there is a defect of double-stranded DNA break, there are disorders that can be caused, diseases that can be caused. Those diseases can be remembered using a mnemonic. What is a mnemonic? ABF. What does ABF stand for? Ataxia telangiectasia, Bloom syndrome, Fanconi's anemia. Okay, defect of double-stranded DNA break repair can cause ABF disorders, ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. To make it more complicated, if they ask you which of these is caused by a defect of non-homologous end joining, non-homologous end joining defect causes ataxia telangiectasia and severe combined immunodeficiency. Okay, non-homologous end joining defect causes what? Ataxia telangiectasia and severe combined immunodeficiency. Whereas homologous DNA repair defect causes 3 disorders. What are the 3 disorders? Bloom syndrome, Fanconi's anemia, and human breast and ovarian cancer. One second. Out of topic question. I've studied well, but my question practice is less. I think, ma'am, if I practice lots of questions from now onwards, can I increase 25 to 30 corrects in INI-CET? Yes. Yeah, it's a big yes. Please practice MCQs. That is the best way for you to increase the number of rights. Okay, be it for INI-CET or FMG or NEET PG. That's why I said 75% of your time that you spend in learning or studying should be spent on working out MCQs. Okay, so human breast and ovarian cancer. So have you heard of BRCA1 mutation? Yeah, BRCA1 is a protein that is involved in homologous DNA repair, and defect of BRCA1, you know, causes a person to be susceptible to develop breast cancer, ovarian cancer, and colon cancer. That's why defect of homologous DNA repair causes Bloom syndrome, Fanconi's anemia, and human breast and ovarian cancer. Okay. Yeah. So that's all about DNA repair defects. Okay. So tell me the answer here. We know the answer already. Double C is double M, mismatch repair defects. Please read this. A woman with a strong family history. So not just for this MCQ, in the exam, whenever you see an MCQ, approach those MCQs with an open mind. Many a times a logical thinking and logical reasoning out will help you to exclude choices. Not when you shut your mind down saying, I've never read genetics, I'm not going to be able to answer this question. Okay, example is this question. Read this. A woman with a strong family history of breast and ovarian cancer is being evaluated for BRCA1 and BRCA2 mutations. Which of the following is the most appropriate test to detect multiple mutations at different codons in these genes? Mutation detection in the gene level, right? Where is gene? Gene is in the chromosome. What is chromosome? DNA. Right? So they're asking you, how will you find out DNA sequence alterations? Isn't that the question? What is the question? The question is about how will you find out DNA sequence alteration? Now look at these choices. Start from choice A. What is choice A? Quantitative PCR. qPCR is quantitative PCR. Will quantitative PCR tell you about sequence changes or about quantity changes? It will tell you only about quantity changes, wherein expression level alteration can be studied. It's not going to tell you about sequence changes. Do you understand this? So quantitative PCR cannot be used. Choice B. RT-PCR is reverse transcriptase PCR. When will you use reverse transcriptase PCR? Only when the nucleic acid of interest to you is an RNA. Right? Only when the nucleic acid of interest to you is an RNA. All of you type in the chat box, what is transcription? Transcription is DNA to RNA. What is reverse transcription? RNA to DNA. Whenever the nucleic acid of interest to you is an RNA, RNA cannot be amplified. RNA cannot be RNA cannot be copied, RNA cannot be quantified. So whenever the nucleic acid of interest to you is an RNA, before you can subject to amplification, before you can subject it to sequencing, you should first convert RNA to DNA. That is done by reverse transcriptase PCR. That is used only when you're trying to understand about RNA. Here you're trying to learn about DNA. So this is not the right answer. Okay, northern blot. Again, you know, southern blot is for DNA, northern blot is for RNA. They've also given you it is RNA. I'm not interested in RNA here, I'm interested in DNA. So what is the right answer, all of you? Shiva Shankaran, highly possible. I'm not your staff. Yeah. I might have been your faculty at Madras Medical College because I was there at Madras Medical College from 2006 to 2016. So it's a high probability that you met me there. Okay. So exome sequencing is the right answer. Okay. What is exome sequencing? Sequencing the exome. Okay. So the right answer here is choice D. But I'm going to help you understand more about RT-PCR, reverse transcriptase PCR, real-time PCR now. Okay. First, let's try to understand what is gene expression. What do you mean by gene expression? What is it? Normal gene expression is wherein genes on transcription give rise to mRNAs. mRNAs on translation giving rise to protein. This is called as gene expression, right? What is gene expression? Gene finally forming a protein is called as gene expression. So gene expression involves transcription and translation. Now, if this is normal gene expression, what causes disease, right? A disease can be caused by gene sequence alterations. A disease can be caused by gene sequence alteration because whenever there is a gene sequence change, correspondingly there can be mRNA sequence change or there can be difference in the level of mRNA expression. Yes or no? These are the two possibilities. Whenever there is a change in the gene sequence, it can either cause a change in the mRNA sequence or it can cause a difference in the mRNA expression levels. Accordingly, what will happen to protein? Protein sequence changes or protein expression changes. In either case, whenever there is protein sequence change or protein expression change, that results in a disease. So this is how a disease happens in a person. It starts from gene sequence alteration, resulting in mRNA sequence alteration or mRNA expression alteration, resulting in protein sequence change or protein expression alteration. So you can detect a disease at all these three levels. To detect a disease at the gene level, you have to sequence the gene. That is called as exome sequencing. At the gene level, what is a technique that is used to check sequence alteration? It's called as exome sequencing. At the mRNA level, if you're trying to understand if there is any mRNA sequence alteration, that can be done by northern blot. Because what do you do in northern blot? In northern blot, you use a probe. The probe is based on a particular sequence. It is based on normal sequences. If this mRNA probe goes and binds to mRNA, the mRNA is normal. There is no sequence change. If the probe does not go and bind to the mRNA, there is a sequence change that can result in a disease. So mRNA sequence changes can be learnt by northern blot. mRNA expression alteration. What do I mean by mRNA expression alteration? As I told you previously, normally if one gene gives rise to 100 mRNAs, in a disease, the gene can start giving rise to 10 mRNAs. That can result in a disease. This is called as down regulation of gene expression. Or sometimes genes start giving rise to 1000 mRNAs. That can also cause a disease. So expression alteration is changes in the number of mRNAs that are available. How will you know that there is a difference in the number of mRNA that is available? By quantifying mRNA. How can you quantify mRNA? By reverse transcriptase PCR followed by real-time PCR. Right? By reverse transcriptase PCR followed by real-time PCR. So it is time that you learn differences between reverse transcriptase PCR and real-time PCR. Let me tell you those differences first. Okay. So RT-PCR for all practical purposes can be abbreviated only as reverse transcriptase PCR. Okay. What is qPCR? qPCR is abbreviated as quantitative PCR. Quantitative PCR is also called as real-time PCR. So don't get confused between reverse transcriptase PCR and real-time PCR. RT-PCR is always reverse transcriptase PCR. qPCR is quantitative PCR or real-time PCR. What are the uses? As I told you, reverse transcriptase PCR is used whenever the nucleic acid of interest to you. Whenever the nucleic acid of interest to you is an RNA. Okay. When will you use quantitative PCR or real-time PCR? Whenever you have to quantify any nucleic acid. You can quantify RNA, you can quantify DNA using quantitative PCR. It is used only for quantification. That is the basic difference between reverse transcriptase PCR and real-time PCR. So practical application wise, what do you use reverse transcriptase PCR for? Example is, suppose you are trying to detect a virus. You are trying to detect an RNA virus. SARS-CoV-2 diagnosis. From the swab sample that is collected, you extract RNA of SARS-CoV-2. And then to find out if it's SARS-CoV-2, first convert the RNA to DNA, for which you'll have to subject the RNA that is extracted to reverse transcriptase PCR. So one practical application of reverse transcriptase PCR is finding out RNA viruses. Okay. Or it is used to find out whenever there is mRNA expression alteration causing a disease. Just now I told you gene mRNA expression alteration. If I'm trying to find out from the tissue, I can extract mRNA. I cannot directly quantify mRNA. I first convert this mRNA to DNA using reverse transcriptase PCR. So these are the two applications of reverse transcriptase PCR. When will I use quantitative PCR or real-time PCR? Whenever I have to quantify nucleic acid, right? Example, to assess any pathogen load, any infectious disease load, not only viral load, bacterial load, fungal load, because I know the number of nucleic acid present in the sample will be directly proportional to the number of viruses present in the sample. So I can count the number of nucleic acid, I can relate it to the viral load or to the bacterial load or to the fungal load. So for this, to assess pathogen load in an infection, I can use quantitative PCR. I can also use quantitative PCR to understand gene expression alteration causing a disease. So the take-home message for all of you is, if I'm trying to understand about viral load, if it's an RNA viral load, first I convert RNA to DNA using reverse transcriptase PCR, and then I quantify DNA using quantitative PCR. If I'm trying to understand gene expression alteration, I extract RNA from tissue, I subject the RNA to reverse transcriptase PCR, convert it into DNA, and then I subject it to quantitative PCR, quantify the DNA. So in both the cases, it is first reverse transcriptase PCR followed by quantitative PCR. Do you all understand this? Yeah. So that is about reverse transcriptase PCR and real-time PCR. So whenever I'm trying to understand if there is any gene expression alteration, first it is reverse transcriptase PCR followed by real-time PCR. And to find out if there is any protein sequence changes, we have to subject it to Western blot. Right? To find out if there is any protein sequence alteration, we have to subject the protein to Western blot. So it is time that you learn about all these nomenclatures related to blotting techniques. Tell me, what is Southern blot used for? Southern blot is for DNA identification. Northern blot is used for RNA identification. Western blot is used for protein identification. How do we remember this? I know you all know the shortcuts. For those of you who don't know the shortcut, South Indians eat dosa. Right? South Indians eat dosa. So Southern blot is for DNA. North Indians eat roti. So Northern blot is for RNA. Westerners eat pizza. So Western blot is for protein identification. Okay. Eastern blot is for protein modifications. Eastern blot is used to find out or learn about protein modifications. You must have learned about co-translational modifications and post-translational modifications, right? So those modifications can be learned using Eastern blot. Southwestern blot is for DNA protein interaction, right? Southwestern blot is used to learn about DNA protein interaction. Northwestern blot is for RNA protein interaction. Far western blot is for protein-protein interaction. Are you clear? Yeah. So southern blot is for DNA, northern blot is for RNA, western blot is for protein. Eastern blot is for protein modification study. Southwestern blot is for protein DNA interaction. Northwestern blot for RNA protein interaction. Far western blot is for protein-protein interaction. Okay. So the answer is evident now. If it's at the gene level, it's at DNA level. It is not quantitative PCR. It is not real-time PCR. It's not northern blot. It is exome sequencing. A very simple question. Please try answering this. Give me a minute. So what is the right answer? Southern blot is for DNA, northern blot is for RNA, and western blot is for protein. Choice D. miRNA is used for what? miRNA is microRNA. It's a precursor of siRNA or small interference RNA. And small interference RNA causes gene knockdown. Okay, small interference RNA causes gene knockdown. So the answer is choice A. But let me explain this to you, because in this MCQ, right, as we discuss about this MCQ, I would also be telling about knockout and knock-in. Okay. So what is siRNA? It's small interference RNA that interferes with gene expression. Right? It interferes with gene expression. What is gene expression? I told you, just now I told you, in gene expression, genes on transcription give rise to mRNA. mRNA on translation give rise to protein. This is called as gene expression. So when I say small interference RNAs interfere with gene expression, I have to tell you whether it interferes at the transcription level or does it interfere at the translation level. The answer is it interferes at the translation level. Okay. How does it interfere at the translation level? It's because all these siRNAs, like any other RNA, they have their own sequences. And suppose one of these siRNAs find complementary sequence on any of the fully formed mRNAs. Right? Suppose an siRNA finds complementary sequence on any of the fully formed mRNA, they go and hybridize with those mRNAs in the 3' untranslated region. Right? What do you mean by 3' untranslated region? I've told you this multiple times. If you take any mRNA, this mRNA has first a 5' untranslated region, after which you see the AUG codon. Because you know AUG codon is the initiation codon for every mRNA. Only after an AUG codon is identified that mRNA translation even begins. So before AUG codon, any sequence that is present is not going to be translated. Those sequences are called as 5' untranslated regions. Okay. And then there is a stop codon. Between AUG codon and stop codon, everything gets translated. But after stop codon, nothing gets translated. So any sequence that is present after stop codon is called as 3' untranslated region. So what is the take-home message for all of you here? Any mRNA has a 5' untranslated region, translated region, and 3' untranslated region. Where does siRNA hybridize? siRNA hybridizes to the 3' untranslated region of mRNA. Not knowing this, a ribosome will be translating this mRNA. Right? Ribosomes start translating this mRNA. When they come close to the terminal, they observe that there is a complex super secondary structure that is already formed. Right? When the ribosome is translating this mRNA towards the terminal, they observe that there is a complex super secondary structure that is formed in the terminal. That is taken as a signal by this ribosome that this mRNA should no longer be translated. Okay, so what do these ribosomes do? These ribosomes recruit exonucleases. These exonucleases break down this mRNA. Once the mRNA is fragmented, these mRNAs can no longer be translated, because remember, at any point in time, one mRNA will be translated by multiple ribosomes. Do you understand this? At any point in time, if you take this as an mRNA, this mRNA will be translated by multiple ribosomes. So from one mRNA, usually you get multiple proteins. But with the first ribosome, when it comes close to the terminal, it senses that there is a complex super secondary structure that is taken as a signal by this ribosome that this mRNA should be fragmented. Once this mRNA is fragmented, the ribosomes which are coming behind it cannot translate it. So long, if this gene was giving rise to 100 proteins, so long, if this gene was giving rise to 100 proteins, following siRNA's interaction, this gene will start producing only 1 or 2 proteins. This is called as down regulation of gene expression. Because there is down regulation of gene expression, that is called as knockdown. Do you understand this? That is called as knockdown. So all of you tell me, what does siRNA do? This has been repeatedly asked in INI-CET, NEET PG as well as in FMG. So what does siRNA do? siRNA, or small interference RNAs, interfere with gene expression at translation level. How do they interfere? These siRNAs have their own sequences. If they find complementary sequences on any of the mRNAs that are formed, they hybridize with those mRNAs in the 3' untranslated region. And that allows the mRNAs to be fragmented. That mRNA is no longer translated. So there is down regulation of gene expression that is called as gene knockdown. Okay. So to summarize about gene knockdown, knockout and knock-in. Gene knockdown is down regulation of gene expression that is caused by siRNA. What is knockout and knock-in? Knockout and knock-in are two ways by which genes can be edited. Do you understand this? Knockout and knock-in are two ways by which genes can be edited. It is gene editing mechanism. What is knockout? Knockout is removal of the defective gene. What is knock-in? Replacing the defective gene with normal gene is knock-in. Which is better? I am not happy with just removing the defective gene. I want a normal gene. So which is better? Knock-in is always better, wherein we replace the defective gene with a normal gene. Knockout and knock-in both are mediated by CRISPR-mediated gene editing. Knockout and knock-in are mediated by CRISPR-mediated gene editing. Here you should know that CRISPR system has got a Cas enzyme. CRISPR system has got a Cas enzyme. Cas enzyme brings about double-stranded DNA break. Okay, and you know, following double-stranded DNA break, repair can be done by two ways. One is non-homologous end joining. The other one is homologous DNA repair. Didn't I tell you about this 15 minutes back? Whenever there is double-stranded DNA break, the repair is done by either non-homologous end joining or by homologous DNA repair. I said in non-homologous end joining, there is loss of nucleotide sequences. When there is only loss of nucleotide sequences, it means I'm removing the defective gene. If it's removal of the defective gene, it is called as knockout. Right? If it's removal of the defective gene, it is knockout. In homologous DNA repair, I said there is no loss of nucleotide sequences. You're removing the defective gene with a normal gene. That is called as knock-in. So whenever there is CRISPR-mediated gene editing, if there is non-homologous end joining, that causes knockout. Following CRISPR-mediated gene editing, if there is non-homologous end joining, that results in knockout. Whenever there is homologous DNA repair, that causes knock-in. Do you get it? So this is about knockdown, knockout, and knock-in. What are the facts that you need to memorize about these terms? Knockdown is done by siRNA. Knockout and knock-in are done by CRISPR-mediated gene editing. CRISPR, there is a double-stranded DNA break, following which if there is non-homologous end joining, that causes knockout. If there is homologous DNA repair, that causes knock-in. Okay, so that is about these techniques. So miRNA is used for what? Knockdown. Okay. miRNA binds to INI-CET question. Where does miRNA bind? 3' untranslated region. Following CRISPR-mediated gene mix, which of the following can result in gene knock-in? What is answer? Knock-in is by homologous DNA repair. Another INI-CET question. So this will be the last question for genetics. And probably after this, I'll give you 10 minutes break and then we'll learn metabolism. Will that work? So a 21-year-old man wants molecular diagnosis of sickle cell anemia, as 3 of his maternal cousins are diagnosed with this condition. The intern shows few steps involved in molecular diagnostics in a jumbled way. Help him choose appropriate steps and arrange in the right sequence. Okay. So when it comes to sickle cell anemia diagnosis, it is diagnosing known mutation site. Sickle cell anemia diagnosis, diagnosing a known mutation site. Why am I calling it as a known mutation? All over the world, sickle cell anemia is caused by point mutation of the 6th codon of beta globin gene. Right? Do I say it is caused by point mutation of 6th codon only in Asia? It is caused by a splice mutation somewhere else. It is caused by intron mutation somewhere else. Do we have such regional variation for sickle cell anemia? No. Do you have any family-based variation for sickle cell anemia? No. So that is why it's called as a known mutation site. It is well established. So whenever you're trying to make a diagnosis of known mutation site, the steps to be followed, okay, would be number 1. Number 1 is always sample collection. Okay, this is called as molecular diagnosis. Step number 1 is always sample collection. And the sample that I always prefer for molecular diagnosis is blood sample, because from blood sample, the DNA yield is always better. Okay, of course, there are multiple other samples that can be collected, but I prefer blood sample. Okay, so step number 1 is blood sample collection. From the blood sample, you will have to extract DNA. Okay, from blood sample, I've extracted DNA. Second step is also over. But when I say I've extracted DNA of an individual, I mean to say I've extracted all 46 chromosomes with all 25,000 genes. Right? It means I've extracted all 46 chromosomes with all 25,000 genes. But I am interested only in molecular diagnosis of sickle cell anemia, which is caused by a point mutation, only one gene, which is beta globin gene. So I don't want to meddle or suffer with so much of genomic material. I want only beta globin gene. Also, I don't want just the entire beta globin gene. I'll be happy getting a fragment of beta globin gene, which includes a sixth codon. So how do I get exactly what I want? By subjecting the DNA that I've extracted to PCR. Because I already told you through PCR, I'll be able to get exactly what I want. Right? So using PCR, what I've done is, suppose this represents the entire chromosome, and suppose this represents the fragment of beta globin gene, which includes the sixth codon. To get exactly what I want, I would have constructed specific primers which go and bind only to this region, so that I've gotten a fragment of beta globin gene which includes the sixth codon. So following PCR, I have this fragment. This fragment includes a sixth codon. Till now, I don't know the diagnosis. I don't know whether the sixth codon is normal or abnormal. So the take-home message for all of you is, conventional PCR does not directly give you the diagnosis. Conventional PCR only gives you the fragment which you want. After you get the fragment which you want, to find out whether it is normal or mutated, there should be a next step. A logical next step would be sequencing. Right? A logical next step would be sequencing, because if I introduce this PCR fragment into a sequencer, the sequencer sequences the entire length. I can look at the sixth codon. I know what is normal and what is mutated, and I can give you the diagnosis. So after PCR, a simple logical next step would be sequencing. But because sequences are not widely available and sequencing is not a cost-effective option, what we do in clinical labs is not sequencing, it is RFLP. Right? PCR has to be followed by sequencing or RFLP. So we know already about sequencing. It's just introducing the PCR product to a sequencer. Let me tell you about RFLP. RFLP is restriction fragment length polymorphism, meaning this technique uses a restriction enzyme. What is the restriction enzyme? It's an enzyme which cuts at specific sites. There are thousands and thousands of restriction enzymes which are available in the market. I cannot randomly choose some restriction enzyme for my diagnosis of sickle cell anemia. I'll have to choose a specific restriction enzyme which cuts at the mutation sites. Do you understand this? Out of the thousands and thousands of restriction enzymes that are available, I should choose a specific restriction enzyme which cuts the mutation site only when it is normal. It should not cut it when it is mutated. That is the criteria based on which I choose a restriction enzyme. After I choose a restriction enzyme, depending upon whether it is cut or uncut, I can give the diagnosis. This is the rationale behind RFLP. But how do we use it clinically, or how do we use it practically? Let me go back to the example that I gave you. It is for diagnosis of sickle cell anemia, for which following PCR, I have a PCR fragment which includes a sixth codon. And suppose the length of this PCR fragment is 1.4 kilobase pair. It is just an example. Okay. In this lab, they have constructed primers in such a way that they always get a PCR fragment of length 1.4 kilobase pair, which includes a sixth codon. Okay. I know MST2 is an enzyme which cuts the sixth codon when it is normal. So if it is normal, MST2 cuts the sixth codon to give rise to two fragments, one of length 0.2, the other one of length 1.2. Okay, MST2 cuts it when it is normal. MST2 cannot cut it when it is mutated. Okay, so when it is cut, I get two fragments, 0.2 and 1.2. If it is mutated, the length will be the entire 1.4 kilobase pair. This I know. How do I use it? Okay, so after PCR, I take this PCR tube. This PCR tube has got the fragment of length 1.4 kilobase pair. To this PCR tube, I add the restriction enzyme MST2 and I incubate. If it is normal, MST2 cuts it. If it is mutated, MST2 cannot cut it. My naked eye cannot tell you whether it is cut or uncut. So I have to run it through electrophoresis. When I run these fragments through electrophoresis, what I am drawing here is a polyacrylamide gel. Right? What is it? It's a polyacrylamide gel. It has got 3 wells. Right? It has got 3 wells. I have 3 patients, patient A, patient B and patient C. I am adding restriction digest of patient A into well 1, patient B into well 2, patient C into well 3. And then I connect it to an electrical current. When I switch on the electric current, fragments start moving. Shorter fragments move faster. Longer fragments cannot move. Do you understand this? Shorter fragments move faster. Longer fragments cannot move. I'm looking at person A's restriction digest. I see that person A's restriction digest is refusing to move. Do you understand this? I see that. Yes, MST2 is the restriction enzyme, which is available in the market, readily available. You can get it, use it. Okay. So I see that person A's restriction digest does not move at all. It stays above. If it does not move, I know that the length is 1.4 kilo base pair. If the length is 1.4 kilo base pair, it means it is not cut. If it is not cut, it means it is mutated. I am looking at person B's restriction digest. It moves faster. If it moves faster, I know that the length is 1.2 kilo base pair. If the length is 1.2 kilo base pair, it means it is cut. If it is cut, it is normal, right? I look at person C's restriction digest. I see 2 bands. One band corresponding to 1.4, the other band corresponding to 1.2. One is cut, the other one is uncut. Cut is normal, uncut is mutated. So person C is heterozygous for the mutation. Person C is heterozygous for the mutation. One is normal, the other one is mutated. So person C is a carrier. Person B, both are cut. Both are normal. Person B is normal. Person E, A, both are uncut. Both are mutated. Person A is sickle cell diseased. Do you understand this? Person A is sickle cell diseased. This is how you identify whether the person is sickle cell diseased or the person is normal or is the person carrier. Okay, so a quick recap on steps that are involved. All of you, you don't have to ask me to repeat. Nor me, doctor, I always repeat it. So listen to this now. What are the steps to be followed for molecular diagnosis of a known mutation site? For molecular diagnosis of a known mutation site, step number 1 is blood sample collection. From the blood sample, I extract DNA. So now I have all 46 chromosomes with all 25,000 genes. And then step number 3 is I don't want to meddle with so much of genomic material. I want only a fragment of the gene that I'm interested in. So I subject the DNA that is extracted to PCR. PCR gives me the fragment that I want, but I don't know whether it is normal or mutated. To find out whether it's normal or mutated, I can subject it to sequencing or it is RFLP. What do I do in RFLP? After PCR, I take the PCR tube, I add an enzyme which cuts when it is normal. It cannot cut it when it is mutated. After I add it, I incubate it. After incubation, to find out whether it is cut or uncut, I run it through electrophoresis. When I run it through electrophoresis, based on the length, I know whether it is cut or uncut. If it is cut, it is normal. If it is uncut, it is mutated. If I see both cut and uncut, it means there is one allele that is normal, another allele that is mutated. So this person is heterozygous for the mutation. Are you all clear about this? Yeah. So this is about steps to be followed for molecular diagnosis of known mutation site. So can you give me the answer now? Here, what is step number 1? Step number 1 is sample collection. Step number 2 is DNA extraction. Step number 3 is conventional PCR. Step number 4 is RFLP. So it is 2764. Okay. Now, out of these techniques that are given here, what are the techniques that you don't know about? We already discussed about sample collection, DNA extraction, conventional PCR. We know about RFLP, right? Do you also know about reverse transcriptase PCR? I said reverse transcriptase PCR is used whenever the nucleic acid of interest use an RNA. So what is left out? Cytogenetics and fish. Okay, so let me tell you about cytogenetics. Cytogenetics is to understand about chromosomal aberrations. Whatever we discussed now about is called as molecular diagnostics. PCR, RFLP, all these are molecular diagnostics, wherein diagnosis happens at the molecular level. What do I mean by molecular level? It is not at the chromosome level. It is not even at the gene level. Within the gene, sequence alteration is what you're checking. Right? So it's at the molecular level. So those are molecular diagnostic techniques. But you know that there are some disorders which are caused by chromosomal aberrations. Chromosomal aberrations meaning copy number variation. What do you mean by copy number variation? Trisomy 21 or Down syndrome, trisomy 18. So that's called as copy number variation can cause a disease. Or it can be a structural alteration like translocation, BCR ABL translocation at the chromosomal level. Third is diseases are also caused by microdeletion and amplification. Right? Microdeletion and amplification. So all these are detected at a chromosomal level. If you want to detect all these aberrations, that is done by cytogenetics. Okay. So what did I tell you about cytogenetics? Cytogenetics is used to study about chromosomal aberrations. What are the chromosomal aberrations I told you? Copy number variations, structural alteration like translocation, microdeletion and translocation. No, microdeletion and amplification. And there are two cytogenetic techniques. One is karyotyping, right? One is karyotyping, the other one is fish. So do you understand that fish is not molecular diagnostics? Fish cannot be used to detect sequence changes. Fish can be used to detect only chromosomal aberrations. Okay, so karyotyping and fish. The only application of karyotyping is copy number variation detection. Okay, so what is karyotyping? Karyotyping is you banding the chromosome using GMSA. After you band the chromosome using GMSA, based on the dark bands and light bands, based on the location of the centromere, based on the length of the short arm and long arm, you arrange chromosomes in a particular sequence. After you arrange chromosomes in a particular sequence, you check whether there are two copies of all pairs. If you see two copies of all pairs, it is normal. But if you see three copies of any of the pair, then that is copy number variation. So tell me, karyotyping is used for what? Only one application. Karyotyping or G banding of chromosomes is used to detect only copy number variation. For detecting other types of chromosomal aberrations, you have to use fish. Fish is fluorescent in situ hybridization, and using fish you can detect all chromosomal aberrations. First, you can detect copy number variation. How can you detect copy number variation? Suppose I am suspecting trisomy chromosome 21. Trisomy chromosome 21. What will I do? I collect blood sample of an individual. I centrifuge the blood sample. I take the Buffy coat. Buffy coat is made up of WBCs. After you take the Buffy coat, this WBC is maintained as a cell culture, right? For cytogenetics, you always need a cell culture. Why do I maintain a cell culture? Only then I can induce metaphase arrest of chromosome. Why should I induce metaphase arrest of chromosome? Because in metaphase, chromosomes are highly condensed. Only when they're highly condensed, I can see the chromosome. Okay, so I induce metaphase arrest of chromosome and then I unwind all the chromosomes. Why do I unwind all chromosomes? Because in fish, a hybridization technique, I am going to use a probe. That probe is single-stranded. And for that single-stranded probe to hybridize, your DNA should be single-stranded. So after metaphase arrest, I unwind all chromosomes and then I'm going to use a probe. Which probe will I be using? I will be using a probe which is single-stranded, which is complementary to chromosome 21 sequences. It is single-stranded, it's complementary to chromosome 21 sequences, and that is labeled with the red fluorescent dye. Okay, and then I add it to metaphase arrest chromosome, which is unwound. And then I look through a fluorescent microscope. When I look through fluorescent microscope in a normal person, I would see 2 red signal. If I see 2 red signal, it means I have 2 copies of chromosome 21. Instead, if I see 3 signals, what does it mean? If I see 3 red signals, it means it is trisomy 21. Do you get it? So can you use fish to detect copy number variation? Yes, by using fluorescent probes, complementary to specific sequences of chromosome under study. Okay, can you use fish to detect translocation? Yes. How can you use fish to detect translocation? For example, I'm trying to detect BCR-ABL translocation. Nobby, doctor, please wait for a minute. I'll tell you all about it. Okay. So suppose I'm trying to find out if there is any BCR-ABL translocation. What am I going to do? Collect that sample, centrifuge, remove WBCs, maintain cell culture, induce metaphase arrest, unwind chromosomes. And then you use probes. How many probes will you use? I would use 2 probes. One complementary to BCR sequences, the other one complementary to ABL sequences. They are differentially labeled. BCR sequences are labeled with red fluorescent dye. ABL sequences are labeled with green fluorescent dye. And then I add both these probes to the cell culture. And then I look through fluorescent microscope. When I look through fluorescent microscope, I know BCR is in one sequence, ABL is in a different sequence. So I would expect 2 green signals coming separately and 2 red signals coming separately. This is normal, right? What if I see this? Right? What if I see this? It means BCR and ABL are together in one chromosome. Right? BCR and ABL are together in one chromosome. It means they have undergone translocation. So this means it is BCR ABL positive, which is actually a good news because for this we have a specific management. Right? So this is about fish. So can fish be used to detect translocation? Yes, it can be used to detect translocation. Can you use fish to detect micro deletion or amplification? Yes. How can you use fish to detect micro deletion or amplification? Very simple. Suppose I suspect Prader-Willi syndrome. Right? I'm suspecting Prader-Willi syndrome. I know Prader-Willi syndrome is caused by micro deletion chromosome 15. Okay. And what do? I synthesize a probe which is complementary to that segment which is expected to have undergone microdeletion. I label it with the green fluorescent dye. I add it to the cell culture. And then when I look through a fluorescent microscope, if I see 2 green signals, there is no microdeletion. If I see only 1 green signal, it has undergone microdeletion one of the 2 chromosomes. And that means it is Prader-Willi syndrome. Okay, so what is the take-home message, all of you? The take-home message, all of you, is fish can be used to detect any chromosomal aberration. It can be used to detect copy number variation. It can be used to detect translocation. It can be used to detect microdeletion. Okay, what it can't be used for? Fish cannot be used to detect point mutations, because point mutations at the nucleotide sequence level, your probe will not go and detect anything at the nucleotide sequence level. So please remember, fish is not a molecular diagnostic technique, it's a cytogenetic technique. It cannot be used to detect sequence alterations. Okay. So this is a very simple MCQ. I'll stop for genetics here and then you can take 15 minutes break and then we'll come back to discuss about metabolism. The M13 bacteriophage vector has been used in molecular biology to identify specific gene sequences such as those related to spike proteins through expression of inserted gene fragments. Everything is there in the question. They have inserted a gene into phage. The phage is expected to express the gene and then they're learning about the protein. So what is it? It is phage expression. The answer is phage expression. A patient presents with skin cancer and hyperpigmentation that worsens with sunlight exposure. What is the disease? Xeroderma pigmentosa, caused by a defect of nucleotide excision repair. Okay. So you can go for a 15 minutes break, come back at 4:30, right? In the next 1 hour, we will finish the remaining parts of biochemistry. Okay. Am I audible now? Yeah, so we'll discuss few facts first and then we'll discuss some MCQs. The first fact that you need to know as far as carbohydrate metabolism is concerned is glycolysis is the only pathway that can generate ATP even in the absence of oxygen. You know that, right? Glycol is the only pathway that can generate ATP even in the absence of oxygen, because as you know, glucose in the presence of oxygen gives rise to 2 pyruvate and 7 ATPs. As long as there is oxygen, from glucose you get 2 pyruvate and 7 ATPs. In the absence of oxygen, from glucose you get 2 lactates and 2 ATPs. So whenever they ask you which is the only fuel which can generate ATP even in the absence of oxygen, your answer should be glucose, and the pathway is glycolysis. That is why glycolysis is indispensable for all anaerobic cells. So what are the anaerobic cells for which glucose is indispensable? RBCs, white muscle fibers. Right? RBCs and white muscle fibers are completely dependent on glucose. They are completely dependent on anaerobic glycolysis. If this is the state of anaerobic cells, can you tell me what is the state of aerobic cells? What are the aerobic cells that you know? Cardiac muscle fibers and red muscle fibers. Yeah, cardiac muscle fibers are known for their mitochondrial content. Red muscle fibers are known for their myoglobin. So cardiac muscle fibers with mitochondria, red muscle fibers with myoglobin are all aerobic cells. These aerobic cells are dependent on fatty acid as their fuel. Though I told you aerobic cells are dependent on fatty acid as their fuel, there is an exception to this rule. The exception is neurons. Though neurons are aerobic, if it's aerobic, they should have used only fatty acid, because fatty acid on oxidation can give rise to more number of ATPs than glucose on oxidation. So knowing neurons are aerobic, they should have used only fatty acid. They don't use fatty acid, but they use glucose. The reason for this is neurons are surrounded by blood-brain barrier, and any fatty acid that is present in the blood is attached to albumin. Anything attached to albumin cannot cross the blood-brain barrier. So neurons do not have an access to fatty acid. That is why though neurons are aerobic, they continue to use glucose. So are you clear about fuel utilization by all these cells? Whenever they ask you what is the preferred fuel for anaerobic cells, like RBCs and white muscle fibers, your answer should be glucose. If they ask you what is the preferred fuel for cardiac muscle fibers and red muscle fibers, your answer should be fatty acid. Neuron is aerobic, but it uses glucose as the fuel. Okay. Having understood that glycolysis is indispensable for RBCs and white muscle fibers, if you're asked what will happen whenever there is a glycolytic enzyme defect, RBCs get affected, white muscle fibers get affected. When RBCs get affected, that presents as hemolytic anemia. When white muscle fibers get affected, that would present as exercise intolerance. So all of you tell me what is expected whenever there is a glycolytic enzyme defect. Just remember which cell is dependent on glycolysis, RBCs and white muscle fibers. So whenever there is a glycolytic enzyme defect, it causes hemolytic anemia and exercise intolerance. Intolerance particularly to anaerobic exercises, right? Intolerance particularly to anaerobic exercises. Another disorder which presents with hemolytic anemia is G6PD deficiency. G6PD deficiency also presents with hemolytic anemia. You know that, right? Can you tell me why? It is because G6PD is an enzyme of HMP shunt. Through HMP shunt, we expect NADPH. This NADPH is necessary for regenerating glutathione, which is an antioxidant that is used by RBCs. Please remember this, G6PD is an enzyme of HMP shunt. Through HMP shunt, which we get NADPH. NADPH is necessary to regenerate glutathione, which is an antioxidant used in RBCs. So whenever there is G6PD deficiency, no NADPH, no glutathione, no antioxidant. So RBCs are susceptible to undergo lysis in the presence of an oxidative stress. So whenever the question says hemolytic anemia, right? Whenever the history says hemolytic anemia, you should find out whether it is G6PD deficiency or is it glycolytic enzyme defect. How will you find the difference? In G6PD deficiency, the hemolytic anemia would have been preceded by exposure to an oxidative stress. Previous history of exposure to oxidative stress. For example, intake of primaquine or intake of fava beans. If you see that, it is G6PD deficiency. If it's glycolytic enzyme defect, there is not only hemolytic anemia, there is also exercise intolerance, intolerance to anaerobic exercises. Okay. What if you see intolerance to aerobic exercise? Intolerance to aerobic exercise is because of fatty acid oxidation defect. Okay. So that is about few facts that you need to know as far as carbohydrate metabolism is concerned. Now, I want you also to know that glycolysis and gluconeogenesis are reversal of each other. Okay, glycolysis and gluconeogenesis are reversal of each other. So, if you want to know steps of gluconeogenesis, you need to know the irreversible steps of glycolysis and you should know a means of reversing those steps. So, what are the irreversible steps of glycolysis? Hexokinase or glucokinase, phosphofructokinase 1 and pyruvate kinase. So please memorize all the facts that I tell you every now and then. What are the irreversible steps of glycolysis? Irreversible steps of glycolysis are catalyzed by hexokinase or glucokinase, phosphofructokinase 1 and pyruvate kinase. So what are the steps of gluconeogenesis? Any step which can reverse these three enzymes are the steps of gluconeogenesis. To reverse pyruvate kinase step, normally pyruvate kinase converts phosphoenol pyruvate to pyruvate. To reverse that, you use two enzymes in gluconeogenesis. One is pyruvate carboxylase, the other one is PepCK. So please memorize it. What are the first two enzymes of gluconeogenesis? Pyruvate carboxylase and phosphoenol pyruvate carboxykinase. To reverse phosphofructokinase 1 step, the enzyme that is used is fructose 1,6-bisphosphatase. To reverse hexokinase or glucokinase step, the enzyme that is used is glucose 6-phosphatase. So tell me, what are the four enzymes of gluconeogenesis which are exclusive for gluconeogenesis? Pyruvate carboxylase, phosphoenol pyruvate carboxykinase, fructose 1,6-bisphosphatase and glucose 6-phosphatase. So whenever they ask you what are the enzymes exclusive for glycolysis, it is hexokinase or glucokinase, phosphofructokinase 1 and pyruvate kinase. What are the enzymes which are exclusive for gluconeogenesis? Pyruvate carboxylase, PepCK, fructose 1,6-bisphosphatase and glucose 6-phosphatase. The remaining enzymes are common to both glycolysis and gluconeogenesis. Now what you should know is, whenever there is a defect of gluconeogenesis, that causes hypoglycemia, right? Whenever there is a defect of gluconeogenesis, that causes hypoglycemia, because what is the significance of gluconeogenesis? Gluconeogenesis maintains blood glucose in the fasting state. In the fed state, Dietary glucose maintains plasma glucose. In the fasting state, plasma glucose is maintained by two pathways. One is liver glycogenolysis. The other one is gluconeogenesis. Please repeat this. What are the two pathways which maintain blood glucose in the fasting state? Number one, liver glycogenolysis. Number two, gluconeogenesis. That is why whenever there is a defect of gluconeogenesis in the fasting state, the person cannot maintain blood glucose. So that causes fasting hypoglycemia. Okay. Otherwise, if they ask you, what are the causes of fasting hypoglycemia? Your answer should be a defect of liver glycogenolysis or a defect of gluconeogenesis. Both can cause fasting hypoglycemia. But when will you see exercise intolerance? Please tell me, when do you see exercise intolerance? Exercise intolerance is seen whenever there is a defect of muscle glycogenolysis, right? And glycolysis. When do you see exercise intolerance? Whenever there is a defect of muscle glycogenolysis or glycolysis. Particularly, exercise intolerance to anaerobic exercise. And what did I tell you? When will you see intolerance to aerobic exercise? Aerobic exercise intolerance is seen whenever there is a fatty acid oxidation defect. Are you clear about all these facts? I'm going to repeat all the facts that I've told you so far. These are the facts that you need to remember for you to understand glycogen storage disorders that I'm going to discuss next. Okay, so what are the facts that I told you? Recollect, what is the first fact I told you? Glycolysis. Glycol is the only pathway that can generate ATP even in the absence of oxygen. Yeah. So what is the first fact I told you? The first fact that I told you is glycol is the only pathway that can generate ATP even in the absence of oxygen. Second fact that I told you is glucose in the presence of oxygen gives rise to 2 pyruvate and 7 ATPs. The same glucose in the absence of oxygen gives you 2 lactate and 2 ATPs. Because glycol is the only pathway that can generate ATP even in the absence of oxygen, what are the cells for which glycolysis is indispensable? All anaerobic cells are totally dependent on glycolysis. What are the anaerobic cells which are totally dependent on glycolysis? RBCs, white muscle fibers. Okay. Now, what about the aerobic cells? What are the aerobic cells that you know? Cardiac muscle fibers and red muscle fibers. They are dependent on fatty acid oxidation. Exception. Neuron is aerobic, but it is still dependent on glycolysis because neurons do not have an access to fatty acid. Having understood that for RBCs and for white muscle fibers, glycolysis is indispensable. If they ask you what is expected whenever there is a glycolytic enzyme defect, what should be your answer? RBCs get affected, so it presents as hemolytic anemia. White muscle fibers get affected, so it presents as exercise intolerance, intolerance to anaerobic exercise. Okay, so glycolytic enzyme defects always cause hemolytic anemia and intolerance to anaerobic exercise. What is another cause of hemolytic anemia? G6PD deficiency. Because without G6PD, there is no NADPH to regenerate glutathione, which is an antioxidant for RBCs. So what are the two metabolic causes of hemolytic anemia? Glycolytic enzyme defect and G6PD deficiency. How do you differentiate the two? In G6PD deficiency, there is a previous history of exposure to oxidative stress. In glycolytic enzyme defect, apart from hemolytic anemia, there is also exercise intolerance, intolerance to anaerobic exercise. This is what I showed you first. Second, I told you there are two pathways, right? There are two pathways which are reversal of each other. What are the two pathways? Glycolysis and gluconeogenesis. So these two pathways have some enzymes which are exclusive for each other, some enzymes which are common. Reversible steps are all common, irreversible steps are exclusive. So what are the irreversible steps of glycolysis? The first enzyme, hexokinase or glucokinase step, phosphofructokinase 1 step, and pyruvate kinase step. So these three enzymes catalyze the irreversible steps of glycolysis. So what are the steps of gluconeogenesis? Gluconeogenesis steps are catalyzed by, please repeat it in the chat box, pyruvate carboxylase, PepCK, fructose 1,6-bisphosphatase, and glucose 6-phosphatase. These four enzymes are exclusive for gluconeogenesis. The remaining enzymes are common to both glycolysis and gluconeogenesis. Now, what is the significance of gluconeogenesis? It maintains blood glucose in the fasting state. So whenever there is a defect of gluconeogenesis, you should anticipate fasting hypoglycemia. When do you see fasting hypoglycemia? Whenever there is a defect of gluconeogenesis and whenever there is a defect of liver glycogenolysis, you expect fasting hypoglycemia. When do you expect exercise intolerance? Muscle glycogenolysis defect and glycolysis defect. Because I told you muscle is dependent on glycolysis for ATP production. So when do you see exercise intolerance? You see exercise intolerance whenever there is a defect of muscle glycogenolysis or glycolysis. This is intolerance to anaerobic exercise. Then do you see intolerance to aerobic exercise? If it's aerobic exercise, the muscle is dependent on fatty acid. So you expect intolerance to aerobic exercise whenever there is a fatty acid oxidation defect. Are you clear about all these facts? Yeah. With these facts in mind, let's start learning about glycogen storage disorders. This is a high yield topic asked in every exam. First, I'm going to tell you about types of glycogen storage disorders, their names and the enzyme defects, and then I'm going to tell you about all clinical features. Okay, so we are going to learn about 8 types of glycogen storage disorders, type 0 till type 7. Unlike what you saw in Revive live online session or in the rapid revision videos that are available, here I'll tell you only in a nutshell how to make a diagnosis. Okay, it will be an ultra shortcut. Okay, so first let's learn the names and enzyme defects. You need to learn about 8 types of glycogen storage disorders, type 0 till type 7. So what is type 0, all of you? Type 0 is glycogen synthase defect. So why do you call it as type 0? Because it's a glycogen storage disorder without any glycogen. Glycogen synthesis does not happen. So this is a glycogen storage disorder without any glycogen storage, hence the name type 0. What is type 1? 1 stands for Vaughan. 1 stands for Vaughan. 1 is Vaughan-Gerke disease. Okay, Vaughan-Gerke's disease is caused by the defect of glucose 6-phosphatase. And what is that you know about glucose 6-phosphatase? Glucose 6-phosphatase is an enzyme of glycogenolysis and gluconeogenesis. Please remember, glucose 6-phosphatase is an enzyme common to both liver glycogenolysis and gluconeogenesis. Did I tell you these are the 2 pathways which can maintain blood glucose? This you should know by heart. Anytime you ask, you should be able to answer this. If they ask you what are the 2 pathways which can maintain blood glucose in the fasting state, just 2 pathways, liver glycogenolysis and gluconeogenesis. In Vaughan-Gerke's disease, when glucose 6-phosphatase is defective, both liver glycogenolysis and gluconeogenesis are defective. So this causes severe fasting hypoglycemia. Only because it is severe, it is type 1. All type 1s are severe. Okay, so that's about type 1, von Gierke's disease. Type 2 is Pompey's disease. Pompey's disease is caused by the defect of acid maltase or alpha glucosidase. Pompey's disease is caused by the defect of acid maltase or alpha glucosidase. Type 3, I have always asked you to remember it is the third alphabet is C. So type 3 is C, stands for Cory's disease. C to be followed by D. Cory's disease is caused by the defect of D-branching enzyme. Cory's disease is caused by the defect of D-branching enzyme. C and D are over. Next, it has to be A and B. Type 4 is Anderson's disease, caused by the defect of branching enzyme. Okay, Anderson's disease, AB, branching enzyme defect. Type 5 looks like the letter V. Please invert V, write it twice. Right, invert V, write it twice. What is the alphabet that you see? M. M stands for McArdle's disease. Right, M stands for McArdle's disease. M for M, muscle phosphorylase defect. Quickly tell me, if muscle phosphorylase is defective, what do you expect? Exercise intolerance. Intolerance to anaerobic exercise. Okay, so you already know about McArdle's disease. Okay, now type 6 is Her's disease. H for H, hepatic phosphorylase or liver phosphorylase defect. Type 7, Taruv's disease. Taruv's disease is phosphofructokinase 1 defect. Glycolytic defect or phosphofructokinase 1 defect. Okay, so a quick recap. All of you look at this table and tell me what is type 0? How many types I told you? 8 types. Give me a second. So 8 types. What is type 0? Type 0 is glycogen synthase deficiency. Type 1 is von Gierke's disease caused by the defect of glucose 6 phosphatase. Type 2, Pompey's disease, acid maltase or alpha glucosidase defect. Type 3, Cory's disease, D-branching enzyme defect. Type 4, Anderson's disease, branching enzyme defect. Type 5, McArdle's disease, muscle phosphorylase defect. Type 6, Her's, liver phosphorylase defect. Type 7, Taruv's disease, phosphofructokinase 1 defect. Okay. Now quickly about Pompey's disease. Pompey's disease, all that you have to remember is it's the only glycogen storage disorder which is also a lysosomal storage disorder. Whenever this question is asked, if you see a word lysosome, glycogen storage disorder and lysosome, it is Pompey's disease, because the enzyme acid maltase or alpha glucosidase is present in lysosome. Okay, what do you see in this disorder? Just remember it this way. In Pompey's, the pump is affected. Which is the pump of your body? Heart. Right, in Pompey's, the pump is affected. Heart is affected. It presents with cardiomegaly, cardiomyopathy. Okay. Not only cardiac muscle, skeletal muscle is also affected. When skeletal muscle is affected, it presents as hypotonia. Yeah, it presents as hypotonia. So one of the causes of floppy baby. If they ask you what is one of the causes of floppy baby, your answer should be Pompey's disease. And infantile Pompey is rapidly progressive. Death happens close to 2 years. And luckily, we have enzyme replacement therapy for Pompey's. If you know this, that's more than enough. So what is that you need to know about Pompey's disease? It's the only glycogen storage disorder, which is also a lysosomal storage disorder. Defect of acid maltase or alpha glucosidase. The pump is affected. It presents with cardiomegaly, cardiomyopathy, and hypotonia. It is one of the causes of floppy baby. Enzyme replacement therapy is available for Pompey's disease. Okay. Now, classification of glycogen storage disorders. As I told you when I told you about few factual facts, right? I told you some facts before. So based on that, we can classify glycogen storage disorders into 4 categories. The first category presents with fasting hypoglycemia. Second category presents with exercise intolerance. Third category presents with both fasting hypoglycemia and exercise intolerance. The last category presents with neither fasting hypoglycemia nor exercise intolerance. Okay, because I told you, right? If it's a defect of glycogenolysis and gluconeogenesis, it is hypoglycemia. If there is a defect of muscle metabolism, or if there is a defect of glycolysis, that causes exercise intolerance. So this is how we are going to classify glycogen storage disorders. Now, what are the types of glycogen storage disorders which present with fasting hypoglycemia? Type 0, type 1, type 3, and type 6. 45 minutes more pluviophile. Yeah, just 45 minutes. After carbohydrates, lipids we'll quickly discuss. I'll give you some facts. And then we'll learn about hyperlipoproteinemias. And then few facts in amino acid and protein metabolism, maximum 45 minutes. Okay. So please repeat this. What are the glycogen storage disorders which present with fasting hypoglycemia? Type 0, type 1, type 3, and type 6. Exercise intolerance, type 0, and then odd numbers. Tell me what are the odd numbers? 3, 5, and 7. Exercise intolerance is type 0, 3, 5, and 7. Now both. Can you tell me what are the types which are included in these categories? 0 and 3. So both fasting hypoglycemia and exercise intolerance would be 0 and 3. Neither fasting hypoglycemia nor exercise intolerance would be left out disorders. What are the left out disorders? Type 2 and type 4. If you remember just this classification, the moment you look at the history, you know how to narrow it down. Okay, so tell me, what if the history says fasting hypoglycemia? What are the types that you will think of? 0, 1, 3, and 6. If the history says exercise intolerance, it is 0, 3, 5, 7. If the history says both fasting hypoglycemia and exercise intolerance, it is 0 and 3. Neither fasting hypoglycemia nor exercise intolerance, it is 2 and 4. Okay, now this is the classification. Now the first category presenting with fasting hypoglycemia, can you all keep the chat box active please? What are the types? 0, 1, 3, and 6. And can you tell me the names? Type 0 is glycogen synthase deficiency. What is type 1, all of you? Von Guericke's disease caused by the defect of glucose 6-phosphatase. Type 3, Cory's disease caused by the defect of debranching enzyme. Type 6, Her's disease caused by the defect of liver phosphorylase. Because we know these two columns already, the last column is going to be easy to know, right? Because type 0, glycogen synthase deficiency, there is no prefix as liver or as muscle. If the enzyme name does not have a prefix as liver or as muscle, it means the enzyme is defective both in liver and in muscle. So when liver is not able to store glycogen, in the fasting state, liver will not be able to release glucose. So what will it present as? It presents as fasting hypoglycemia. Muscle is also not able to store glycogen. So when the muscle tries to exercise, it will not be able to do it. So that causes exercise intolerance. Intolerance to which exercise? Anaerobic exercise, because glucose is needed only when it is anaerobic exercise. So tell me, type 0, presence with both fasting hypoglycemia and exercise intolerance. Whenever you see fasting hypoglycemia and exercise intolerance, you're supposed to take a liver biopsy. Yeah, what you're supposed to do is you're supposed to take liver biopsy. In this case, liver biopsy reveals zero glycogen. Glycogen synthase is defective in liver. Liver shows zero glycogen, hence the name type 0. So are you clear about type 0, everybody? Type 0 is both fasting hypoglycemia and exercise intolerance. Liver biopsy reveals zero glycogen. Type 1 von Gierke's disease, as I already told you, glucose 6-phosphatase is defective. Both glycogenolysis and gluconeogenesis cannot happen. So this causes severe fasting hypoglycemia. Right? What does it cause? It causes severe fasting hypoglycemia. There are so many causes of severe fasting hypoglycemia in a neonate, but all other causes of fasting hypoglycemia in a neonate can respond to counter-regulatory hormone administration. What do you mean by counter-regulatory hormone administration? You start glucagon. Immediately, the child will respond by increasing glucose. Because in all other conditions, there is either a defect of glycogenolysis or there is a defect of gluconeogenesis. So when you give these counter-regulatory hormones, even if one pathway is defective, the other one can maintain blood glucose. So all other causes of neonatal fasting hypoglycemia respond to counter-regulatory hormone administration. But the only disorder which presents a severe fasting hypoglycemia with absolutely zero response to counter-regulatory hormone administration is von Gierke's disease. So always in von Gierke's disease, the history will be classical. They would say a neonate presenting with severe fasting hypoglycemia, even after 12 to 14 hours of fasting, the child is not able to maintain glucose. There is no way it can maintain glucose because no glycogenolysis, no gluconeogenesis. Do you get it? So that's about von Gierke's disease. Very good. Cory's disease is a debranching enzyme defect. In this name, did I give you a prefix as liver or as muscle? I did not. Which means it's defective both in liver and in muscle. So tell me what is expected. Liver debranching enzyme is defective. No liver glycogenolysis. That causes fasting hypoglycemia. Muscle debranching enzyme is defective. That causes exercise intolerance. Again, one more condition which presents with both fasting hypoglycemia and exercise intolerance. Did I tell you whenever you see fasting hypoglycemia and exercise intolerance, you should take liver biopsy. In this case, if you take liver biopsy, it's a debranching enzyme defect. So here you see an abnormal glycogen with multiple branches. Right? Debranching enzyme defect, branches are not getting broken. So in this case, you see an abnormal glycogen with multiple branches. That structure is called as limit dextrin. So if liver biopsy reveals zero glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is type 3. That is why type 3 Cory's disease is also called as limit dextrinosis. Very good, Kevin. It's also called as limit dextrinosis. Now about Hurst's disease. Hurst's disease is liver phosphorylase defect. Whenever liver phosphorylase is defective, liver glycogenolysis is defective. That causes fasting hypoglycemia. My question is, will this fasting hypoglycemia be severe as you see in von Gierke's? Or will it be mild? It will be mild because in Hurst's disease, it's only a defect of glycogenolysis. But what is intact? Gluconeogenesis is intact. So this presents as mild to moderate fasting hypoglycemia. It responds to counter-regulatory hormone administration because gluconeogenesis is intact. So tell me, how do you differentiate von Gierke's disease from Hirsch's disease? Both present as fasting hypoglycemia. Von Gierke's is severe. Hirsch's disease is mild to moderate. Von Gierke's does not respond to counter-regulatory hormone administration. Hirsch's disease responds to counter-regulatory hormone administration. In von Gierke's, even after overnight fasting, blood glucose is not maintained. In hers, after overnight fasting, slowly blood glucose increases because gluconeogenesis is switched on. Okay, so this is about differentiating von Gierke's and hers. So can we have an algorithm? Okay, algorithm to make a diagnosis of glycogen storage disorder if the mother complains of fasting hypoglycemia. Again, no mother would come and tell you that a child has got fasting hypoglycemia. What would the mother say? The mother would say frequent cry. My child often cries, right? Cry between meals. A cry which is soothed only after feeding. Demand for frequent feeding, right? So these are the terms which you can hear from the mother, right? Frequent cry, cry between meals, cry which gets soothed after feeding, demand for frequent feeding. In that case, you should suspect fasting hypoglycemia. So if you suspect fasting hypoglycemia, look for features of exercise intolerance. Okay, what if you find exercise intolerance as well? Please tell me. If you see both, quickly answer. If you see both fasting hypoglycemia and exercise intolerance, you should take liver biopsy. What if liver biopsy reveals zero glycogen? What is your diagnosis? Type 0. If liver biopsy reveals limit dextrin, it is type 3. Is it not simple, right? So what if there is no exercise intolerance, only fasting hypoglycemia? Then look for response to counter-regulatory hormone administration. What if there is no response to counter-regulatory hormone administration, that is pathognomonic of von Gierke's disease or type 1? What if there is response to counter-regulatory hormone administration, that is Hirsch's disease or type 6? Okay. If you have understood, can I see some lights? Yeah. So if you have understood this, give a thumbs up or like this video. We can proceed. Okay. So this is about an algorithm which a person can follow when there is fasting hypoglycemia. Now, what if there is exercise intolerance? What did I tell you are the types which present with exercise intolerance? 0, odd numbers. What are the odd numbers? 3, 5, and 7. Okay, tell me the names. It's just a repetition name. 0 is glycogen synthase deficiency. 3 is Cory's disease or debranching enzyme defect. 5 is McArdle's disease, muscle phosphorylase defect. Type 7, Tarew's disease, phosphofructokinase 1 defect. Okay, we know this already, which means you know the last column, right? Particularly for the first two disorders. Don't you know the last column for the first two disorders? Glycogen synthase deficiency, defective both in liver and in muscle. So what do you see? Both fasting hypoglycemia and exercise intolerance. Liver biopsy reveals 0 glycogen. Cory's disease, liver debranching enzyme defect and muscle debranching enzyme defect. So again, you see fasting hypoglycemia and exercise intolerance. Liver biopsy reveals limit dextrin. So this we know already. What we are going to learn about now is McArdle's disease. What is that you know about McArdle's disease? Muscle phosphorylase defect. Muscle glycogenolysis is defective. In this case, when you ask the person to perform some anaerobic exercise, right? Anaerobic exercise, best example is clenching the fist. So if you ask the person to clench only one fist, the person will be able to do this for the first 5 to 10 minutes, after which the person complains of painful muscle cramp. The reason for this painful muscle cramp is sudden ATP depletion. Because in this case, you're asking the person to perform anaerobic exercise. For anaerobic exercise, muscle needs glucose. That glucose should come from muscle glycogen. But this person does not have any glycogenolysis happening. Muscle does not get glucose. Muscle does not have glycolysis. Muscle is not able to generate ATP. And you must have learnt in physiology that not only for contraction, even for relaxation, you need ATP. When there is sudden ATP depletion, there is no relaxation. That sustained contraction is responsible for muscle cramp. Okay, so tell me, what do you expect in McArdle's disease? You ask the person to clench one fist. The person will be able to do this for the first 5 to 10 minutes, after which the person complains of painful muscle cramp. The painful muscle cramp is because of ATP depletion. Okay, have you all experienced muscle cramp in your life? Yes. And how do you differentiate a muscle cramp that normal people like us experience versus the muscle cramp which a person with McArdle's would experience? In a person with McArdle's, when the person complains of painful muscle cramp, you should get blood sample from the exercising arm. And that blood sample shows low glucose and low lactate level. Post-exercise, from the exercising arm, if you collect blood sample, the blood sample shows low glucose and low lactate. You should ask me why. The reason is, in this case, the muscle is not able to get glucose from its glycogen. So the muscle starts getting glucose from the blood. So any glucose that is available in the blood would have gotten extracted. That causes post-exercise reduction in glucose. Please remember, this is not fasting hypoglycemia. This is post-exercise reduction in glucose because muscle has extracted glucose. And why is there a low lactate level? When I say there is a low lactate level, it is relatively low. What do I mean by relatively low? If you and I do some anaerobic exercise, when blood sample is collected, the lactate level would be high. But in a person with McArdle, no glucose, no lactate. So lactate level does not rise. Post anaerobic exercise, lactate level does not rise. That is McArdle's disease. Do you all understand this? Yeah. So tell me, what is McArdle's disease? McArdle's disease is muscle phosphorylase defect. They present with exercise intolerance, intolerance to anaerobic exercise. Post-exercise, when you collect that sample, the glucose and lactate levels are low. Okay, so that is about McArdle's disease. Taruv's disease, can I wait for you to answer? What did I tell you about Taruv's disease? Phosphofructokinase 1 defect, glycolytic defect. This I told you multiple times. Whenever there is glycolytic defect, what do you expect? Hemolytic anemia and exercise intolerance. So Taruv's disease presents with hemolytic anemia and exercise intolerance. Okay, so that is about glycogen storage disorders with exercise intolerance. Let's write down an algorithm for exercise intolerance. What if the mother complains of exercise intolerance? No mother is going to come and tell you her child has got exercise intolerance, right? What would it be in mother's terms? The mother would say, my child is not able to play as much as my friend's child, right? Or the mother would say, my child is not able to play as much as my child's friend, okay? Or the mother would say, my child often complains of painful muscle cramp. If you get to hear all these statements from a mother, suspect exercise intolerance, right? So whenever there is exercise intolerance, which is a presenting feature, collect the fasting blood sample. In that fasting blood sample, estimate glucose, estimate total CK, and estimate LDH. First, tell me, why do you estimate total CK? To ascertain that there is really exercise intolerance. It should not be like the child is weak, right? Just because a child is weak, the child is not able to play as much as the friend's child. All that should be taken care is nutrition, right? In that case, total CK will not be elevated, okay? So estimate total CK to find out if there is really an exercise intolerance. Estimate glucose Y to find out if there is fasting hypoglycemia also. Okay, so what if there is exercise intolerance and that is accompanied by fasting hypoglycemia? Both. What did I tell you you should do if you see both? Do a liver biopsy. Okay, if liver biopsy reveals zero glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is type 3. This we know already, right? What if there is exercise intolerance? Total CK is elevated. Check LDH values. Okay, what if LDH value is high? It's a sign of hemolysis. If LDH value is high, it's a sign of hemolysis. So exercise intolerance plus hemolytic anemia is glycolytic enzyme defect. If there is only exercise intolerance, no hemolysis, it is McArdle's disease. Do you get it? So I recommend that you watch this part of the video again. Okay, get this algorithm registered in your mind so that you don't get confused during the exam. Okay, so algorithm for exercise intolerance. Whenever there is exercise intolerance, collect a fasting blood sample, estimate glucose, CK and LDH. If there is high CK and low glucose, take a liver biopsy. Zero glycogen type 0, limit dextrinitis type 3. There is exercise intolerance, but there is no hypoglycemia. Look at LDH values. If LDH value is high, it is hemolysis, it is glycolytic enzyme defect. No elevation of LDH, there is only exercise intolerance, suspect McArdle's disease. Okay. Second wind phenomenon, I don't explain about second wind phenomenon because that's not exclusive for McArdle's. Once in one of the INI-CET exams, they gave second wind phenomenon. Thereon, we are all clinging to it. You and I also experienced second wind phenomenon. How many of you have run full marathon? How many of you have run a full marathon or a half marathon? I do not count 5 kilometer running as a marathon. Okay, so the actual marathon is 42 kilometers. If you have not run 42, at least half marathon, just 21 kilometers if you have run. Okay, what you would experience is after you have done like 10 kilometers, you will see that there are multiple muscle cramps. You're not able to run. Okay, and then we call it as mind over body, right? Mind over body, when you're supposed to take over it, you should push through it. You should continue running. If you continue running for another 10 minutes, despite you experiencing all these muscle cramps, at one point you'll see a relief. You are able to run more. Okay, that's called a second wind phenomenon. This is not exclusive for McArdle's. It has got nothing to do with diagnosing McArdle's. Do you all understand that? So second wind phenomenon is because when there is lactic acid accumulation, slowly lactic acid causes vasodilatation. When there is vasodilatation, muscle feels the relief. Muscle starts taking oxygen from the blood. Muscle starts taking glucose from the blood. Muscle starts taking fatty acid from the blood. And ATP starts getting generated. The muscle cramp is relieved. That is a normal phenomenon. Do you all understand that? Yeah, second wind phenomenon is a normal phenomenon. You and I experience, a person with McArdle will also experience. So if there is something of clinical significance, I won't skip. Okay. So neither has fasting hypoglycemia and exercise intolerance. What are the two types I told you? Type 2 and type 4. We already learned all about type 2, which is Pompey's disease. What is Pompey's disease? What does it present with? Cardiomegaly, cardiomyopathy, and they present with hypotonia. Right? This we already learned. Now, what is type 4 or Anderson's disease? Anderson's disease is branching enzyme defect. So when there is a branching enzyme defect, liver accumulates glycogen without branches. Branches provide compactness to glycogen. So in this case, liver accumulates an abnormal glycogen without any branch that occupies a larger space. That causes hepatomegaly. So what does Anderson's disease present with? Anderson's disease presents with hepatomegaly that progresses to liver cirrhosis. Okay, so just because we say type 4 does not present with fasting hypoglycemia or exercise intolerance, please don't get misguided and please don't think it's a mild condition. It's not a mild condition. It starts as an innocent hepatomegaly that progresses to liver cirrhosis because abnormal glycogen accumulates without any branches. So that's about Anderson's disease or type 4. Okay. So MCQs. INI-CET, November 2021. Metabolic fuel for RBCs during starvation. The moment you see RBC and fuel, it can be a well-fed state, it can be fasting, it can be starvation, that does not matter. RBCs always use glucose. Okay. The only fuel RBCs can use is glucose because it does not have mitochondria. This is a complicated MCQ which I wanted to discuss today and explain it to you. Deficiency of which enzyme leads to increased 2,3-BPG levels and low glucose levels in vitro. Okay, so what is 2,3-BPG? What are the facts that you have learnt about 2,3-BPG? 2,3-BPG is a byproduct of glycolysis. Because do you know that in glycolysis, there is an intermediate 1,3-bisphosphoglycerate. This 1,3-bisphosphoglycerate in the presence of phosphoglycerate kinase normally becomes 3-phosphoglycerate. And this phosphoglycerate kinase directly generates 2 ATPs. This is a normal, right? This is a normal sequence of steps in glycolysis. But in hypoxia and in anemia, right? In hypoxia and anemia, your tissues want to get more oxygen from hemoglobin, for which your RBCs need 2,3-BPG. Have you learned that 2,3-BPG reduces the affinity of hemoglobin for oxygen? Yeah, you must have learned this in physiology. 2,3-BPG reduces the affinity of hemoglobin for oxygen, helps in unloading oxygen to tissues. So 2,3-BPG should be generated whenever there is hypoxia, whenever there is anemia. How do you generate 2,3-BPG? It is a byproduct of glycolysis, wherein 1,3-bisphosphoglycerate in the presence of bisphosphoglycerate mutase gets converted to 2,3-bisphosphoglycerate. Then this 2,3-bisphosphoglycerate becomes 3-phosphoglycerate. So this helps in reducing the affinity of hemoglobin for oxygen, helps in unloading oxygen to tissues. Having understood this, look at all the choices here. Pyruvate kinase defect. First tell me, pyruvate kinase is an enzyme of which pathway? It's an enzyme of glycolysis. And pyruvate kinase is the last step of glycolysis. When that enzyme is defective, the precursor 2,3-BPG will be accumulated. So yes, pyruvate kinase defect will cause an accumulation of 2,3-BPG, helps in unloading oxygen to tissues. This can happen, but this is not going to cause hypoglycemia because glycolytic enzyme defect does not cause hypoglycemia, right? Glycolytic enzyme defect will only cause hemolysis. Only gluconeogenesis enzyme defect will cause hypoglycemia. So this is not pyruvate kinase defect. If at all something happens to glucose level in pyruvate kinase defect, when you're not using glucose, glucose level in vitro will increase. glucose level will not decrease. Okay, so this is not pyruvate kinase defect. What if it's phosphoglycerate kinase defect? In phosphoglycerate kinase defect, 1,3-bisphosphoglycerate can become 2,3-bisphosphoglycerate. The level increases, and phosphoglycerate kinase is an enzyme common to both glycolysis and gluconeogenesis. What are the enzymes exclusive for glycolysis? I told you, hexokinase or glucokinase, phosphofructokinase 1, pyruvate kinase. Does it include phosphoglycerate kinase? No. So phosphoglycerate kinase is not only an enzyme of glycolysis, it's also an enzyme of gluconeogenesis. So when that enzyme is defective, gluconeogenesis cannot happen, and that can cause low glucose values. Okay, so what is the right answer here? The right answer is choice B, phosphoglycerate kinase defect. What about other choices? If it is glucose 6-phosphate dehydrogenase defect, it causes only hemolytic anemia. It does not cause low glucose, right? It does not cause low glucose. So this is not the case. What if it's hexokinase defect? Hexokinase is the first enzyme of glycolysis. If that is defective, byproduct of glycolysis cannot be synthesized. Do you understand this? When it is hexokinase or glucokinase defect, byproduct of glycolysis cannot be synthesized. Also, glucose level will be high. This is how you can answer INI-CET questions. Do you get it? At a first glance. At a first glance, you might think, okay, this I've never studied about. What have they asked? I have not learned about 2,3-BPG and low glucose levels. There are enzymes. So don't have any mind block the moment you see the question. I want you to have a positive outlook to an exam. Positive outlook to every MCQ. You have done your bit, right? Just sitting in this lecture beyond 4 hours should tell you that you're working on it. When you're working on it, you would have learned many facts. So just have an open mind, look at all MCQs, exclude choices. Almost all MCQs you'll be able to answer. Do you get it? So what is the right answer here? The right answer here is phosphoglycerate kinase defect. Another INI-CET question. A child presents with fatigue and hepatomegaly. So remember, there is hepatomegaly. Liver enzymes are elevated. Ketosis was significant. Liver biopsy shows excess glycogen. That is why liver is enlarged. After feeding, blood glucose level rise. Yeah. After feeding, blood glucose level rises. But there is no rise in glucose after overnight fasting. So I would call it as a condition wherein there is fasting hypoglycemia, okay, which does not rise even after overnight fasting. The moment you see this, it is pathognomonic for von Gierke's disease or glucose 6-phosphatase defect. What is the right answer? It is von Gierke's disease or glucose 6-phosphatase defect. Okay, how do you exclude other choices? Please listen to this. How do I exclude other choices? If it is liver phosphorylase defect, yes, there will be hypoglycemia. Yes, there will be glycogen accumulation. Yes, there will be hepatomegaly. But will it increase after overnight fasting? Blood glucose will increase after overnight fasting. This I told you is pathognomonic for von Gierke's disease. And if you're asking me, in von Gierke's, will there be glycogen accumulation? Yes. Why? Because in von Gierke's, glucose 6-phosphatase is defective. When glucose 6-phosphatase is defective, glucose 6-phosphate cannot become glucose. So what accumulates? Glucose 6-phosphate accumulates. When glucose 6-phosphate accumulates, it enters into glycogen synthesis. Do you understand this? It enters into glycogen synthesis. So please understand, this is how INI-CET MCQs are tricky. Okay, so both von Gierke's disease and Hers disease can present with hypoglycemia, can present with hepatomegaly, can present with glycogen accumulation. The pathognomonic feature of von Gierke's disease is no increase in blood glucose even after overnight fasting. Are you all clear about this? I don't want you to make mistakes here, right? So what is the right answer? It is von Gierke's disease, glucose 6-phosphatase defect. A child was fatigued after exercise. So it is exercise intolerance. And the blood sample collected soon after exercise showed low glucose and low lactate level. Don't you know the right answer? Exercise, post-exercise reduction in glucose and reduction in lactate level. What is it? It is McArdle's disease. A 4-year-old child presents with EC fatigability. Right? EC fatigability is exercise intolerance. The mother also complained that the child was more hungry between meals. Being hungry between meals is fasting hypoglycemia. And the child recovers after food. So you see both exercise intolerance and fasting hypoglycemia. In that case, you should take liver biopsy. That is what they have done. Liver biopsy reveals zero glycogen. What is it? Type 0 glycogen synthase deficiency. Yeah, very good. So we are done with carbohydrate metabolism. This is the last part for tonight, okay, or today evening. I'm going to start with lipid metabolism, factual memory recall, right? So first about fatty acid synthesis. Usually I don't discuss about fatty acid synthesis. I always say this because there is no inborn error of metabolism related to fatty acid synthesis. Right? As medicos, as medical students or medical professionals, we should learn about a pathway which has got a clinical significance. So usually I skip fatty acid synthesis, but recently I saw 2 MCQs on fatty acid synthesis in INI-CET. One question was, after carbohydrate rich meal, right? No, after taking, after being on high calorie diet. After being on high calorie diet, weight gain happens because of all except, right? Weight gain happens because of all except A, B, C. All these were related to fatty acid synthesis. D was related to fatty acid oxidation. Fatty acid synthesis can cause weight gain. Fatty acid oxidation cannot cause weight gain. So choice D is the right answer. But for you to be very clear about this, you should know about A, B, C, all the 3 of which are related to fatty acid synthesis. That is why I'm telling you about this. So about fatty acid synthesis, point number 1, it happens in cytoplasm. Point number 1 is it happens in cytoplasm. Point number 2, for you to synthesize fatty acid, the precursor is acetyl-CoA. So if they ask you which is the building block of fatty acid, your answer should be acetyl-CoA. There are 3 sources of acetyl-CoA and all the 3 sources of acetyl-CoA are present in mitochondria. Tell me what are the 3 sources of acetyl-CoA, then you will understand why I'm saying it's present only in mitochondria. One source of acetyl-CoA is pyruvate. In the presence of pyruvate dehydrogenase complex, it can form acetyl-CoA. And that pyruvate dehydrogenase is present in mitochondria. Another source of acetyl-CoA is all fatty acids on oxidation give rise to acetyl-CoA. That also happens in mitochondria. Third source of acetyl-CoA is ketogenic amino acids on oxidation can give rise to acetyl-CoA. That is also in mitochondria. So what have you learned today? Today you have learned that fatty acid synthesis happens in cytoplasm. The building block of fatty acid is acetyl-CoA. There are 3 sources of acetyl-CoA, all of which are present in mitochondria. So I can synthesize acetyl-CoA only in mitochondria. but I have to transport acetyl-CoA from mitochondria to cytoplasm. Only then it can take part in fatty acid synthesis. Right? As acetyl-CoA, it cannot cross mitochondrial membrane, so you need a transporter. The transporter is tricarboxylate transporter or citrate transporter. So what happens? Whenever you form acetyl-CoA within mitochondria, immediately acetyl-CoA reacts with oxaloacetate, enters into citric acid cycle, becomes citric acid. Then the citrate transporter transports citrate from mitochondria to cytoplasm. That citrate gives rise to acetyl-CoA. What should you remember? For fatty acid to be synthesized, you need a tricarboxylate transporter or citrate transporter which transports citrate from mitochondria to cytoplasm. After acetyl-CoA is formed in cytoplasm, the first enzyme of fatty acid synthesis is acetyl-CoA carboxylase. All of you please memorize it. This was asked in INI-CET. What is the first enzyme of fatty acid synthesis? Acetyl-CoA carboxylase, which converts acetyl-CoA to malonyl-CoA. So what is malonyl-CoA? Is an intermediate of fatty acid synthesis. Then malonyl-CoA enters into fatty acid synthesis. So are you clear about all these facts that I told you just now? What are the facts I told you? Fatty acids get synthesized where? In cytoplasm. And what is the building block of fatty acid? Acetyl-CoA. The three sources of acetyl-CoA are present in mitochondria. So you have to transport acetyl-CoA from mitochondria to cytoplasm, for which you are dependent on tricarboxylate transporter or citrate transporter. After acetyl-CoA is formed in cytoplasm, the next enzyme is acetyl-CoA carboxylase, which converts acetyl-CoA to malonyl-CoA, and that is the rate-limiting enzyme of fatty acid synthesis. Okay, that's all about fatty acid synthesis. About fatty acid oxidation. Fatty acids get oxidized in mitochondria and in peroxisomes. Right? Fatty acids get oxidized in mitochondria and in peroxisomes. About peroxisomes, they always ask you this. What is Zellweger syndrome? All of you tell me what is Zellweger syndrome. It is peroxisomal biogenesis disorder. In Zellweger syndrome, peroxisome is not synthesized at all. So no function of peroxisome will be met in the person. It's a severe condition. It presents as cerebrohepatorenal syndrome. Zellweger syndrome is peroxisomal biogenesis disorder. It presents as cerebrohepatorenal syndrome. It presents as a severe neurological disorder. Do you understand this? Severe neurological disorder. What is another peroxisomal disorder? Refsum's disease. Don't get confused between Zellweger syndrome and Refsum's disease. Refsum's disease is a defect of alpha oxidation of phytanic acid. Right? Refsum's disease is the defect of alpha oxidation of phytanic acid. So among all the functions of peroxisome, in Refsum's disease, only one function is affected. So it is not a very severe disorder. It starts as retinitis pigmentosa. Do you understand this? It starts as retinitis pigmentosa with mild neurological manifestations. This is how you can differentiate the two disorders. Zellweger syndrome is cerebrohepatorenal syndrome, severe neurological dysfunction. Refsum's it presents as retinitis pigmentosa with mild neurological manifestations. Okay. The next fact about fatty acid oxidation is, for fatty acids to get oxidized in mitochondria, you have to transport fatty acid into mitochondria. But fatty acids are in the form of acyl-CoA. As acyl-CoA, it cannot cross the mitochondrial membrane. So you need a carrier. Tell me what is the carrier, all of you? The carrier is carnitine. And the enzyme is carnitine acyl transferase 1. This is called as carnitine shuttle. Citrate shuttle is involved in fatty acid synthesis. Carnitine shuttle is involved in fatty acid oxidation. So what does carnitine do? Carnitine reacts with acyl-CoA. CoA is released. Acyl carnitine enters into mitochondria. After acyl carnitine enters into mitochondria, the carrier has to be removed. If you don't remove the carrier will take it back to cytoplasm. So which enzyme takes out the carrier? Carnitine acyl transferase 2. What does transferase 2 do? It releases carnitine, attaches CoA, converting acyl carnitine to acyl CoA. Then this enters into fatty acid oxidation. Did you see this MCQ? The latest INI-CET November 25 had this question. Did you all see this? All of you, please look into previous year question paper. Okay. So what is that you need to remember here? Fatty acids get oxidized in mitochondria. For fatty acids to get oxidized, you need a carrier. The carrier is carnitine. The enzyme is carnitine acyl transferase 1. They asked you, where is carnitine acyl transferase 1 working? It is working on the cytoplasmic side to convert acyl-CoA to acyl carnitine. Then acyl carnitine enters into mitochondria. Carnitine acyl transferase 2 acts on the mitochondrial side, releases carnitine, attaches CoA. Put together, this shuttle does not use energy. Right? To transport fatty acid into mitochondria, you don't need energy. These are the facts that you need to know about the shuttle. And carnitine acyl transferase 1 is the rate limiting enzyme of fatty acid oxidation. Which is the rate limiting enzyme of fatty acid synthesis? Acetyl-CoA carboxylase. For fatty acid oxidation, it is carnitine acyl transferase 1. You should also know what happens whenever there is a fatty acid oxidation defects. It's my pleasure, you all. I'll be very happy if all of you who attend this session, throughout the session, get benefited and you get a seat in INI-CET. You get a seat in AIMS, right? I'll be very happy to hear that. So what should you also know is what happens whenever there is a fatty acid oxidation defect. Whenever there is a fatty acid oxidation defect, gluconeogenesis will be suppressed because gluconeogenesis is dependent on fatty acid oxidation for energy. So whenever there is a fatty acid oxidation defect, gluconeogenesis is suppressed. That causes fasting hypoglycemia. So this also presents as neonatal fasting hypoglycemia. But the classical feature is, in all other causes of fasting hypoglycemia, you see ketosis. But when there is a fatty acid oxidation defect, it presents as non-ketotic fasting hypoglycemia. Why do you see non-ketotic fasting hypoglycemia? Only when there is fatty acid oxidation, you get acetyl-CoA. Only when you get acetyl-CoA, there can be ketone bodies. Fatty acid oxidation is defective, no acetyl-CoA, no ketone body formation. So like what I told you for von Gierke's disease, the pathognomonic feature of von Gierke's disease is severe fasting hypoglycemia, which does not respond to counter-regulatory hormone administration. That is pathognomonic for von Gierke's. What is pathognomonic for fatty acid oxidation defect? Fasting hypoglycemia, which is non-ketotic. Okay. And there is hyperammonemia. Why do you see hyperammonemia? When fatty acid oxidation does not happen, as a compensatory mechanism, amino acid oxidation happens. Whenever amino acids get oxidized, ammonia will be released. That causes hyperammonemia. And you also see dicarboxylic aciduria. Yeah, you also see dicarboxylic aciduria. So tell me, what are the features of fatty acid oxidation defects? All of you start answering. Please look at the slide here. What are the features of fatty acid oxidation defect? Non-ketotic fasting hypoglycemia, hyperammonemia, and dicarboxylic aciduria. That's all about lipid metabolism. Okay. I want you also to know about hyperlipoproteinemias before we start discussing MCQs and PYQs. Okay, because there are so many questions on this topic. A quick revision on hyperlipoproteinemias. It's all about Fredrickson's classification. Did you all see these MCQs to be recently asked? Yes, right? So Fredrickson's classification of hyperlipoproteinemias. First, you need to know there are 6 types. My pleasure, Dr. Sneha. So there are 6 types. What are the 6 types? Thanks, everybody. This gives me more energy because when for the last 5 to 10 minutes, I felt a bit tired, but seeing the fact that you're enjoying the session gives me more energy and more pleasure. Okay. So there are 6 types of hyperlipoproteinemias. What are the 6 types? Type 1, 2A, 2B, 3, 4, and 5. Please remember what are the 6 types? Type 1, 2A, 2B, 3, 4, and 5. And for your benefit, I am going to classify these 6 types into 3 categories. The first category presents with only an elevation of cholesterol. Yeah, the first category presents with only an elevation of cholesterol. Second category presents with only an elevation of triglyceride. Third category presents with an elevation of both. Why am I classifying it this way? Because clinical features would differ based on this. If a patient has got only an elevation of cholesterol, then that patient presents with tendon xanthomas. If there is an elevation of only cholesterol, then the patient presents with tendon xanthomas and accelerated atherosclerosis. So what are tendon xanthomas? Whenever the case history or the stem of the question says tendon xanthomas, please register in your mind that it is hypercholesterolemia. What are tendon xanthomas? Look at this image. These are tendon xanthomas. These are small eruptive lesions which are present along the line of attachment of tendons. There are tendons pronounced ankles and knuckles. So if you see these tendon xanthomas, remember hypercholesterolemia. Remember that this patient can present with accelerated atherosclerosis. Okay. Whereas if your patient presents with an elevation of triglyceride, they don't present with tendon xanthomas. Instead, they present with eruptive xanthomas. They don't present with accelerated atherosclerosis. They present with recurrent pancreatitis. And on examination, you find lipemia retinalis. So tell me, what is expected when there is hypertriglyceridemia, eruptive xanthomas, recurrent pancreatitis, and lipemia retinalis? Now, what are eruptive xanthomas? Eruptive xanthomas are even tinier than tendon xanthomas. Look at this. These are eruptive xanthomas. These are even tinier than tendon xanthomas, and they are present along the extensor surfaces of the limb. For example, back of elbow. So if you see these eruptive xanthomas, then it means your patient has got hypertriglyceridemia. They can present with recurrent pancreatitis. What if there is an elevation of both cholesterol and triglyceride? In that case, you see a combination of eruptive xanthomas, tendon xanthomas, accelerated atherosclerosis, recurrent pancreatitis. You see a mix of both. Okay. Now, this is how I am going to classify hyperlipoproteinemias. Out of the 6 types I told you, there is only one type wherein cholesterol alone is high. Okay, cholesterol alone is elevated in type 2A. So tell me, in which type there is only an elevation of cholesterol? Type 2A. That is why type 2A is otherwise called as familial hypercholesterolemia. Logical, right? Because cholesterol alone is elevated in this condition, you call it as familial hypercholesterolemia. And this is caused by a defect of LDL receptor. So you should ask me, why should LDL receptor defect present with hypercholesterolemia? Simple logic. What is the function of LDL receptors? LDL receptors are present on the tissues, and the function of these LDL receptors is to clear LDL from the circulation. Right? What is its function? Its function is to clear LDL from the circulation. So when there is LDL receptor defect, LDL is not cleared from the circulation. LDL accumulates in the blood. LDL carries cholesterol, so blood cholesterol level would be high. These patients present with tendon xanthomas and accelerated atherosclerosis. Okay, and it's an autosomal dominant condition. This was asked previously. What are the autosomal dominant hyperlipoproteinemias? All of you look at what I am writing. Autosomal dominant hyperlipoproteinemias are type 2A, type 4 and type 5. Please don't forget this. Autosomal dominant hyperlipoproteinemias are type 2A, type 4 and type 5. The class will continue for the next 20 minutes if I am right. Yeah, 20 to 25 minutes. Now about the types which present with hypertriglyceridemia. What are the types which present with hypertriglyceridemia? Type 1, 4 and 5. Please remember 4 and 5 are always coupled. Okay, because 4 and 5 are familial hypertriglyceridemias. The genetic defect is common for both these. So most of the times when you write type 4 close to your I and answer it as type 5 as well. For example, both present with elevation of triglyceride, both are autosomal dominant conditions. So what are the conditions wherein triglyceride levels are high? Type 1, 4 and 5. What are the mixed conditions? Mixed conditions remaining 2B and 3. Okay, type 2B and 3, both cholesterol and triglycerides are elevated. Okay, so what are we going to learn about now? I am going to tell you about type 1, type 3, 4 and 5. Okay, so type 1. Always we learn about chylomicron first. Whenever you learn about lipoproteins, we learn about chylomicron first. So what is type 1? Familial chylomicronemia syndrome. All of you tell me what is type 1? It is familial chylomicronemia syndrome. It is caused by the defect of ApoC2 or lipoprotein lipase. Just remember, it is caused by the defect of ApoC2 or lipoprotein lipase, because ApoC2 of chylomicron and lipoprotein lipase, right? Lipoprotein lipase of the vessel wall. So ApoC2 of chylomicron and lipoprotein lipase of the vessel wall together cause chylomicron metabolism. So whenever there is a defect of ApoC2 or of lipoprotein lipase, chylomicron will not be metabolized. Chylomicron stays back in the blood, causing familial chylomicronemia syndrome. Chylomicron carries dietary triacylglycerol. It has excessive triglyceride. So carrying excessive triglyceride, if chylomicron accumulates in the blood, that causes massive hypertriglyceridemia. In familial chylomicronemia syndrome, triglyceride level can be more than 1500 milligram per deciliter. What is a normal serum triglyceride level? Less than 150 milligram per deciliter. In familial chylomicronemia syndrome, it's almost 10 times normal. Okay, massive hypertriglyceridemia. So these patients present with eruptive xanthomas, recurrent pancreatitis. On examination, you find lipemia retinalis. Okay, and whenever you see this combination of eruptive xanthomas, recurrent pancreatitis, lipemia retinalis with massive hypertriglyceridemia, you should suspect familial chylomicronemia syndrome, for which the confirmatory test is plasma lipoprotein lipase enzyme activity. If you can show that plasma lipoprotein lipase enzyme activity in this individual is low, diagnosis is confirmed. Okay, so these are the facts that you need to know about familial chylomicronemia syndrome. So tell me all about type 1 quickly. Type 1 is, please look at the slide here. Yeah, please look at the slide here and read it. Type 1 is familial chylomicronemia syndrome caused by the defect of ApoC2 or lipoprotein lipase. There is massive hypertriglyceridemia, more than 1500 milligram per deciliter. They present with eruptive xanthomas and recurrent pancreatitis. On examination, you find lipemia retinalis. Confirmatory diagnosis is showing that plasma lipoprotein lipase enzyme activity is low. It is not heparinized. Whenever I try to skip a fact, you keep bringing out that fact, and that fact is also wrong. It is not heparinized sample, it is post-heparinized sample. Right? What is it? It is post-heparinized sample. What is post-heparinized? You inject heparin into the individual and then you collect the blood sample. When you inject heparin that is floating in the blood will compete with heparin sulfate of the vessel wall that is holding the enzyme. Okay, so what is the blood sample that you should estimate? It is post-heparinized blood sample for type 1. Okay. Now, type 3 and E sound similar, right? You want 5-minute break? No, I'll finish it in 15 minutes. Okay. So, type 3 and E sound similar. 3 is an ApoE defect. Please remember, 3 is an ApoE defect. From here, there are many high yield facts that I'm going to tell you about. So stay with me. If you had been with me till now, stay till the end. Okay. Because I've included few other INI-CET questions about which discussion is not always done. Okay. So stay put. So it's an ApoE defect. ApoE is an apoprotein of remnants. Yeah, ApoE is an apoprotein of remnants. So whenever ApoE is defective, remnants accumulate. So this condition is called as remnant disease. Remnants carry both cholesterol and triglyceride. I said chylomicron carries triglyceride. Remnants carry both cholesterol and triglyceride. Carrying both cholesterol and triglyceride because remnants accumulate. In this condition, there is an elevation of both cholesterol and triglyceride. Okay, and there is a pathognomonic feature on lipoprotein electrophoresis. When you run lipoprotein electrophoresis for a patient of type 3 hyperlipoproteinemia, you see a broad beta band. So this disease is called as broad beta disease. It is also called as familial dysbeta lipoproteinemia. Broad beta disease or familial dysbeta lipoproteinemia. All of you remember for type 3, there are 3 names. What are the 3 names? The first name is remnant disease, broad beta disease, familial dysbeta lipoproteinemia. Okay. And it is caused by a defect of E2 allele. All of us have E3. When I say all of us, if your lipid profile is normal, then assume that you have E3 allele. And when E3 is replaced by E2, that causes remnant disease or type 3 hyperlipoproteinemia. I also want you to know that dermatologically, there are 2 pathognomonic features for this. One is palmar eruptive xanthomas. If eruptive xanthomas are present in the palm, please think of type 3 hyperlipoproteinemia. The other one is xanthoma palmaris striae, yellowish discoloration of palmar creases. So type 3 hyperlipoproteinemia, can you all repeat this? Type 3 is ApoE defect. It's a remnant disease. Both cholesterol and triglyceride levels are high. It is broad beta disease or familial dysbeta lipoproteinemia. ApoE2 defect. Palmar eruptive xanthomas and xanthoma palmaris striae. Okay. Type 4 and type 5, usually I would not have discussed about this, but recently there was a question about this. So let me explain about this as well. Type 4 and type 5 are together called as familial hypertriglyceridemias. Type 4 and type 5 are together called as familial hypertriglyceridemias. And in both these conditions, there is the defect of VLDL metabolism. There is an increase in the rate of VLDL synthesis and decrease in the rate of VLDL catabolism, because of which VLDL levels are high in the blood. When VLDL level is high, VLDL carries triglyceride. So in both these conditions, plasma triglyceride levels are elevated. That is by the name familial hypertriglyceridemia. If there is just the genetic defect, you call it as type 4. If an individual with a genetic defect of type 4 has a superimposed secondary factor which contributes to hypertriglyceridemia more, that is called as type 5, right? For example, a type 4 individual who is obese, already triglyceride level is high, the person is obese, further elevation of triglyceride levels, okay? Obese individual or a diabetic individual, type 4 who has become diabetic, a type 4 individual who is a chronic alcoholic, right? So there is a superimposed secondary factor for further elevation of triglyceride, that is called as type 5. So in type 5, not only VLDL levels are high, chylomicron levels are also high. This was given as a STEM in the recent MCQ. The recent MCQ showed triglyceride levels to be elevated, and they said both chylomicron and VLDL levels are high. They asked you for the diagnosis. What is your diagnosis? Type 5. So that is why type 5 is called as familial mixed hypertriglyceridemia. Why is it called as mixed hypertriglyceridemia? There is an elevation of both chylomicron and VLDL. Got it? So this is about hyperlipoproteinemias. To summarize about hyperlipoproteinemias, if cholesterol level alone is high, it is 2A. 2A is called as familial hypercholesterolemia. They present with tendon xanthomas and accelerated atherosclerosis. If triglyceride alone is elevated, it is 1, 4 and 5. How will you differentiate 1, 4 and 5? Please listen to this. In 1, chylomicron is high. In 4, VLDL is high. In 5, both chylomicron and VLDL levels are high. This is how you differentiate 1, 4 and 5. Okay. And then I told you about type 3, ApoE defect, remnant disease, broad beta disease, familial dysbeta lipoproteinemia, Palmar eruptive xanthomas, and xanthoma palmaris striae. Okay. You will be able to answer this. Can you try answering this? Which of the following is not true about? That's all about the theory part. We are going to discuss MCQs. As we discuss MCQs, I'll tell you a few facts about amino acids and proteins as well. Okay. So which of the following is not true about beta oxidation of fatty acid? I told you November 2025 MCQ. Both carnitine acyl transferase 1 and 2 are involved in the transport of fatty acid across the mitochondrial membrane. Very true. Okay. ATP is involved. That is false. Which is not true? Choice B is not true. Look at choice C. CoA is released in the cytoplasm while formation of acyl carnitine is observed. Yes. Along the cytoplasmic side, CoA is removed, the carrier is attached. True. Carnitine is released in the mitochondrial side. True. So which is a false statement? Choice B is false. Patient with xanthomas on Achilles tendon. Tendon xanthomas. What did I say? Hypercholesterolemia. Right? Answer is choice A. A patient came to the emergency room with severe pain in the abdomen. Triglyceride level is 10 times normal. This is then recurrent pancreatitis. The moment you see such a massive elevation of triglyceride, it is type 1. What is type 1? Familial chylomicronemia syndrome caused by the defect of ApoC2 or lipoprotein lipase. Again, tendon xanthomas, high cholesterol, high LDL, right? Familial hypercholesterolemia caused by the defect of LDL receptor. Very good. I'm happy to see all of you answering it right. Yeah, it is LDL receptor defect. So I told you, right, very recent MCQ and it's an FMGE question. That's why I always say this in all my sessions, don't underestimate FMGE questions. Okay, so man presenting with high VLDL and chylomicron. The moment you see this, think of type 5, which is one of the familial hypertriglyceridemias. The best option would have been familial mixed hypertriglyceridemia. Right? What is it? It's familial mixed hypertriglyceridemia. A 25-year-old male presents with hypercholesterolemia. Elder brother has died of heart disease, autosomal dominant condition, right? LDL receptor defect was observed. All clues are given. What is it? Familial hypercholesterolemia. Which gene defect causes familial hypercholesterolemia? Recent MCQ, LDL receptor defect. I told you this, right? After a high carbohydrate meal, weight gain is explained by all except. When there is a high carbohydrate meal, insulin is released. Insulin is an anabolic hormone. Anabolic hormone stimulates fatty acid synthesis. And what are the proteins which are involved in fatty acid synthesis? Acetyl-CoA carboxylase is the rate-limiting enzyme. Tricarboxylate transporter is essential for transporting citrate from mitochondria to cytoplasm. Malonyl-CoA is an intermediate of fatty acid synthesis. So following a high carbohydrate meal, there is stimulation of all these three. Whereas mitochondrial carnitine is involved in fatty acid oxidation, that will not be stimulated. In the presence of an anabolic hormone, mitochondrial carnitine, which is involved in a catabolic process, will not be involved in weight gain. Do you all get it? Yes, very good. The answer is choice D. Match the following amino acids with their derivatives. This is also a November 25 MCQ. Let's try answering this question first and then I'll tell you about amino acids and their derivatives. Okay. From tyrosine, we get thyroid hormones. Apart from thyroid hormones, we also get neurotransmitters, namely dopamine, norepinephrine, epinephrine. Not just this, from tyrosine, you also get melanin. Please memorize it. Tyrosine is a precursor for thyroid hormone, dopamine, norepinephrine, epinephrine, and the pigment melanin. Okay. How about tryptophan? From tryptophan, we get niacin. I hope that everybody knows. From tryptophan, we get niacin. 60 milligram of tryptophan is equivalent to 1 milligram of niacin. It is also necessary for serotonin synthesis. From serotonin, we get melatonin. What is serotonin? 5-hydroxytryptamine. The name tryptamine tells you that's from tryptophan. So from tryptophan, we get niacin, not only niacin, we get serotonin and melatonin. Okay. And then from glycine, we get creatine. All of you remember the mnemonic. The mnemonic that can be used to remember the amino acids that are used for synthesizing creatine is GAME. What does GAME stand for? Glycine, arginine, methionine. Have you memorized it? What are the three amino acids used for creatine synthesis GAME? Glycine, arginine, and methionine. And glycine is not only necessary for synthesizing creatine, it is also necessary for heme synthesis. What is the first step of heme synthesis? Glycine reacts with succinyl-CoA. to form ALA. So glycine is also necessary for heme synthesis. It is necessary for purine ring formation, right? Not just that, it is the most abundant amino acid of collagen. Glycine is necessary for glutathione synthesis. So all these are functions of glycine. So what have you learnt about glycine? Remember game, it is necessary for creatine synthesis, heme synthesis, purine ring formation, collagen synthesis, and glutathione synthesis. How about cysteine? From cysteine, we get taurine, right? From cysteine, we get taurine, which is a neurostimulator, right? So taurine, Taurus means bull, right? That is why Red Bull is called as Red Bull, to tell you everybody that Red Bull is rich in taurine, which is a neurostimulator. Actually, the major reason behind why Red Bull gives you that feeling of wakefulness is it has got more caffeine. Okay, so cysteine, from cysteine we get taurine, we also get glutathione. Okay, so a quick recap on the specialized products that we get from amino acids. From phenylalanine, we get tyrosine, right? From tyrosine, just now I told you we get melanin, neurotransmitters dopamine, norepinephrine, epinephrine. We also get thyroid hormone. Okay. From tryptophan, we get niacin, we get serotonin, we get melatonin. From arginine, you get nitric oxide. So I would expect you to answer this. Tell me from glycine, what are the specialized products that we get? I told you just now. From glycine, we get creatine, we get heme, purine ring formation, most abundant amino acid of collagen, and it is also necessary for glutathione synthesis. Okay, if you know this table, then you will be able to answer most of the questions on specialized products obtained from amino acids. Okay. And the next one is the last MCQ for the session today, but it's quite interesting. Which amino acid donates nitrogen to sodium benzoate when given for urea cycle disorders? Right? This is an excellent question because it's so applied. Donates nitrogen to sodium benzoate when given for urea cycle disorders. So what do you expect in urea cycle disorders? You know the function of urea cycle is to convert ammonia to urea. So whenever there is urea cycle disorder, you would expect hyperammonemia. Whenever there is hyperammonemia, you would observe a combination of CNS stimulation and depression manifestations. So if you want to bring down ammonia levels in an infant with urea cycle disorder, what are the strategies that you need to follow? For you to understand these strategies, you need to know first the sources of ammonia. So can you tell me what are the sources of ammonia? There are two ways, right? If you want to reduce ammonia levels, there are two ways. One is to inhibit the source of ammonia. The other one is to scavenge ammonia. So I'm asking you, what are the sources of ammonia? The first source of ammonia is amino acid breakdown. What is another source of ammonia? It is urease producing microorganisms. You know your colon is loaded with urease producing microorganisms. This urease acts on urea in the colon, converting urea into ammonia. And ammonia is non-polar. As long as it exists as ammonia, it can cross any membrane and it can get into circulation. That is why, what did I tell you is another source of ammonia? It is urease producing microorganisms which are present in the colon. So how can you inhibit these two sources? If you have to avoid amino acid breakdown being a source of ammonia, then you should ensure that the protein intake is reduced. Right? So what you're supposed to do is you stop the child who's on mixed balanced diet and you start glucose only diet for the child so that there is no source of ammonia that way. And another fact that you should remember is the moment you tell a mother that you should restrict protein intake, the mother, because she's already anxious, the mother will not be able to give anything to the child. that results in calorie restriction. That's quite dangerous, right? When there is calorie restriction, the body gets into negative nitrogen balance. More and more amino acid of the body gets degraded, causing further elevation of ammonia. So you should tell the mother clearly that protein has to be restricted in the diet, but calories should not be restricted. The mother should ensure that adequate calories are given to the child. So what are the two measures that you take here? Protein intake has to be reduced and adequate calories should be given to children. Okay. Now, how can you inhibit urease producing microorganisms acting as a source of ammonia? This is why you give low dose antibiotic like neomycin. So neomycin kills urease producing microorganism. One source of ammonia is gotten rid of. Another way is by giving lactulose. What happens when you give lactulose? Lactulose is a non-digestible disaccharide. So undigestible disaccharide reaches colon, and in the colon lactulose is utilized and it is converted to an acid by microorganisms. This creates acidic pH in the colon. Whenever there is acidic pH in the colon, ammonia reacts with hydrogen ions to form ammonium ions. As ammonium ions, it cannot cross the membrane. So you're reducing the absorption of ammonia by giving lactulose. Are you clear about this? So tell me, what are the measures that are taken to inhibit the source of ammonia in a child with urea cycle disorder? Step number 1, protein restriction. Step number 2, adequate calorie intake. Step number 3, give neomycin, kill the source of urease producing microorganism. Or give lactulose. Lactulose creates acidic pH in the colon so that ammonia becomes ammonium. It is not absorbed. Okay. Now, another way of reducing ammonia levels is whatever ammonia has been already formed should be scavenged. And how can you scavenge it? By giving sodium benzoate or by giving phenyl acetate. Right? By giving sodium benzoate or phenyl acetate. So what happens when you give sodium benzoate? The moment you start IV sodium benzoate, liver comes for the rescue. Liver senses the sodium benzoate as a non-polar substance which has gained entry into the body. It wants to get rid of the sodium benzoate, for which it conjugates sodium benzoate with glycine. Right? What does liver do? Liver conjugates sodium benzoate with glycine, converts sodium benzoate to hippuric acid so that it gets excreted in the urine. This way, glycine availability is reduced. Whenever glycine availability is reduced, the child starts synthesizing glycine. How does a child synthesize glycine? If at all you want to synthesize glycine, you can synthesize glycine from carbon dioxide reacting with ammonia with N5N10 methylene tetrahydrofolate. Yeah, you can synthesize glycine from carbon dioxide reacting with ammonia and N5N10 methylene tetrahydrofolate in the presence of glycine cleavage system. So do you see that for every mole of sodium benzoate that is given as IV infusion, 1 mole of ammonia is getting scavenged, right? For every mole of sodium benzoate that is given as IV infusion, 1 mole of ammonia is getting scavenged. That reduces ammonia levels. So tell me, how does sodium benzoate act as an ammonia scavenging agent? When you start IV infusion of sodium benzoate, liver conjugates glycine with sodium benzoate, converts it into hippuric acid, gets excreted in urine, thereby reducing glycine availability in the system. So the body tries to synthesize glycine. Your body works in such a way that to synthesize glycine, it has to allow carbon dioxide to react with ammonia and N5N10 methylene tetrahydrofolate to form glycine. So every mole of sodium benzoate helps in scavenging 1 mole of ammonia. Okay. Now, what is another ammonia scavenging agent? Phenyl acetate. Whenever you start phenyl acetate, again liver comes for the rescue. Liver conjugates phenyl acetate with glutamine. Sodium benzoate is conjugated with glycine. phenyl acetate is conjugated with glutamine, it gets converted to phenyl acetyl glutamine, gets excreted in urine. This reduces glutamine availability. So the body tries to synthesize glutamine. How do you synthesize glutamine? It starts from ammonia. Ammonia reacts with alpha ketoglutarate to form glutamate first. This glutamate reacts with one more ammonia to form glutamine. So do you see that for every mole of phenyl acetate that is given as IV infusion, 2 moles of ammonia are getting scavenged, right? For every mole of phenyl acetate that is given, 2 moles of ammonia gets scavenged. That is why we call phenyl acetate as an ammonia scavenging agent. So what are the facts that you need to remember here? Whenever you use sodium benzoate, what is used as a conjugating agent? Glycine. Whenever you use phenyl acetate as a scavenging agent, what is used as a conjugating agent? Glutamine. Which is a better scavenging agent? Phenyl acetate is a better scavenging agent because it scavenges 2 moles of ammonia for every mole of phenyl acetate. Also remember this, just because I told you this in the session, that in hyperammonemia, you can start IV sodium benzoate and IV phenyl acetate. Please don't start any of these IV infusions in a patient with hyperammonemia due to liver failure. Right? What is another cause of hyperammonemia? Decompensated liver disease. Do not give any of these in decompensated liver disease because the liver is already damaged. When you give these scavenging agents, you're putting more burden to the liver. Okay, so when will you give these ammonia scavenging agents? Only when hyperammonemia is because of urea cycle disorder. Are you clear about this? So what is the right answer? When sodium benzoate is used, what is used as a conjugating agent? It is glycine. Okay, so overall, we have touched all topics in biochemistry. I kept seeing people asking me, is this enough for INI-CET? Right? I am not here to give you any such false promises saying if you watch this entire session, you will be able to answer all MCQs. So to reiterate this will help you to quickly recall and recap all that you have learned in biochemistry. And even if you have not learned biochemistry till now, this will help you to get a foundation for you to learn biochemistry. But what you're supposed to do after this, I recommend that you watch rapid revision videos in PrepLadder version X, right? Wherein I have explained all topics using PYQs and PYTs. If you club these together, more than 95% of MCQs in upcoming exams, you will be able to answer, right? I hope you enjoyed the session. My best wishes.